tiny hornet to use. ये लैपटॉप पे तो मुझे नहीं लगता वो भी ये जरूरी है लगाना। हेलो प्लीज प्लीज हमारा वो जो है ना 24 का में आवाज सही से नहीं आ रहा है, बहुत ही उसमें वाइब्रेशन हो रहा है, फ्रिक्शन ठीक है। तो हमने क्या किया था, माइक से ही स्टार्ट करवाया, इसको एक बार चेक कर लीजिएगा। 2 बजे स्टार्ट, अच्छा हाँ 2 बजे से 2 बजे से लंच के। हाँ चाहिए भी क्या एप्लीकेशन है। अच्छा person will just
Okay, good morning, everyone. Now we'll start with the session, first symposium of today. And our first speaker is Dr. Rajkumar sir from New Delhi. He is the additional professor and head. Sir, please, we welcome you, sir, on stage. We'll start with your presentation.
Thank you, Dr. Gagan and whole organizing team for inviting me. So I here welcome you all to the presentation on musculoskeletal ultrasound interventions. I will be speaking on the topic of the shoulder. And as you know, as a sports medicine professional, we strive to provide optimal care of our athletes. And point of care ultrasound has revolutionized the diagnosis and treatment of shoulder injuries. Shoulder joint is a little bit complex joint. It has got extra mobility in the cost of stability. So lots of muscle, lots of ligament, lots of joints is involved there. So I'll be sharing how to approach this problem of the shoulder, and in which musculoskeletal ultrasound is the important part for our diagnosis, interventions, and guiding force for intervention. So I'll be sharing my last more than 15 years of experiences with you through this topic. So our learning objectives are what are the indications, benefit, anatomy, protocols, pathologies, case studies, intervention, and finally I will conclude. So these are the indications. Coming to shoulder anatomy, we know shoulder mainly when you say shoulder, we think about glenohumeral joint, but there are other joints like atomic clavicular joints, and scapulothoracic muscle is very important. And the joints, there are many ligaments, glenohumeral ligaments, let's say superior, middle, and inferior glenohumeral ligament, thoracoabdominal ligament, thoracohumeral ligament, transverse ligament. So wherever two joints like thoraco-clavicular ligament, plenty of ligaments which stabilizes the joint and provides the mobility as well. But you don't forget, especially for the ultrasound purpose, greater tuberosity has three facets: superior, middle, and inferior facets. And lesser tuberosity, where subscapularis attaches, superior facets, supraspinatus, middle facet, infraspinatus, and inferior facet, tibialis minor. Okay. So let's recapitulate very fast the action of the shoulder. Flexion by anterior fiber of the deltoid, pectoralis major, and bicep brachii. Okay. Extension by posterior fiber of the deltoid, latissimus dorsi, and teres major. Adduction, pec major, latissimus dorsi, teres major. Let's continue looking for the origin and insertion, because it will help when we will scan. It will require basic, the most important thing to do ultrasound scan is its anatomy, and anatomy. इनमें तीन चीजों से चलती है, वैसे अल्ट्रासाउंड तीन चीजों से चलती है: एनाटॉमी, एनाटॉमी एंड एनाटॉमी. Similarly, abduction initially by the supraspinatus, then deltoid, and finally lateral rotation and medial rotation. And there are bursa which causes pain, which causes impingement to our athletes. So we should identify the bursa, we should know the bursa, and we should identify the history, clinical examination, and finally we will confirm through our ultrasound investigation. So main bursa are subabdominal subcoracoid bursa, other is subcoracoid bursa and subscapularis bursa. So after knowing the clinical anatomy, we should come to the clinical history to know the real cause of pain, to identify the real cause of the pain. And we should also confirm where pain is from the shoulder, coming from the neck, or coming from the below, elbow, or peripheral. Okay. And when we have done the history part, then we come to the physical examination. Because the physical examination is very important, because otherwise you will not able to know what to scan, where to scan, and what to look for. So we should scan from the front, back, side, top, bottom, everywhere we scan to look over the muscle, look over the symmetry of the scapula, and any obvious deformity, any other signs of injury, trauma, everything will look for, height of the shoulder, everything. Okay. Then come to palpation. In palpation, we'll do everything. We'll palpate all bony points, all joints, all tender points of all the muscles. Okay. Then we'll look for the range of motion. Whether range of motion is full or not. During the abduction, during the flexion, scapula is moving normally or not. Whether there is normal range of motion, whether there is increased range of motion. Because most of our athletes may have got extra power, extra mobility, extra force due to their increased mobility. That also predisposes them to trauma. So we look for the range of motion. It's very, very important. Seems is most of the simple thing, but it's very important. Okay, like power weight athletes, because due to increased mobility, they will complaining of the shoulder pain. But when we assess, we will not find any pain because they are getting extra load on the acromioclavicular joints. We will scan the acromioclavicular joint in this person, all tendon, all but everything will be normal. Will not get disturbed. When we identify the correct things, we will be able to connect it. Coming to the basic ultrasound consideration, we normally use linear probe, that is 6 to 15. That I commonly use, but 6 to 20, depending on the machine you have, you can use. So you should use optimal gel. You should scan every structure in both transverse as well as longitudinal plane. And you will scan the full length, full thickness, otherwise you will miss. Because in ultrasound, we are scanning through in that area only. In MRI, we have got all these scans. So similarly, ultrasound, we have to visualize the 3D anatomy and we have to scan all the parts of that area. Okay. And finally, we can compare with the normal side. We're also able to do dynamic scan. Something will get in the dynamic scan. And sometimes in case of tendinopathy, inflammation, we'll get color sign on the Doppler. So I think you all know the musculoskeletal basic. Just I will tell it. Muscle in cross section will look starry sky appearance, starry night appearance. And in longitudinal section, it's leafy appearance or pinnate appearance. And tendon is hyperechoic or fibular. And in cross section, it looks compact to shape structure. And nerve in cross section, it looks honeycomb appearance. And in bone, we'll say continuous this white line. So any breach in this structure may denote a minor fracture that may not be visible on X-ray. So we can also scan the like scapular fracture and other things. We can also diagnose for musculoskeletal ultrasound. And ligament similar to the tendon, it looks fibular hypoechoic. This is anterior talofibular ligament, not ligament of the shoulder. So coming to the protocols, we commonly use for European Society of Musculoskeletal Radiology 2016 guidelines. Here I have stick. There are numerous guidelines, everybody being, but we have to stick to one guidelines. This one is good, and we should start in beginning. We should start scanning through protocols so that we cannot miss any important structures. So positioning is very important, but most important is the patient positioning. Patient should be seated in the revolving wheelchair, and for the doctor, he should be lying in front, back, but he should take care of his or her ergonomics. That is very important. Wow. So in anterior part of the shoulder, we start scanning the biceps shoulder. Biceps, we put transversely upper part of the anterior hand shoulder. You will see this is lesser tuberosity, greater tuberosity, and this is compact structure is biceps tendon. Okay. Here, when we move proximal, it looks over, and we look down, then we come to the musculotendinous junction. So this is biceps in cross section, and this is biceps in longitudinal section. And anterior, what is it? We scan the subscapular tendon. So we scan in the longitudinal section. So we scan here, 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 everywhere we will scan, and then we scan in the transverse axis also. And elbow should be in the external, hand should be the external rotation position, so that it is spaced out and we'll be able to visualize that subscapular tendon. Okay. So here subscapular tendon inserting on the lesser tuberosity, and this is in the cross section. Multiple tendinous origin can be visualized. Here you can see 1, 2, 3, 4. Multiple tendinous origin, and in between this hypoechoic area, we should not confuse this with the tear. Okay. This is in between the muscle is getting converted into the tendon. And similarly, other anterior important structure is visualize this. Important one is coracoacromial ligament. Coracoid process, acromion, and this is coracoacromial ligament. This is thickened in case of adhesive capsulitis. This is coracoacromial ligament. And this is subcoracoid bursa. This is coracoclavicle ligament. Clavicle, coracoid. So coracoclavicle ligament. Then coming to supraspinatus tendon. So hand should be placed in the crash or modified crash position. This positioning is very important. Then only this supraspinatus tendon come out from the acromial process and you will be able to visualize, because it is beneath the most of the part is beneath the acromial process. So this typical is the parrot beak appearance in the longitudinal section, and in cross section here you can see the biceps, and this whole area is of supraspinatus, and this posterior part is of infraspinatus. We will not able to differentiate between the supraspinatus because tendons are so intermingled here. When you see the cadavers, we will never able to differentiate between the supraspinatus and infraspinatus. There is so much intermingling of the fibers. Okay. So here, this is the schematic diagram. So see and visualize where these structures are. Then later we can look over the impingement. This is subacromial. We will see in the later side subacromial subdeltoid bursa. So we should do the dynamic examination and assess the subacromial impingement. This is external impingement, and one another is internal impingement to the coracoacromial arch, where subscapular tendon or bursa get impinged. So for that we know the clinical part, the ultrasound examination. And posteriorly we will scan the infraspinatus muscle in infraspinatus fossa. This is the longitudinal section. You see the insertion of the infraspinatus muscle in the middle facets. And this is in the cross section. This is infraspinatus and this is teres minor. So here we will be able to know through this ratio of the infraspinatus and teres minor whether there is any tear will be in the tendon or not, or whether there is atrophy of the tendon, or there is any other neurological causes in the soil. Okay. And we come to the posterior part. Posteriorly, we will scan the glenohumeral joint. This is the humerus. When you do the external and internal rotation, humerus will be moving, and this glenoid will not be moving. So you will be able to know this is glenohumeral joint, and we will also able to visualize the posterior part of the shoulder labrum. Okay. So we will able to scan the labrum little bit, not in detail as MRI. So we should understand the limitation of the ultrasound. Otherwise, ultrasound is a very, very good modality. The structure which we can see, we will not able to get that good in the MRI. Okay. And coming to the top, this is the acromioclavicular joints. Sometimes if there is very much disturbance here, if this AC ligament is like swollen, so there may be, it means there is some rotator cuff pathology inside also. So it will give a window for the rotator cuff in initial scan. Will be the fast scan. We'll come to how we'll scan the different modes of scanning, fast scan, slow scan, anterior, posterior, everything in this sometimes. So this is the common, this is the normal tendon. And how we'll look for the pathology? These are the pathologies. So look for tear, tendinitis, tendinosis, bursitis, calcification, effusion, bicep subluxation, impingements, everything. So in like rotator cuff tear, one is dorsal surface tear, other is articular surface tear. One is full thickness tear, this other is partial thickness tear. So here again I have given you a normal picture to see so that you will be able to understand the abnormal structure. This is parrot beak appearance of the supraspinatus in longitudinal section, and this is the transverse section. Again, this is the longitudinal section, this is transverse section. Now I will go to the pathology of the supraspinatus. So just for time being, remember these images and coming to the pathology. Where we can see is in cross section supraspinatus, there is lot of, like it has thickened, normal thickness is 5 to 6. It has thickened, it is more than 8. And here, you can also say it is not totally hyperequivalent. It is heterogeneous. This is hyperechoic, this is hyperechoic, so it is heterogeneous. But like bony parts and other things are, and this is in the same thing in the longitudinal axis. So, how to differentiate between the tendon and tendinosis? So, tendinosis is heterogeneous, hyperechoic, ill-defined, it will be swollen, but cortex will explode. And in case of tear, this tear will be anechoic and it will be well defined. And if there is traumatic or degenerative tear, we will also see the bony irregularity. Here we can see there is bony irregularity. So this is the way to differentiate between. So let's see some pictures of the supraspinatus tear. This is the tear. This is complete tear. So this is known as flat tire sign. Complete normal is tire sign, then abnormal is flat tire sign. Okay. And this is insertional tear of the supraspinatus. This is the longitudinal section and this is in the cross section. Okay. This is traumatic in 50-year-old patient. Okay. Tear of the supraspinatus. So these are all abnormal pictures of the tear of the supraspinatus. Okay. And this is one cyst. This is one of my patients has got cyst. I confirmed through MRI because it was so well localized, border was remarkable. So I thought, no, it is maybe old tear, but it had formed some kind of cyst. So it was a case of mucinous cyst in the supraspinatus. When you read the IAPMR textbook, this picture is there is in shoulder chapter, so musculoskeletal on the shoulder. This is there, and this is calcification in supraspinatus muscle. And for early calcification, ultrasound is better than the MRI. That's what. Such calcification is visual and X-ray doesn't require any investigation. But here it is very feeble visual. We'll able to confirm through ultrasound. And some which are not giving any clue on the X-ray, but ultrasound can fix the early calcification. That is the beauty of ultrasound. Okay. This is abnormality of the bicep tendon, biceps tenosynovitis in cross section, in longitudinal section. Again, bicep tenosynovitis. Here, biceps has been subluxated medially, near subscapularis tendon. So here it is not here, it has come medially, medial subluxation of the biceps tendon. And this is Popeye sign. Here we can see the retracted fibrous muscle of the biceps muscle. So similarly, all here can be visualized. This is the subacromius subdelta adversa, and this is huge effusion in subaqueous adversa. And somehow it was reported in the MRI, but nobody has taken care of. This is one 70-year-old gynecologist. I aspirated 120 ml of the fluid, and patient got relief. Patient had taken multiple consultations, and this is effusion of the glenohumeral. These are all pathologies, and here we can see this is not a typical protocol, but anterior protocol we can see glenohumeral joint effusion, and all 5 muscles all have, we can see all both sides. This is a young patient. Okay. This one like stable like this, but he has got inflammatory diseases. Who has got some? All tendons are normal. And this is the way we do interventions. Okay. AC joint intervention, subacromial subdelta, glenohumeral hydrodilatation, rotator cuff approach, suprascapular nerve block. So ultrasound has got many diagnostic benefit, therapeutic benefit, especially guided injections, guided aspiration. We can personalize the treatment. That is the most important, especially in the case of a sports person. And patient has got a huge clinical benefit, especially enhanced patient satisfaction, and will get faster return into the play. So focus protocol, if we get like basic, we can do it in 5 to 10 minutes. Advanced, it may take up to half an hour. Anterior shoulder scan, like area scale is localized to anterior shoulder, no other things. We can do it in 5 to 6 minutes. Posterior shoulder, 4 to 6 minutes. Okay. So most structure we can do most area in 4 to 5 minutes. But we know it's at operator dependence and huge learning curve for this. And we know limitation because it has limited resolution, high frequency, has like depth penetration up to 4 to 6 mm only. And if you go to like deeper penetration, we get lower resolution. So that's important things. Still, there is no lack of standardization. Okay. So I will conclude the musculoskeletal ultrasound. We do for a sports ultrasound. It's known as sports ultrasound. You can call. And it is a game changer in sports medicine. And accurate diagnosis is the key. For that, not only ultrasound is required, ultrasound is able to confirm it, followed by the clinical examination so that we are able to know the which structure, because we can get the abnormal ultrasound images, but that may not be causing pain. So that is the great, and it requires more than a decade of the experience. And so ultrasound provides comprehensive assessment and guided intervention. When I say guided intervention, not guided, only guided intervention, but it guides the intervention also. Whether we should do intervention or not, that is the most important thing. So mastering ultrasound is required, as I told, anatomical knowledge, followed a scanning technique, then pathology identification, and then finally it's a passion for it should be there. Thank you.
Thank you very much, sir, for an insightful talk. Do we have questions or comments, sir, from the senior professors? Anyone? Dr. Manish. Senior professor. Please, Dr. Manish.
This is administration and logistic issue. I am working in the institute. Our institute take care of everything. It comes through all protocols, everything. We don't have to do anything. But in private sector, it's really. But I think if people are getting, one should apply in the civil surgeon office and you will get. We can also take question after this session, but all speakers will be there.
Madam.
So, let's say point of care ultrasound is a game changer in sports. And we take a scenario like this, in which an athlete, and we take the normal pathogenesis of like what is the clinical finding we get. We have a hamstring tear. Such an athlete who's a runner and she presents with sudden onset of hamstring pull and she has excruciating pain. Now, the typical finding of a posterior ecchymosis, which is the clinical textbook findings, that you will get a ecchymotic patch, you will get severe pain. Ecchymotic patch would be actually, it will be confounding our findings. So you will be confused whether it is a back patient or a thigh patient, that thing. Then MRI, you cannot go for an MRI way on the field. If you have a point of care ultrasound there, it will be definitely of help to you. So nowadays we have a very small probe, which is also under the PNDT, like you need to follow the guideline, but there is a butterfly probe, which is now allowed in India. And many centers, I've heard that Army has procured many for the on-field, for military, for their on-field services. So these should be incorporated in sports scenario as well, where definitely time is everything, and it is important for the athlete to return to sport on time. As I said, posterior high FM muscle would be not every time it would not be good. X-rays would not be helpful. MRI you cannot go for. Patient will be in severe pain. So the importance of point of care ultrasound. I'm talking about hamstring. We'll just start with the basic anatomy. As you can see in this athlete, the muscles very well demarked. And the semitendinosus tendon. And on the lateral side, you have the long and short head of the bicep femur. So the semitendinosus is coming down and attaching the middle half of the hamstring. On the tibia medial side and the bicep fibula on the lateral side. Knowing the anatomy is very important, as Dr. Raj also emphasized. Now, this is a tuning fork approach which is followed in hamstrings. So there are two forks, and for hamstrings, usually we follow the tuning fork approach. So that it has a tendinous origin of the hamstring. There is a proximal half, the tuning fork. Then we have the medial half or the distal end, and the other distal end, which is the lateral half. So you can visualize it as a inverted tuning fork, like this, where you can easily see that the tuning fork, which is the handle of the tuning fork, that is showing you the hamstring origin from the ischial tuberosity, and this approach is landmark guided. So there is another approach which is volumetric guided, so muscle volume guided. But I'm talking about landmark guided approach, in which at the handle of the fork, the landmark will be the common tendon. So we all know that when it is attaching at the ischial tuberosity, there is a common tendon and the semitendinosus muscle. Mainly, you will see that. So that is the landmark of the fork handle. As we go down, you will see the curvature of the tuning fork, in which the landmarks will be a Mercedes-Benz sign. We don't have a pointer. So I'll show you the Mercedes-Benz sign in the subsequent slides, in which you see the sciatic nerve, and flanking the sciatic nerve, you will see the biceps femoris and the semitendinosus muscle. As you come down, you will see on the medial side semitendinosus and semimembranosus. On the lateral side, you will see the long and the short head of biceps femoris. This is a cut section. If we want to just go through the anatomy once again, because as we know, anatomy should be very clear before we do with ultrasound. So here, easy to see the semitendinosus and the semimembranosus muscles, which have been taken out. You can see that the semimembranosus muscle So this is important. When you're scanning with the ultrasound on the proximal part, you will see the muscle clearly seen here, flanked by the semimembranosus tendon, the medial side. The semimembranosus tendon is there. And on the lateral side, you will see the biceps femoris. So, and that will be conjoining, you will get a conjoined tendon there, in which biceps femoris forms a tendon. Semitendinosus muscle bulk also there. So here only we also appreciate the Mercedes-Benz sign. I will show you in the first one slide. And you can easily see another anatomical landmark in the semitendinosus muscle. There is an oblique line there. So semitendinosus muscle is a digap muscle. It has different, there are different components of the tibial nerve which give innervation to both the segments of the semitendinosus muscle. This is also important. When we scan the semitendinosus muscle, we get a raphe there, and we get a curtain-like appearance, which you might have appreciated. When you go from the distal to the proximal side, you will get the raphe. This raphe, which you can see in the semitendinosus muscle. Now, and on the lateral, you will have to, the landmark will be shattered now for the biceps femoris. So there are different approaches. Different people have said that you can go from medial to lateral, you can go from distal to proximal. So Jacobson has, there is a good paper by Jacobson which states that he says that you start from the medial side and then you will appreciate a triangular section of the semimembranosus muscle on the proximal half I'm talking about. Then once you're keeping your probe on the proximal part of the thigh, you will see a triangular section on the medial side, followed by on the lateral side, you will see the semitendinosus and the biceps femoris. Whereas Bianchi and Macchioni, they have said that semimembranosus in the short axis plane, you appreciate that and then move distally. Then you will see the semitendinosus and laterally you will see the section of the biceps femoris. Now, it totally depends on you, what suits you best. So what I follow is, I go from distal to proximal. So once you go from distal to proximal, you know the anatomy. You know that anatomically the semimembranosus, semitendinosus is attaching on the medial part of the tibia. You start from there. You will see the bulk of the semimembranosus and a small tendon of the semitendinosus, and you start scanning up. On the proximal part of the thigh, you will appreciate the which I'm going to show you just now. So this is the proximal part of thigh. Now you can see this on the right side of your the screen. You can see the probe position. The probe is kept horizontally on the proximal thigh in this case, and what you will appreciate is also on the left side of the screen. So this is Mercedes-Benz sign, and the central part, the Mercedes-Benz sign, that symbol, that is the sciatic nerve, right? In the center is the sciatic nerve. So flanked by, as I told you, on the proximal part, you get the semitendinosus muscle bulk. So this is the semitendinosus muscle bulk, ST, right? And on the lateral side of the thigh, you will see the biceps femoris. So this knowing what is normal is very important to be able to appreciate the pathology, right? So this is the normal architecture, how you see on an ultrasound scan. And this slide is also important clinically because, as you all know, conjoint tendon is the most important part of the injured, which is injured in an athlete. So getting conjoint tendon injuries, that's the most common thing. And most important intervention also you go for at the conjoint tendon only. So I think there are many presentations by speakers about PRTs. So the most common intervention, which is in sports for hamstrings, will be an ultrasound guided PRT at the conjoint tendon. So appreciating this conjoint tendon is important and looking for this Mercedes-Benz sign. If you keep the probe, I'm right now at the proximal part of the thigh only. If you keep the probe vertically, what will you? B and the C is the kept vertically. On the lateral side, biceps femoris, this is the longitudinal section of the muscle, and that is the longitudinal section of the semitendinosus, where I showed you, where I told you about the digastric nature of the muscle. So you will see a oblique pattern, a rapid in the semitendinosus muscle, which is also important to appreciate. If that is deranged, if you're not able to see that oblique pattern, you can suspect a semitendinosus injury. So appreciating the normal architecture of the muscle, that is very important. Now, as I told you that you can go either from proximal to distal, or you can go from distal to proximal. It depends on your ease, how you are comfortable. So once you're coming from the proximal part of the thigh to the distal, what are the cut sections you will get? In the proximal point, you will get, as I told you, semitendinosus muscle bulk, right? The muscle bulk is there, flanked by semimembranosus, tendon will start appearing. which you can appreciate in the second diagram. Once we are coming down, you can start seeing the SM right on the lateral side. You can see there is SM written. So that is the semimembranosus muscle which is starting to appear. In the first diagram, semimembranosus will be a tendon, right? So semitendinosus muscle, semimembranosus tendon, and flanked by the conjoined tendon on the lateral side. As we come down in the second part, you are starting to see the semimembranosus muscle coming up with the semitendinosus there. As you go down, semimembranosus start becoming bigger, right? We know that on the proximal part, semimembranosus is a tendon, and as we go down, it starts to become the muscle bulk starts appearing. So that you can appreciate the third diagram, in which semimembranosus is starting to become bigger, semitendinosus is starting to become smaller. As you come further distal, semitendinosus is small bulk in the last section you can see, flanked by a bigger semimembranosus muscle. So this is how you scan the medial hamstrings. Another important thing which you can appreciate by the thigh ultrasound, if you go for it, is this architecture, in which you can appreciate the pes anserine muscles, right? So if you keep the probe in the distal and towards the medial side of the thigh, what you will see is if you go from lateral to medial, right? You will see semitendinosus. This is the cut section, cross section of the thigh at this level. This is the probe position kept horizontally on the distal part of the thigh. So you will see the semitendinosus muscle, then followed by semimembranosus, gracilis, sartorius, and vastus medialis. So the girl between the two, that pes anserine muscle bulk, that is also can be appreciated from the proximal, from the posterior thigh ultrasound. And I told you about the medial hamstrings. Coming to the lateral hamstrings. So medial hamstrings, we saw that it was landmark guided. We saw the Mercedes-Benz sign, and then we saw the volumetric difference between the muscle of semimembranosus and semitendinosus. Coming to the lateral side, talking about the biceps femoris, here you have to keep it in mind that you have to trace the sciatic nerve. As you start tracing the sciatic nerve, which I showed you in the Mercedes-Benz sign, from proximal to distal when you're coming, the biceps femoris short head will start appearing. So here on the small triangular part, biceps femoris short head, which is starting to appear. So, and you can see in that fourth diagram, the short head is becoming bigger, right? It's an oblique, parallel, just starting to appear. So this is how you will scan. So we have talked mostly about the proximal thigh, the medial arm, the lateral arm. This is majorly the hamstrings. And clinical implications are important here. So this is a very good paper. Whoever wants to go and read about it and start doing the hamstring ultrasound, they have talked about the sonographic landmarks in hamstring muscles, and I majorly covered them. So this is going for the case scenarios. I'll just talk about 2-3. I told you about the conjoined tendon pathologies, which is the most common in sports. So going for a conjoined tendon, you will see that conjoined tendon becomes thicker. The architecture changes. You can see edema there. You can see hypoechoic shadow there. Then you know, and you compare it with the normal side. You know that there is a pathology there. You can correlate it with the MRI and then go for an intervention if indicated. In this, this is the MRI floor image, and this is the ultrasound image. You can see the ischial tuberosity where the hamstrings is attaching. It's a long axis view, so the probe has been kept vertically in the proximal thigh like this, and you are able to appreciate a small hypoechoic shadow, the lateral one that's the screen towards me. So that hypoechoic shadow is the retraction of the tendon from the ischial tuberosity. It can also be appreciated there. I'll just quickly conclude I'm just telling you about one more scenario and I'm concluding it. So This is a semimembranosus bursa, which can be seen in the MRI scan. Now, if you have got an MRI picture and you want to go for an intervention, how to go ahead? So this is the ultrasound image of the same MRI, and you can see the semimembranosus bulb. It's there, and there is a U-shaped bursa, right? And this is the in the plane approach. There are two approaches. If you go along the plane of the probe, it is in the plane approach. If you go obliquely, the other approach, it is out of plane. This is in the plane approach of an intervention, and this is how you go ahead. So in the plane of the probe, right, which can be appreciated here. That's all. Thank you so much. If there are any questions, I will be happy to answer. So I think you were talking about the PCP and the how to get it in your department. So in an institute, if you are affiliated to any big institute, it's easy to procure. In a private loan setup, there is the challenge, right? So that then you have to talk to the civil surgeon, and maybe they tell you to be associated with a radiologist. So that is how you go ahead. But in a bigger institute, it's easy to procure.
Small
Yes, sir.
Very nice presentation.
Thank you.
Thank you very much. I just want to know that being clinicians, we are all the time seeing the hamstring strain is one of it's an headache in
Yes.
any sports also.
Yes.
Straight to strain and a chronic hamstring. What do you see in ultrasound? Of course, in acute we know there's the edema, there's the heterogeneous, there's all things there. In chronic nature,
Yes, sir.
where there is massive amount of fibrosis take place. In
Okay.
case you have a picture, we'll love to have it.
So I don't have a picture right now, but I can share how it appears. So fibrosis will be there, and if we know the normal architecture, how what I showed, the architecture will be deranged. So I have a very good case of a para athlete. He's a runner, and he has a biceps femoris tear, a chronic one, as you said. And his when we go on the biceps femoris and we scan it, what we get is totally deranged architecture. We don't see the short head of the biceps femoris, and we see straight away the long head. So that is what we see, and mainly the architecture is deranged, and we don't appreciate that muscle only. So we are basically
All of the muscle you see that
no only in the distal parts, sir, where that fibrosis has happened. So with him, we are going for strengthening. We basically are focusing on his return to sport and going for a graded return to sports.
Thank you very much. Doctor.
Very good morning.
I'm going to be speaking about rectus femoris injuries in sports and ultrasound perspective. Rectus femoris injuries very common in sprinting, jumping kind of sports. Seen a lot even in football players. So when we look at rectus femoris injuries, we are concerned with the tears in the rectus femoris. It could be in the central aponeurosis. It could be in the muscle. Avulsion of the direct head from the anterior inferior iliac spine. And there could be injury to the indirect head that comes from the superior aspect of the acetabulum. So when we see ultrasound in musculoskeletal injuries, mainly the role is you get real-time imaging. You can detect the muscle tears, tendons, ruptures, avulsions. The advantages is that you can detect the hematoma. You can precisely go and do the interventions, aspirate the hematoma. So it's very important in sport medicine. Now coming to the rectus femoris avulsion, the rectus femoris is a part of the quadriceps muscle which runs, rectus femoris runs from the anterior and inferior iliac spine to the patella. And injuries in this, when there is avulsion, it attaches, the direct head detaches from the anterior inferior iliac spine. Sudden forceful contraction during sprinting or jumping. And the treatment goals is to restore the muscle integrity, function, pain relief, and then minimize the complications and return to sport. So when we look at the anatomy, so we'll start with the picture on the left. So when we see this is the anterior inferior iliac spine, and we see the rectus femoris, we see the indirect head, which is the bigger arrow, and we see the direct head, which is the small arrowheads on top. So moving on to the second image. So this is seen in short axis. So how you place the probe is you place it on the inguinal ligament, go laterally, find the anterior inferior iliac spine, and that's where you see the first in the short axis. When you located the anterior inferior iliac spine, you turn your probe longitudinally, and that's the picture you see. And in that, you see the long axis, you see the eye is the anterior inferior iliac spine, and the tendon, that is the direct head, passing there. When we move the probe laterally, this is the image we see. You see the hypoechoic reflection in between, that is the indirect head. So when we move our probe laterally, this is the image that we see. We see a hypoechoic reflection, that is the indirect head. And so this is the indirect head. Now, when we see this hypoechoic, this is when and when we turn the probe, we see the indirect head of rectus. So this is the basic anatomy, how we are going to locate the direct head and the indirect head. Now this is short video. So this is the distal end, that's the proximal end, that is the anterior inferior iliac spine. Now when we move the probe laterally, first you see the direct head, and as you move it laterally, we see that hypoechoic reflection, that is the indirect head. Again, that's the proximal end, that's the distal end, anterior inferior iliac spine. So that's the direct head. The hypoechoic reflection is the indirect head. Now, again, this is the anterior inferior iliac spine. This is where that's the anterior inferior iliac spine. That's where. So that's the head of femur. Now, as we move laterally, we find that hypoechoic shadow. This is the indirect head. Now we turn the probe to 30 degrees. When we turn the probe, we can see the indirect head in the long axis, and that's the indirect head. So anatomy is key, and now we move on to a case. There was a 25-year-old female pole vaulter who had a sudden forceful takeoff in pain in the groin area. When we examined her, she had pain on the straight leg raise. The resistance straight leg raise was painful. The power was decreased. Got an MRI done. It showed the coronal images showed the tear in the rectus femoris. There was an avulsion from the anterior inferior iliac spine. The ultrasound confirmed the avulsion, and it was treated conservatively. Mostly the proximal rectus femoris injuries, they work well, they respond well to conservative management, and ultrasound guided PRP was given. So again, just finding the anterior inferior iliac spine, finding that spot, and then going in the long axis and injecting the PRP. When we move to the actual, even the muscle, the anterior thigh, we see that the rectus femoris and below it is the vastus intermedialis. And when we go laterally, below that, we see the to the side, we see the vastus lateralis, and on the medial side, the vastus medialis. So this is a tear in the rectus femoris muscle. So you can see a hypoechoic shadow that. So we before we inject anything, we aspirate the hematoma. So rectus femoris injuries do well with conservative management. The post-injection rehabilitation is very important. In the first phase, you do simple stretching and get back to functional training and return to play. So the outcomes of ultrasound injections are good in the proximal rectus femoris small avulsions. They're good in the muscle tears of the rectus femoris. The only complicated part is when the avulsion is on the lower end, where it inserts onto the patella. Those injuries are difficult, and the central office injuries are a little more difficult to treat. I conclude my talk here. Thank you, and so take any questions later.
Over Dr. Kati. Now I invite our next speaker, Dr. Susanti, contact from.
कहीं
Presenting on the topic of sono anatomy of the medial side of elbow and a brief on ultrasound guided babakai. Let's begin with our presentation. We'll talk about the anatomy, the scanning techniques, the normal sono anatomy, the common injuries of the medial side of the elbow, the pathological findings, and finally ultrasound guided intervention. Now, why the medial side of the elbow? Because as we know, after Neeraj Chopra won a historic gold in the Olympics, there has been a rise in the number of javelin throwers and also in the rise of medial-sided elbow injuries. So the sports associated with medial elbow stress. Now, when the elbow stresses, what happens is there is a valgus stress on the medial side, where there is a tensile stress. On the opposite side, the lateral side, there is a compression, and on the posterior side, there is a shearing stress. So the sports which are associated commonly are javelin throwing, baseball, especially the pitchers, tennis, golf, American football, the quarterbacks, gymnastics, volleyball, the spikers, setters, and weightlifters. Coming to the anatomy of the medial elbow, we talk about just three things. Common flexor tendon. So we just focus on the pronator series. Flexor carpi and gravis, palmaris longus, flexor carpi and gravis. Now in this is a mnemonic. It's very easy to remember. So when you see, you can just take your arms. The index finger is the pronator series, the flexor carpi and gravis, palmaris longus, and flexor carpi and gravis. So this is how this happens. This star asterisk sign is the ulnar nerve. This is the medial epicondyle, and this is how the common flexor tendon comes out. So it's easy for you to do the ultrasound later on. Then next structure is the ulnar collateral ligament. So in this, there is the ulnar collateral ligament is made of three parts. One is the anterior band, which is a cord-like structure coming from the medial epicondyle to the sublime tubercle. The second part is the posterior band, which spans from the medial epicondyle to the ulna, and the third is the oblique band, which connects the anterior band to the posterior band. The third thing is the ulnar nerve and the cubital tunnel. Let's talk about the borders first. I'll show you the medial wall, the medial epicondyle of the human. The lateral is the olecranon. The floor is made by the medial collateral ligament. The ligament spans between the medial epicondyle and the olecranon. Now this ligament standing techniques. Now the patient's position. Whenever we do intervention, it's better to make the patient comfortable. So we make them lie down supine. Then the shoulder is at abduction and external rotation position. The elbow is flexed between 60 to 90 degrees with the palm facing the root. Coming to the position of the probe. So we prefer a landmark-based approach where you first keep the probe on the medial epicondyle, and then let me tell you two tricks. For optimal imaging, you should point the distal end of the probe towards the little finger if you want to visualize the if you want to visualize the common flexor tendon, you turn the probe a little and point it towards the thumb of the dish. Now coming to this normal sono anatomy. So common, this is the position. Normally this will appear like, so this is the position, as we said, medial epicondyle point. Normal Now, that this is the medial eccondyte. This is the auricular nerve. This part is the ulnar collateral ligament. And this is the common flexor. So, ulnar nerve. Now, for ulnar nerve, there is a different technique. This is the posterior viewing approach is a better technique to visualize the ulnar nerve. We'll go into detail a little later when I show you the video. That will be easier for you to visualize. But you should know that ulnar nerve, when you see it on a when we keep the probe transfer, it will be ovoid, echogenic with multiple small hypoechoic spaces, which represents the bundles of nerve fascicles. Longitudinally, it will be hyperechoic and hypoechoic fibrillar pattern will be seen, but it is less fibrillar than tendon. Lastly, and the most important is the ulnar collateral ligament. This is another approach which has come up recently. The first approach, as I showed you in the first picture, this is a posterior viewing approach in which the patient is seated, the elbow approximately 45 degrees left with arm gently externally rotated. Now, what we do here is you begin with the common flexor tendon origin in the longitudinal view, keeping the marker end of the toe fixed on the medial epicondyle. So, at no point you should miss out on that bony landmark, which is the medial epicondyle. Then you rotate the non-marker or the heel of the transmission posteriorly until the sublime tubercle of the ulna. Now you will be able to see a very beautiful back. I'll just move this part so you can see. So, right, you can see moving on, you when you try to rotate posteriorly, you will come and you will find the posterior band of the ulnar collateral. So this is the same receipt. Now coming to the pathological findings, we'll start with medial epicondylitis. So in this case, epicondylitis, there will be thickened, it will be thickened. And in cases of ulnar collateral ligament tear, we will see two things. One, you can see that the ulnar collateral ligament, the fibrillary pattern will be disturbed. The ligament will become bulky, thickened. That will be that you can visualize air bubbles in the joint space. And on doing dynamic valgus stress test, you will see that the joint is opening. There's a video I'll just play. So in this, we can see. So he's palpating a medial epicondyle. Marker of now you will see that this should be pointing towards the middle finger, so that you can visualize the ulnar collateral ligament. See, so beautifully you can see the ulnar collateral ligament. And this is the joint space between the ulna and the humerus. To the dynamic valgus stress test, so he is giving stress and he's seeing whether the joint is opening or not. So again, as ma'am also mentioned about Martinelli, he's the person who has explained about this. Now the second part is the common flexor tendon. Now can you see we turned this slightly changed, and this now it becomes the common flexor tendon. So you change the probe left slightly and you will find nervous anatomy. One interesting finding is the ulnar nerve subluxation. So in this, I'll first show you what is normal again. Ulnar nerve, as I said, it's to be second would be on the olive. So this will be molecular. This is the ulnar nerve. This structure is the ulnar nerve. Now again, dynamically he is checking whether the ulnar nerve is subluxated or not. That so subluxation 90 degrees of flexion and it is pulled by the ulnar. I will quickly finish off this presentation by just showing you how the subluxation looks like. Another 32 seconds. Just keep, so this is the medial epicondyle. So, no. see how it will subluxate. I'll keep moving. Moving. Plastic materials. Why do we do it in cases of calcific tendinitis, myositis, ossificans also? How do we do it? I'll just briefly tell you. I'll show you the video and I'll explain it to you. So can you see this mirror? So we just irrigate plastic. So this is the little image of the computer, and then we see this calcification which comes up when we do this percutaneous intervention. And these are the references that I went through. Any questions? We can probably take after lecture. Thank you. With diagnosis of diagnosis followed by ultrasound guided interventions. Since I have only 15 minutes to go, so I'll be covering all the important structures: medial collateral ligament, the lateral collateral ligament, then patellar tendon, anterior cruciate ligament, posterior cruciate ligament. So we'll start with the medial collateral ligament. It is the last structure on the medial aspect of the knee. We have superficial part and the deep part of the MCL. So how do we see the ultrasound? We keep the patient in supine with knee 30 degrees of flexion, and we keep the probe in the long axis of the MCL. So this is how we see MCL. So this thin hypoechoic homogeneous fibular pattern. This is our medial collateral ligament part. And the structure which is near to the bone, this is the deep MCL. So this is the normal MCL, is looking the superficial part and the deep part. The fibular pattern is maintained. However, on the affected side, here we can see the thickening of the medial collateral ligament. The fibular pattern is also blocked over here. There you can see a hypoechoic halo. So this is the case of the partial tear of the medial collateral ligament. So I'll be showing a video of how to see. This is the femoral concha, the normal. So as we go down, this is our medial joint line, meniscus system over here. So this thin hypoechoic structure is going on the tibial aspect. So this is the tibial attachment of the medial collateral ligament. So I'm showing a video of the affected side. So this is the thickened part. See over here. This is very thickened as compared to the normal side. I go down. So this is we go the tibial attachment. So next how we give injection. So we can give corticosteroid injection or PRP injection. So this is a case of giving corticosteroid injection, implant technique, approach from superior to inferior approach. And here I'm giving the needle. So in case of the corticosteroid injection, we don't give inside the ligament, we give below the ligament or. And next, I'm showing a video of how we give PRP injection in MCL. Well, if we give the PRP injection, we can give directly inside the ligament. And under the ultrasound guidance, we can change the position here and there where we want to give the injection. So this is how we give the injection. Coming to lateral collateral ligament, this is on the lateral knee, as you can see here. So how we examine? So we give the patient in supine with mild general rotation, so they can force the lateral aspect of the knee. So how we examine is, so this is the femoral end of the LCL. The thin hypoechoic homogeneous fibular pattern. This is our femoral attachment of the LCL. As we go down, so this is the fibula. Since this thin structure fibular pattern, this is the fibular attachment of the LCL. LCL is little difficult as compared to the MCL to see in the ultrasound. So I'm showing a video. So this is the femoral attachment of the LCL. As you could see very nicely over here. As I'm going down, so this thin homogeneous hypoechoic structure is attaching to the hepatic fibula. So this is how we see LCL in ultrasound. So I'm showing video of how we give the PRP injection in LCL. So we give implant technique. So this is our LCL. This is the fibula. So when I give the injection, there will be separation of the fibers over here. I give intraligamental injection since this is a PRP. Coming to patellar tendon, which is on the anterior aspect of the knee. So how do we examine? We give the patient in 30 of the knee section. We give the probe in the long. This hypoechoic homogeneous structure. This is our patellar tendon. So I'm presenting a case of 19-year-old footballer presented with a 2-month history of the pain on anterior aspect of the left knee, which was worsened over the past 2 weeks. And this is how I get the patient position. And on the right side, this is the inferior pole of the patella, and this homogeneous fibular hypoechoic. This is our patellar tendon. And on the left side, this affected side here, we could see there is thickening of the patellar tendon. Here on the normal side, 3 millimeters. Here it comes around 6 millimeters. And another thing you can appreciate is hypoechoic structure, which is probably the inflammation or the tear. So this same patient I examined in the third axis. So this is in the third axis. I keep the probe in the third axis of patellar tendon. So this is how we could appreciate the patellar tendon in the normal side. So on the affected side, as you can see, there is thickening of the patellar tendon with the hypoechoic structures in between. So this is the case. So this case I have done Doppler ultrasound as well. So this is on the normal side as we go from inferior patella to the tibial tuberosity. There is no increase in vascularity is appreciated over here, but on the affected side, this is the increased neovascularity on the affected side. So this is how we can confirm the critical case of the patellar tendinopathy. So this patient has given injection PRP. So we give the probe in the third axis of the patellar tendon, and we give implant technique of the PRP injection. So this is whole thickness is our patellar tendon. So as we give the injection, this is our needle, and we could appreciate the separation of the patellar tendon, this fiber. So this confirms that our PRP is inside the patellar tendon. So the post PRP 2 months finding of this similar patient. So this is before the PRP, but 2 months after the PRP, when I do the same Doppler ultrasound, but there is no neovascularity. It has completely lost. But hypoechoic fibers are still there, but it has very much reduced. So this is the benefit of the PRP injection, which I have shown in my case. So coming to anterior cruciate ligament, which is on the anterior goes from the lateral femoral condylar figure anterior spine. So how do we examine the ultrasound is we keep the patient in full knee flexion, as you can see here. First, we keep the probe in the long axis of the patellar tendon, and after that, the inferior pole of this probe is medially rotated around 20-30 degrees medially. Why? Because we are keeping over the anterior twisted ligament. So I'm showing how we see the ACL. So this is inferior pole of the patella. So this is our patellar tendon, and this is the tibia, and this triangular structure, hypoequial triangular structure, is the or Hoffa's facet, and this structure, this hypoequial structure lined by the hyperequial structure, this is our ACL. So this is how we see ACL in ultrasound. So we have to check whether it is the origin of this ACL. It should be around 11 millimeters, around 1 centimeter from the tibial tuberosity, and we can measure the thickness, anterior-posterior thickness as well. So I want to show a direct dynamic sign of ACL injury. So this is the ACL as I have discussed. So when I bring the knee in passive flexion, this ACL will be moving forward. Will move forward. What happens? It will compress this Hoffa's facet in between this patellar tendon and the ACL. So just like sandwich, it is a sandwich when we used to call it. So this is in the normal side, as you can see, this is ACL. When I bring the knee in flexion, so this Hoffa's facet is compressing between the patellar tendon and the ACL. So let us compare on the affected side here. Hoffa's facet is going here and here, not compressing completely as compared with this. So this is one dynamic direct sign of the ACL injury. So another, I'm showing anterior tibial translation. So I'll keep the patient in prone position, and I'll give pressure on the posterior aspect of the tibia. So when we raise the proximal tibia, in this one is normal side, so there is no translation of the tibia over femur. So on the affected side, as see here, when I press, there is translation of the tibia over femur, as we could appreciate over here. So we can also have measurement of the anterior tibial translation. For this patient, I have done the same. And if it is more than 1 millimeter of the compared with the uninjured side, then it is found, we can say it is significant ACL tear. Coming to the injection technique, we have three techniques, implant technique. So this is the implant technique, superior to inferior approach. So we just put the needle just inferior to the inferior pole of the patella, and this is implant inferior to superior approach. We just give just superior to the tibial tubercle, tibial condyle, and this is another this is out-of-plane technique. So this is how we give PRP injection. So as this is I give implant technique. So this is our needle, this is our ACL. When I give the injection, there will be separation of the fibers, the transmission of the PRP or seen over here. Coming to the posterior cruciate ligament, this is the PCL. How do we examine this? We keep the patient in the prone position, and this is the MRI picture of the PCL seen over here like this. So this hypoequial structure is our PCL. So how do we see in ultrasound? We just find the posterior this artery neovascular structure. We found out the tibial tubercle, and this hypoequial structure. This is our PCL. Just find the posterior artery, just go medial, and we will be able to see the hypoequial structure, that is PCL. So lastly, this is the case of PCL injury. On the normal side, it is around 5.4 millimeter thickness. On the affected side, it has some 9.3 millimeter thickness. So how do we give injection? It is better to give implant technique because of we scared of injury to the neovascular structure. So this is our needle as we give the injection. So we could appreciate the separation of the fibers So this confirms that our PRP is inside the PCL. To conclude, ultrasound provides real-time precision with accurate and immediate insights. It enhances accuracy, diagnostic accuracy, and ultrasound provides minimally invasive precise interventions, and it enhances outcomes with faster recovery, with patient satisfaction. Monitoring ultrasound is the foundation of pediatric care. So to monitor ultrasound, we will practice multiple times. So this is ultrasound phantom, which is costing around 25,000. We can practice in here, but it is little costly, so we can go for. So this is only 250 rupees per 500 gram. So we can practice over here. So thank you so much. Thank you.
Hey, very nice, very explainable event. I have two questions.
Yes.
One is you said between PRP and the corticosteroid. What are your indications on that? And the second thing is you also said that when you are seeing the ACL, we have the upper pad also, which is being visualized over there. Upper pad impingement is again a very common problem that we see in sports.
Yes.
Of course, ACL is there. So how do you define over there in your imaging techniques? Upper pad, you see, when it is impinged, that's an impingement which is normally.
Yes, sir. Yes, sir. Coming to your first question, the indication of the corticosteroid in the MCL is actually we don't want. We prefer PRP injection rather than the corticosteroid injection. But in some patients who wants to return to sports, they like in 1 week. So that time we have to give corticosteroid injection. But we focus on not inside ligament, but in the inflamed area over the ligament or under the ligament, sir. But we prefer PRP injection, sir.
Corticosteroids are very, very problematic and
Yes.
ethical. That's why I raised it. So
Yes, sir. And coming to the second question, about bed replacement. So when we bring the knee into flexion extension, especially in the flexion, the patient will be complaining with pain and inflammation will be more in the HOPA area. Triangular structure, which will be more hypothetical structure will be there. But I haven't seen any case of the impingement in ultrasound, so I have not experienced yet, sir.
Yeah, absolutely.
yeah, please.
Sir, the first thing which you said, corticosteroid, like Dr. Swasti said that it return to play a role. And definitely we can give the steroid, but 10 days watch period is there. So QE has to be filled up because we are going to just for your
Yes, sir. Yes.
that want to return to school. So we have no option. And then you fill up a TUE and do the proper documentation and then you go for it. Second question, sir, like Mora, that as engagement one, so that can only be visualized on the MRI. Wait.
As far as infiltration with corticosteroid, I don't give you a question. But the point of the question is always that whether we use it, even under the guided also. According to my experience, I don't use it at all, especially in the ligaments and the gap. Even when the ultrasound also, but you have to infiltrate into the ligament and then cause more damage. Right.
Thank you so much, Dr. Swati. And we move to the next section, that is the physiology parameters. And I invite Major Dr. Amia Kadali, Ramia Amochi, the room.
Just a very valid point in the discussion which has come up over there is because the doctor raised about the TUE. Now, TUE, you see, it takes 21 days if we request for a TUE. And in such kind of injuries, when the athletes are always in a hurry or so, and first of all, TUE is not required in local unless a lot of orthopedic surgeons are mixing it, see also, and they are mixing both sometimes, so that of course will change it. Yeah, you need to have the photo. That's another point you see, because it has been raised.
State government should budget for local speeding, create guided infection, should not leave on the. Anurag, give the mic, sir.
The various branches involving parasport, where I'll just start off with an overview and an insight and predominantly more towards the classification aspect of things, followed by the other two esteemed speakers. One thing is that just to give a broad outline, generally when you talk about certain kind of impairment or disability, we tend to categorize everything under one big umbrella. Okay. So today we are here to address benefits as such. Okay. So when I'm talking to give you a equivalent, I'll be giving you equivalent so that you guys understand better. If I'm talking about Olympics, I definitely not talk about cricket, at least until now. Right? So similarly, there is a Special Olympics, which is very different from Paralympics, it is very different from a Deaf Olympics, and of course everyone knows that it's different from the Olympics. So just a broad, incline of things. Secondly, it's unconventional. What makes it so unconventional? Do we need to get scared? Do we be skeptical? What makes it so unconventional? One is that the basic anatomy, which we are taught in the first year. Sometimes it's out of the window. Okay, like I heard the previous speakers talk about the MCL, ACL, EPFL. In a club field, it's going to be ADFL. Okay, so you again have to be, you have to do a lot of unlearning to learn again when you're dealing with a para. The definition of normal is again very different. From a perspective of an age for the other, I just use the word normal there. Because normal for them is something else. Okay? And then it's a multidisciplinary, so I do need my physios, I need my SNCs, I need the biochemists. Just the benchmark is more, the readings are more, It's just like comparing black male, African male, the ECG with the Caucasian ECG. The benchmarks are different, right? Basically, one is abnormal and the other is. Then it's, of course, multi-speciality and multi-disciplinary, and I put it as that because this is one area where we deal with a lot of people who neurology, neurophysicians, neurosurgeons, because we have a lot of wheelchair on athletes. So, right from the Brown Sequard syndrome, the rotary accident, poliomyelitis, cerebral palsy, pediatrics, such a vital call, because that's where. And when you talk about able body, we talk about obviously framing as LTE, right? Long-term active development. When you long-term development, you know, when, what age you get. When you to take into consideration and not get too scared or skeptical of it, but just, you know, with as when you work with more people like these, and especially in the departments, like as I mentioned in the neurology department, financial stroke patients. In fact, that was more in the last, right? And tournaments and travel are the iconic, it's the parameters, of course. Just like you have your world championships in physics for able body, even the athletes undergo these training schedules and the tournaments throughout the year. And in every sport, so every sport, like 22 events are there in the Olympics, in 22 sports, each having a world championship every year. So basically, the tremendous, right? Just in fact, 2 days back, we say around the next World Six event is in 2025. So I'm worried. Anyway, then what one is to six? Any idea what the ratio is like? It's more into research. So the 6 papers on sports medicine is 1 paper on marks. Okay, so we would like to change that. Any teaching there, be it MPD or an MD, in any branch now in Ramaya, we have almost right? Uncharted therapy, of course, very importantly, even at religion, there's a lot of blueprints. And it's not more than 15 more novels. No, this is the golden figure. There we just having. So just the option of the equals, IOS, the athletes can be given the same. Now, I'm going down. You throw, again, to them. Number, it's Monday. This one stays. I break it. Not eligible. So this brings me to the next point, which is something called the MIC, the minimum impairment criteria. Now, when it's in hospitals, they are still in there. Disability certificate. The disability certificate has little or nothing to do in the classification process of a physician. So clinicians and activity entirely field with the disability certificate, please take it with a pinch of salt. Because the requirement of the sporting domain is much different than buying a train ticket in confession. Yeah. In the other part of that, good sport law and the activity law. So we got an objective and not we want more empathy. We are people of science. So, and one must realize that when we classify, when we declare a person to become a para-athlete, they are competing with someone with a similar impairment. It's not you versus them. That, you know, or sympathy or any other half of a bit, they are that means that we can answer to the athlete. We can equal in 80 kilos, what we enough point of view, it's competing dangerous. It's these all. If the level at C7 vertebra, there is another athlete, we will complete him and there is a person with with lesion at the C7 level itself. If an amputee is there, more often than not get challenging here, because we will not find that many with that it's kind of entry. Now there is a lot of action and actually in the mid part. That's what we have to do. It's difficult to find eight things which all for one. So then let's put an ambiguity there, which is where we're talking about. So we can't do too many classifications and too many categories. The competition reduces. Whereas very less classification, it's unfair on the athlete. Right? So any and every task is under one of this impairment. There is nothing beyond this. So I would like all of you all who are practicing clinicians, physiotherapists, whoever it is, it's available on the net. They come under one of this only. Now the point of this is mentioned on the left side. It's not inclusive, but these are the main causes of what gives. You take any sport, in Paralympics specifically, I'm saying. Right? So just, we run through it. Impact muscle power, either side bilateral. Impact PRM, passive range of motion. Limb deficiency, as we said, leg length difference, we take the true length and the apparent length and then compare. So different sport has different, for example, for para-athletics, for javelin, it has to be at least 7 centimeters or more the difference. If it is 7.1 centimeters, you can participate. If the difference is 6.9 centimeters, you cannot. And trust me, it doesn't get this close. So now imagine, there's not a few, I think this is you already want it in your orthopedics, neurology, health medicine. But GP, whoever you are, you're going to need it. You take a knowledge, you keep doing. Now, like mentioned, we insist on with the athlete comes to the classifiers. So I am fortunate to be on both sides of the table since I'm an international classifier right now. So when it comes to me, I not only have to see reports, I have to examine the athlete and give my wording. Many a times there we have a conflict because the athletes have told, and it's not only applicable in India. Worldwide, we have classified Italians, Portuguese, Greece, all of them. So it's just because the athlete tells here, I think this is a form, just build this. This is a diamond type. No, we don't have an action. 6.9 centimeters, 7.1, it didn't make a difference. In clinical cases, there is form makes a huge difference. Not the margin of error. So please be very precise and don't give out a word. It makes the person job a lot strong and you're creating a lot of conflict. Ambiguity in the speech fine. See, they don't know about all these things. Now, if one prescription comes to me or if another test does not come to me, they will be able to decipher it and decode it. And I'll be understanding what these people will not understand. They will say, yeah, the government of what of say actually get a quarter. This pura matlab nahi ban raha hai. Which conversations on that? Then it's for only topic. So, for example, simple market it's going on in the pediatrics department. So now we are trying and we have to stay there. So that's what I think the needs for the children. And you can't wait for them to come. So you can go to various other departments and see the potential. That was fast. Anyway, then the regular impairment. These two have a separate domain. I don't want to confuse things more out here. The first intellectual impairment, I think the training in intellectual capacity, which is they don't know basically the 100 meter, 200 meters, 400 meters. We have to run in a particular phase. They don't know the mission branches into the class. It's not linguistic. These are the summer sports like this that are on the annual device story, trauma, all the thing works. And that's one thing. So most of the sports India have a ideal implementation, not reached the team sport yet. I mean, this para badminton, there is no team sport yet. Then there's winter, which is some part away from that. A lot of European nations have already world champions in this area, even with one sport, again, putting sports into the same. Some of those speaks. So, for example, if you are to have one sport that does not make you a paralympic for power sports. For example, in blind sport, you can chop blind footballer we can't get that. And vice versa. Of course, this sport, it's Olympics and Paralympics. And for you guys, there's something called as the MDL, which is there in every sport, that is the medical diagnostic form. We want to fill it up as competitively as possible and not in word itself. So then you will take it. In fact, you have to come to, I think, so the set of documents. Basically, we have 34, 51, it's never good. And you will want to for education. It's not that, it doesn't work that way. So if you see an automatically shown, okay, hypotonia, reflexes, superficial deep, you go back to the physiology textbook first year. There's a practical book, so all the respiratory exam, PA exam, CNS, muscular therapy, if you do that exam, anyone can fill the MDF as a medical diagnostic. What's that for? And yeah, the point is in what we know. You mentioned between ball and blind football. And eligible to compete in a sport, it can mean that the field is not eligible to compete in any other sport. So we need to give them options. Now here they can be conflicted because given a control in the athlete's life, sport is more than life for them, it's a way of life. Yesterday, Dr. Chetty mentioned that in terms of using drugs and medication to get fit. Now imagine the flight here. They have to pay social norms, community norms for not fighting. So they do whatever it takes to not just get fit, but to get classification. So this is just practically the most complex kind and almost 58 categories in one. So that's why you find, javelin throw and Olympics just one throw and done. In another sport, there are 2, 3, 4 categories. Stock is the world champion, ultimate is the world champion, some throw here, 2 pitches. With a pretty equally level. So, so there are multiple events happening because they don't see so much. That's athletics, Samipur, that Rakshita, for Indian run-out line who was in struggle with Karnataka. Even there is similar one this time. Jumping, Majapan, foot legging, 3 medals still there. There's slim jump, there's right jump. That's what throwing can look like. So most time you'll see that there are a lot of bench shoulders out there. You see that people for 50 seconds, that kind of pressure. Then nothing for cylinder brain, wheelchair bound is the brain. Table tennis has only wheelchair bound players, and sometimes they are only pretty players. A choice of picks, which will make more sense to you. Now, early playing someone like that, the gentleman is from Egypt, he serves it as he serves with his toe, spins the ball, right? So how will you exercise those muscles? You have to innovating and depending on what the particular anatomy of an individual is, and not apply norms of whatever twinkle is, or a squat or a lunge or deadlift is. It does not work with weighing in sport. Swimming again, he just has one leg. And the way he moves his torso is like to see. And have you wondered how that is the end board? He just rams his head into it. So then after that, immediately you go concussion case. So there you go, a scalp qualification. You should be, it's very normal to assess in that kind of situation. In fact, you anticipate it. In any other sport, I don't think you anticipate doing a right? That's archery. I've not put Sheetal Devi because everyone knows her. But Sheetal Devi's inspiration is this gentleman from USA who's been a reigning world champion, that's wheelchair fencing, wheelchair basketball. So this thing here to wheelchair rugby, I mean, it is a bloodbath in there. So we have to always be on our toes. Even emergency specialists, everyone is on their toes there. These two sports, world war and blind football, are specific to Paralympic sport, and they don't have an equivalent in the Olympics. And of course, PCR. One of the more sports with the highest level of impairment and central party. That's it. So just the challenge I think Podema can take on a others can there is a little bit of history in this stuff. Like history, so he mentioned this in my slide, and I don't take much of your time. Thank you for listening. And I hope I change this to many equals. Thank you. questions now at the end of it.
Afterwards, you take it when you want to.
Yes, ma'am. I'm here for guidance. Thank you.
With wonderful talk. So I invite next speaker, Dr. Arif Kishore. CSMR, New Delhi.
And right, so we are talking about para sports and also the physiology medical engineering. So here still not medical examination is done. I will show you what is the commonly seen medical examination and how to emphasize rather just plain examination. What other thing you should do and we are not doing. Right? Though we are excelling every day in para sports, but still a lot of more needs to be done. Right? So starting. So first of all, the subject angle challenge. Look at one guy at the left and one guy at the right. You both have to make them think. One has able body, fast legs, well developed, and the other one is actually running on artificial legs. So let's to make them win the race. And that too with the best. So make the run time. Give the race for or if you try to say when you want to see the best line of the world, so you can only make that's why the medical classification is done. That doing the medical classification needs a good medical examination also. Okay, so moving forward. So you have seen this impairment category, everything has been very well explained by them, right? So you see one amputee, one with cerebral palsy, one on a wheelchair, one with a dwarfs, one with a blind person, and you know the girl in the bus. Oh, excellent. So some people are watching sports. That's so good. Okay, so moving forward. So the most important thing from where we start evaluating the athlete is the pre-participation examination. So in pre-participation examination, in case of Paralympics, it completely differs from what you see as a normal or an able-bodied guy, right? So a history of seizures, a history of cardiopulmonary disease, renal disease, plantoaxial instability, openness, right? Something like fracture dislocations, prosthetic devices, right? And a very common impairment you don't see in sports is Down syndrome. You have to ask some questions regarding Down syndrome also, right? For athletes with Down syndrome, spinal cord injuries, and other things. Okay. If you can see on the far right, there's a guy. You can see the relative muscle wasting. What can be the disease? Relative asymmetric polio. It's the best example. And you see the guy on that left. What would you like to call him? A fit person and unfit person. What would you like to call him? The person in here in the left, down left. If you want to call him fit, you want to call him unfit, just with some specificity. What should be the background? I want to make it interactive. Don't just want to give a lecture. I want to make it real in practice so that you don't see. Okay. So a person, and can you see that image of the skull? What is being shown there? If anybody can try to diagnose it. It's a clantoaxial instability. It can lead to paralysis. So these are small things which you should always know. And very important, the signs of cerebral palsy, right? Impaired eating, impaired balance, impaired coordination. That's why a good medical examination and that to pre-participation is more important.
You may see these deformities every day, like club foot, bottom foot, sharp foot. Okay. What is this condition called as on the left corner? What is this condition? What is this condition called as? Yeah, it's hypertrophy. It's physiological, pathological. Yeah, that's very important. You may think, hey man, he's living with cancer. You might confuse it. That's why a good medical examination is important. Hypertrophy of the cup, right? Due to fibrotic tissue injuries. And what is the common sign you see in clinical examination? Morse sign, very important. So these are very small things that you should emphasize in your examination, right? And very important and very often missed. Gait. The pattern of gait, that who all of you have attended the movement and gait analysis workshop from policies, right? So a gait pattern doesn't see how your joints are. A gait pattern can also tell the type of person you are indirectly. Okay, not scientifically proven much. Yes, but yes, then small impairments in gait can lead to diagnosis of very important diseases, just like the Quindenberg sign. Very often we miss. Well, how the patient, aging body, step on a single cord to stand on a single, how will we do a single leg stance test? Oh, there are people. Oh, that's good. I often miss it. It's very important because it also takes the time of the change, right? But for that guy who has lost or who has impairment in one of his limbs, so it becomes even more important because these are the small things which we miss. So a good examination can lead to a very good diagnosis. Type of gaits, a scissoring gait, maybe antalgic gait, right? Waggling gait. These small things should be documented very well. Now, the guy which I have shown you on the down there, he's a fit with special ability guy. So you can't tell his body type directly. So to counter this, there is a society named ISAC. ISAC came up with a method of photoscopic somatotyping. They said, guys, we can't blame him that he's born with this special type of ability. So you need to grade the fitness also. So the ISAC made a photoscopic somatotyping, right? Which grades the endomorphy. Endomorphy is a measure of mental fat. How much of fat is inside your body, indirect measurement. Right? Mesomorphy tells about your muscular nature and ectomorphy tells you about linearity. Okay, so according to the degree of linearity, muscularity, or the fatty substances in you, you are graded according to by seeing your photos. And according to that, the rating scale is prepared. We will not discuss it here. Maybe sometime we have anthropometry workshop of the ISAC. We can discuss it there. Very important part, movement and screening. Right? You just not have to make the patient walk. Ask him to do different types of maneuvers. Squatting, sitting on a chair, walking and then sit, walk. Right? That's how many of you do ask your patients, even in a normal person, to do a duck walk test? How many of you have asked? Oh, that's good. Very important to check the confidence in it. So for movement patterns, screening it becomes even more important to check these small defects. Well, you can find that in a number of ways very helpful. There's a proper performer now available, and you will be proud to know that this paper for movement pattern screening got published from India. See, such an important thing can be missed out. Now, what are the challenges of evaluation? Now, since awareness has been slowly rising up to increasing Paralympics and social media, but still the challenges still remain in India because we are a huge population, right? Dr. Bruckner, who comes from Australia, has only 4 crores of population to handle. We have 150 crores. So the challenge itself is quite great. But that doesn't mean he can't win. We have to win. We have our own challenges and we can win. And we have shown to the world that we can handle such a great amount of running. Like how many teams Kashi Vishwanath yesterday? Saw that? Was anybody fighting and killing each other? That's the art of India. We know we are the champions of crowd management. But we have to become champions in sport also. That is very important. Right? So some of the challenges which I have listed are lack of good facilities and good logistics, a good support staff. That is a very common thing that trained professionals are not available for these guys. And multidisciplinary approach, sir has very well emphasized. Guys, I need everyone. I can't do everything alone. I need physios also. I need rehabilitation specialist also. I need a podiatrist also. I need a nutritionist. I need a psychologist. The more we go towards multidisciplinary approach and a team approach, guys, in sports, does a player win or does a team win? A simple question to all of you. Team wins, the team effort wins. Even if there's an individual achievement for a single person, there's a whole team behind it. So if we don't develop a good team approach, we will never win in sport. That is very important. That is true for every sport. Right? And we don't, as of yet, now if you go towards the central government buildings, they are now having some dedicated facilities for specially able people. Earlier, we don't used to see such signboards. But slowly it is coming up, and many of the foundations have been helping them. One example is Go Sports Foundation in Bangalore under VP Bobaiya. Do see that. They are really helping many of our para athletes. Now some changes in physiology. So, guys, a para guy or a guy with special ability loses skeleton. Guys, how many of you attended the CPT workshop? Okay, so in the CPT workshop, what three things measure endurance? What three things are correlated by the CPT? Anybody from the audience? What three things are correlated in the CPT? Or three organs which are correlated in the CPT? The heart, lung, the muscle. If any three of them is impaired, your endurance goes down. So you lose skeletal muscle mass, so you lose your VO2 max, your fitness, right? And since you lose your muscle mass, you also have a problem with your spinal cord control. Since you lose spinal cord control, you lose your sweating ability, your temperature control. At the same time, because your muscles are not pumping well, you lose cardiac output also. And also at the same time, you may develop hypotonia, atonia, hyperreflexia, spasticity, right? And this may lead to muscle imbalances along with altered joint sense position. So there are some common medical issues which need to be addressed in a para athlete, just like autonomic dysreflexia, altered thermoregulation, pressure sores, neurogenic bladder, nerve entrapment syndrome, overuse injuries, and ataxia with low intelligence. So regarding the pressure ulcer, the first stage is non-branchial erythema, then the superficial layer is gone, then the deep dermis, and then you have exposure to bone and tendon. Likewise, in case of bladder, you have a spastic bladder, you have a placid bladder. In spastic bladder, retention is a common problem, and in the placid bladder, overflow incontinence is a problem. So you need to classify both of them. A very common medical issue that I need to address, especially for the wheelchair athlete, is the autonomic dysreflexia. So autonomic dysreflexia is that whenever there is a spinal cord injury below the level of T6, right? So there is loss of autonomic control. So below the level of lesion, there will be a lot of vasoconstriction. Vasoconstriction, the limbs become pale and cold, but above the level of injury, there will be extreme high flushing, there will be high BP, and due to high BP, there is reflex activation of baroreceptors that brings you in bradycardia. So is it disadvantageous or advantageous? My question to audience. Is autonomic dysreflexia advantageous or disadvantageous?
Fatal also.
Yes, I have answered correctly. It can be fatal also. It can be advantageous also. Yes, why? Because the blood flow in the upper body is increasing. He is not having legs, so he has to propel from the hands. The blood supply to the upper body increases, and this also can help indirectly to increase the heart rate. And he can use this as a method of cheating to gain advantage over his opponents. So that's why it can be sanctioned under doping. It is life-threatening. Most commonly, bradycardia has been reported, but in some cases, tachycardia has been reported. It can lead to sudden death. So how can you prevent autonomic dysreflexia? Check the Eurobag, check for fecal infection, check for pressure sores, and check for acute dislocation or fracture. Because they have impaired sensations of all of them. And they try to continuously retain it to use the boosting effect. Right? So autonomic dysreflexia should never be missed. Okay, you may be a lot of not because then the legs are not working for many wheelchair athletes, so they use hand as leg. So they use legs. So they due to overuse, due to faulty pattern use, and due to limbs overuse, they develop nerve entrapments. At the same time, since they are developing nerve entrapments, they also develop overuse injuries, more commonly in the shoulder, right? In the shoulder, in the finger, and the upper body. Guys, how are you doing?
This is already very late. Concluded now.
Almost done, sir. 2 seconds. Okay. So, guys, how many of you know this girl? This is Anulima Sinha. Despite having amputation, she climbed Mount Everest, and almost all high peaks of the world have been conquered by her. See the level. Having a prosthesis can bring you with these problems like in or loose fitting prosthesis, neuroma formation, Sudex osteodystrophy, phantom limb, tendonitis, stum infection, altered temperature control, and psychosocial issues. Right now, coming to the final slide. So what is your all's role as a healthcare provider? First of all, guiding for injury prevention. That is what I want that you should guide. Injury prevention, changes of prosthesis care, neurovasc changing and pet stores, recognizing the danger signs, and ensure that you properly refer to a person who has the knowledge of sport. Okay, if you know someone who is working with para athletes, please try to refer with him. Please try to have a conduction with him. Try to keep in loop with it. Very important point, which is very much missed by all healthcare providers, is guys, you have to be a very good listener and don't show sympathy, you show empathy, which sir has very well emphasized. Try to be in his shoes and try to think what will happen to you if the same thing happened to him. Try to keep him in your place. That is very important. And very important, you have to educate them regarding doping. They are losing a number of athletes due to doping. Guys, we don't win even 10 medals in Olympics, but we are first in doping. Very unfortunate statistic. So this awareness needs to come. And very important, the last important point, even if you take this point at home, my purpose is solved today. A good clinical examination with counseling and empathy can solve most of the problems. You have to be a good listener, guys. Some people are good listeners, but they are quacks. People fall prey to them. And I don't want that we lose athletes or capable persons to them. Okay, with this, I end my talk. If you have any questions, I am open to ask. Only one question I have. Any question?
Thank you very much for your talk, Dr. Aditya. Now I invite Dr. Purnima Raman on the madam for the next talk. Copy the madam. Yeah, 5 only 6. You must copy that. You have any other copy, any laptop?
I have my laptop. Can I put in my laptop? इसी में डाल दे.
The meantime, we can take any other question if somebody wanted to ask any question for Dr. Cynthia or Dr. Umi Angagani. You can ask. No further questions. Thank you. Actually, live transfer flow online. Where is it?
This is. My apologies for the delay. I'm Purnima Ramanandish and I'm still in sports physiotherapy. And I have been working on field for the last 14 plus years. And as Dr. Amey also said, well, sports is very close to my heart as well because I also started working at sports Tokyo Paralympics and we were preparing athletes to participate in Paralympics. And as you know, there are not a lot of research and not a lot of work has been done in Paralympics. So it has been very challenging and it's a different work altogether. So we would just like to, it's a very short time to actually explain everything in detail, but we would like to just touch the challenges and different techniques and areas where, it is very different from your able-bodied athletes. So. It's not happening.
I'm sure you're making video channels.
What is the file to take that?
What is
Just be with us. We'll start in a short time. No, you continue with your talk.
Yeah, I'll keep it PowerPoint and use. What's that? But the PowerPoint itself is hanging now.
No, you probably go. In the meantime, we will project the physical. We started the talk.
Okay. With the talk so that we will continue with the presentation later on. Basically, as a physical therapist, our role when we look at working with para sports, the first thing is to understand the classifications. So when we are understanding about the classifications, why it is important is, as Dr. Amey said, sometimes there are disabilities which cannot be very equal in terms of your medical disabilities, but some of these are classified as functional disabilities. So, above knee amputee or below knee amputee may not be able to categorize them in the same category per se, but their functionality in a particular sport might be same. So, as physios, we need to understand what is the functionality of the. Okay, you have to adapt to the individual needs, of course. That is very, very important, and that you will understand if you understand the classifications and the requirement of the. Now, this is how.
So when you saw this is Mariappan, which Dr. Amay had also shown. He had injured his feet when he was around 5 years, 4 or 5 years. A bus ran over his feet. And in the same category, we do have even another athlete who is polio. So technically, you can compare both of them, but then their functionality is the same. They compete in the same sport. I don't know if you followed Paralympics as much, but then if you remember, Maripan had a technical problem when he said because of the rains, he wears socks, the other athlete doesn't wear socks. So his socks were soaked up with water and he missed the goal by a bit. So these are the challenges that are there with para sports, which are not seen in able-bodied sport, which is very, very different. And each athlete presents with different challenges. So as physiotherapists, as healthcare professionals, you need to understand this difference. What is it? Now, I will go through this. I can share it later, but these are the basic differences between your able-bodied athletes and para-athletes. Just for understanding, I have broadly divided them into physical, visual, intellectual impairment. Though the classification is very wide, but the differences are almost similar. So visually impaired athlete will have a lot of different challenges that in one sense is absolutely not there. So they have to rely everything on the other senses. So you have to incorporate those things in your treatment program, your prehab program, your rehab program. So I'm just going to rush through these slides. You have differences in the training and performances as well. So your able-bodied athletes and para-athletes, your training is very different. Your competitions are very different. You're not competing with somebody who is exactly the same physical ability as you. Sometimes you might feel, like as Dr. Amay said, you might feel, you are competing with somebody who has lesser disability than yours. But that is the job of the classifier and the doctor to, look into that. That doesn't. There is a lot of use of assistive technologies in para sports. And then a lot of social factors involved in sport, especially in our country as well, because the socio-economic status also plays a major role. The funding and resources are very lacking. And the major challenge what we have seen with para sports is our stadiums are not built for para athletes, unfortunately. Because they are all built long ago and probably changes are very difficult to happen. There are changes happening, but still, if you ask me, can you leave a visually impaired athlete free to go into stadiums? Sorry, we can't. So I hope all of you do understand the difference between rehab and prehab. And rehab is particularly done to prevent injuries, and rehab is usually done post injuries in simple broad terms. But in fact, it is an ongoing process because when you look at para athletes, say again, I'll take an example of an amputee athlete. The pain doesn't go away completely. You are always working on everything all the time. So it's not that you have clear-cut phases where how you work with able-bodied athlete, like you work on the pain, the inflammation, the swelling, and then you go on to movements, and then you go into strengthening, conditioning, performance. With para sports, it's an ongoing process. So you have to be prepared to that. For that, we have to understand what is required for that particular sport. And again, I would stress on the same thing. What is the functionality of the sport it is participating in? That plays a very major role. So if you look at this as a physio, you have to have your assessment priorities with physical impairment, like it will be more for physical assessment and sport specific assessments and sport specific movement. Say for example, you won't train a para athlete who has spinal cord injury and is participating in say a club throw and probably a power lifter, because there will be first you need to understand how the spinal cord injury, the lesion is, where the lesion is, and how much impairment the athlete has. And again, what is the purpose of the function, what you're going to train the athlete for? So it is very, very specific. Again, your flexibility, your strength, power, coordination, and I have put in the athlete and support team education because this is something which is still very, very lacking. Just to give you an example, when we had been to Paralympics, all athletes were only given one attender. And one of the athletes, I still remember, was a paraplegic, had an elderly mother with her, and she had to go to the washroom and she couldn't, which is logical, but because it was just us who were running around and we were traveling, logistically it was very difficult for us because every event was probably more than an hour away. So to come back to the athlete, to just lift the athlete with the proper lifting techniques, and then help the athlete then go back on ground. These are the logistical issues which we have faced. So this education part is very, very important, and that is how you will understand. Suppose you are taking care of a team, you will understand how many people you need in the team, depending on the sport people are participating in, athletes are participating in, and what kind of disabilities they have. Now, when we look at visually in the athlete, it will again be a lot of departmental navigation skills, balance, mobility, sensory integration is very, very important because they are all going to be in environments where they have to rely on all the other senses except vision. So these as a physiotherapist, also this is your job to train the athletes for. It's not just you just look at an injury, you treat it and you're ready to go. This, as I said, this is an ongoing process, and this is where your knowledge of your neurophysiotherapy is going to come into work. Then intellectual impaired athletes are completely different because they come with movement difficulties along with intellectual disabilities. So to train them, you need to simplify the training program as well. Your injury management becomes very, very different because you have to work with them in a very different way because the process is going to be slow. The movements are going to be slow. So you have to have that amount of patience and you have to plan the program accordingly. So just because they are athletes with different abilities and you perceive that probably this is a limitation and your training program along with that limitation, the athlete is never going to achieve high performance. You have to break the barrier in your mind that you can push the athlete further. This is the biggest challenge because there is actually no work done on those lines. So to understand that, to understand for us as healthcare professionals that we can break the barrier and push the athlete more, that I think till we do it, the athlete also won't probably believe in themselves. So as I said, these are adaptive techniques and functional training. Again, movement training, balance, coordination, depending on impairments, which I just put in as broad terms. So even assessment, when you're doing physical assessments, your assessments have to be very, very tailored to that sport. Say for example, I have to do a flexibility assessment for a paraplegic patient. I can't do the flexibility assessment for the lower body. I want to do core strength, say push-up test for a paraplegic athlete. I can't do it because these paraplegic cannot do. We can set tests for them. There are no standards set yet. You have some standards, but then in our country, as Dr. Amay has put the standards and the research still needs to come up. these tests have to be modified. The visually impaired athlete may need people along with them to do the testing with them. For running, say, say a Cooper test, you need somebody to run with them just to do the Cooper test. So these modifications have to be put in place. You cannot say that they are physically disabled or they are impaired. You cannot do the test. Everything can be done. You can even do core tests. You can even do, say for a quadriplegic patient who cannot do any movement at all, you can do any continuous movement. You can ask them the maximum what they can do. They can lift their arm up, let them do that continuously. Test that. Check it again and again. It has to be set on their own standard, unfortunately, because you cannot compare exactly the impairments with others. So again, athletes you have to look at the prosthesis considerations, because using a prosthesis or not using a prosthesis will change the biomechanics of the body, the load distribution of the body. Your treatment plans will change, and also you have to look at how they are getting used to those prostheses, because more and more new prostheses are coming every day. There is a lot of gradations happening, but that doesn't mean that it can fit for all. So they need to get used to it, be a part of it, that where they understand how they can don it, doff it. They have to learn to balance along with it. It's an external equipment for them. They have to learn to say, people who are doing blade running, they call them blade runners. They something which you cannot even imagine that you could stand on. So the barriers are breaking, but then it still needs a lot of, again, a lot of sports science needs to work here. The wheelchairs are shifted from aluminium to carbon fiber now, so the wheelchair racing. So things are growing very fast. You have to understand spinal cord injuries again, very different, though again physical impairment, but very different from other physical impairments. So because their challenges will be very different, as Dr. Aditya has already taken. Again, their conditioning techniques will be very, very different. You need to understand how to transfer them, how to move them, how to have emergency protocols set in place, because more often than not, the physiotherapists are the first one at the point of contact with the athletes on ground. So you have to understand how to give first aid, how to take care of athletes, what to do in these kind of cases, what happens if there is an autonomic dysreflexia. So these are the things you have to educate yourself. Anybody who's working on ground with para athletes, I think they need to be educated on all this. And again, as I said, injury prevention to strength training, I think, is the key to everything. I think even an able-bodied, injured people, I think key to having a good quality of life is strength training, be it even elderly patients, be it anybody. I think strength training is the key. You have just put cerebral palsy because a lot of people do, because of the different movement patterns with cerebral palsy. It's very difficult to do, and a lot of spasticity is there. So strength training might not be the best choice of treatment or increasing the performance for them. But you have cerebral palsy patients and athletes who are benefiting from strength training. And strength training is one of the protocols which are used in their improving the movement patterns. Yes, you have to do things to improve the spasticity, relieve the spasticity also, but you have to train the balance, you have to train the coordination, you have to train the reflexes, and at the end of the day, strength training will work because they have to get up and run. So these are the, just want to play this one small video.
Right now, I'm with the captain of the Rajasthan Cerebral Palsy Football Club, and he is going for his first India CP football tournament. तो गगन भैया कैसे लग रहा है?
बहुत अच्छा लग रहा है, एक्साइटेड हूँ और नई टीम के साथ पहली बार टूर्नामेंट खेलने जा रहे हैं, तो मनोबल भी काफ़ी ऊपर हाई है, तो हमारी पूरी कोशिश रहेगी कि हम जीत कर आएँ इसको टूर्नामेंट को, और हमारी टीम भी बहुत अच्छी तरह परफॉर्म कर रही है।
तो पक्का जीत के आना।
Something which is very heartening to watch, and you can see the movement is different. Again, we cannot say this is abnormal. This is quite normal for them because they are playing on ground with those different movement patterns and challenges, balance challenges, proprioception challenges, and you're fighting against your own body. There is possibility of performing on ground. So
जरूर
this I will skip. I'll send this link to you because it's very interesting to watch this. Watch the athlete do strength training. Again, incorporating technology is again very important. There are a lot of accessibility problem in this country as well. So you need to probably find a solution where you can have telehealth consultations for such athletes. I think COVID has taught all. Even I think I never thought physiotherapy could be possible, online. But we had no choice at that point of time. We could do whatever is possible. Because of the accessibility issue, you try to make the other person more probably independent on them. There are also innovative experiments coming on. I can again share the videos, whatever I'm putting up. And again, as able-bodied athletes, you can use a lot of technologies to monitor the load, which is again very important for these athletes as well. So there are a lot of takeaways, I think, from the all three conversations and talks. But the main thing is, I think this lot research needs to be done. I feel we need to understand how to tailor your rehab, working on high performance, working in collaboration, all the sports science and healthcare professionals. I think that is the key to high performance in any part of sports, like whether it is able-bodied or para sports. But it's more so because you cannot function without, say, you need a nutritionist as well. You need a biomechanist. You need the orthotist. You need a podiatrist. You need everybody random, and you need a doctor. You need everybody. So you cannot say that you're the now. We all are, we are also arsenals for these athletes, I think, who are superheroes already before even, getting into the ground. So
Thank you, ma'am. Thank you for the talk.
thank you so much. Leaving you with this slide, which I think has explains this very well, what I and Dr. Amin, Dr. Sood want to convey to everybody. Thank you so much. Any questions if we have time? Thank you so much.
Now I invite Dr. Deora to taking the speaker. Sir, please, sir, come forward, sir. Dr. Amia, Dr. Aditya, please come forward. Yeah. Sir, please stay, sir. Dr. Nathkumar, sir, next, please, sir. Boris.
Thank you, everyone. I just want to end with a short story. It takes 30 seconds. There is one person who saw Dipti Jivanji, the first non-medalist in the international in the international event. So what happened? 400 meters, but
So Shvetashwari. 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 The one for you that what are the everyone please stand. Sir. Sorry. Sir, please. Just take seats, sir.
30 seconds, yeah. So, for me, what I'm the following for, just a few moments is each one. It's a personal request. She's an infected impaired athlete, and it was a small story, like when you are there running the 400 meters, 1,000, 3,000, 5,000 meters. The coaches is often about basic, right? So there are certain building and biomedics and all that. So she's in the case that we see events. She doesn't, she can't, and I will take it. But doctor looks designer. So how do you train students? So it's very interesting before the person that each side of them when she wants to comment. You know what was very for instruction were just three words. Run, lane, and run. Just that. There was nothing like take off after 10 meters, 20 meters, like you are counts for it. Three words. Hold her right in front, like just 5 centimeters away from her. 50, run, lane, that. We just kept repeating that again. So just a small story to end. That's what passport is all about.
Hello everyone. Now we continue with the talk. We have with us Professor Nimita Verma.
So let me introduce myself. Hello everyone. I'm Professor Nimisha Verma. I'm not a sports medicine expert. I'm an anesthesiologist who has specialized in pain management. So that pain management thing finds me here amongst you all. And my area of work is more in so I will be dealing with what my specialty is. Yeah, so something of interest. You see different kinds of pictures that we have in pain here. So what is common in all these? I would like to have the audience participating actively because we are very few of us. So what is there common in all of these patients here? They're all in pain, right? I'm a pain physician. I talk only about pain. So they're all in pain. But what is different? This lady who had just given birth was also in pain. The pain was not weird for her. Suddenly, the man was getting worried. Nothing, despite the pain he was facing. And then, again, my forte, most of it pain, is my area of interest. See, patients undergo surgeries for their benefit, but they do suffer from post-operative. Similarly, some pains like chest pain, cardiac, and acute abdominal pain, low back pain, with which all of you must have been familiar, CRPS pain, some chronic renal pain syndromes. So I thought emotional pain of separation, pain of loss of some nearby person who is not there, or cancer pain. These pains are all different.
the perception of these pains are very different from each other, although we all broadly classify them as pain. So in my next 15 minutes, I'll just try to help you join the dots about what you know and how one can see the specialty of pain management by summarizing what pain is, what are the types of pain, what are the factors affecting pain, what is the biopsychosocial model of pain, how do we assess as pain clinicians, how do we assess pain, and how do we manage pain by non-pharmacological, pharmacological, as well as interventional pain management techniques. So what is pain? Can anybody tell me? What is pain? That is a
Sensory, motor, all kind of.
Yeah, sir. The International Association of Study for Pain has defined pain in a very specific term, which is an unpleasant sensory or emotional experience associated with actual. So pain can occur either if the damage is or they will not sufficient to define pain. So after 40 years of research in pain, this small that associated with was added to the definition. Because there's so many types of pain which we cannot define with the previous definitions. So इस पूरे कहानी का शॉर्ट ये है कि हम लोगों को देखो मैसेज ये है कि पेन को पर्सनल एक्सपीरियंस की तरह we have to treat. It is not that what we define, it is what the patient defines. Then it cannot be inferred solely from the activity of the sensory neurons. The sensory neurons may be good, but the pain may still be there. Next, it is the individual learns the concept of pain throughout their life, and we have to accept what the person reports us. And verbal descriptors, as we are discussing para-Olympics, para-athletes, verbal descriptors are only one of the ways in which we can assess, or in which the patient can tell us how his pain is. So, coming on to what pain is, the basic physiology and sort of some physiological anatomy. There are four parts of pain transmission. One is transduction, in which the peripheral signals are transmitted from the receptors. They are converted into electrical impulses and sent to the nerves. From there, the nerves transmit this signal to the spinal cord dorsal horn. And from there, the pain is either modulated, it is transmitted up into the thalamus and into the somatosensory cortex, and doing this finally perceived. Okay, so whatever the periphery is doing, the perception is actually taking place in the brain. So that makes us to have two components of pain perception. One is sensory, the other one is affective. So this makes us classify pain into broadly two categories. One is the chronic pain and the other one is acute pain. And also based on various mechanisms like nociceptive pain, neuropathic pain, nociplastic pain, and mixed pain. So duration, based on the duration of pain, the pain may be acute, which is less than 4 weeks, or sometimes it is up to 3 months also. But for chronic pain to be chronic, it has to go beyond 3 months, which is the normal healing time of the body. Okay, so acute pain and chronic pain. As sports physicians, you must be dealing more with acute pain, but it is not uncommon to see this acute pain going on to become chronic pain if it is not treated well. So, based on the mechanisms of pain, why we are discussing mechanisms? Because if we know the mechanism of pain, then only we will be able to treat it. We have sensory and affective components and neuromodulation also. So at every component, every neurotransmitter is different which is acting. So it's very important to know the mechanism of pain. For example, acute pain is also known as nociceptive pain. So कुछ idea nociceptive? क्या nociceptive pain क्या होता है? Yeah, any pain which is by the activation of the nociceptors. Our whole body is full of receptors everywhere. The free nerve endings, A, delta, and C fibers. So if those fibers are activated by an external stimuli, that is nociceptive pain or which is acute in nature, like the pain of childbirth, like acute post-operative pain, like inflammatory pain, post-injury, post-burn. All these pains are acute nociceptive pain, and this is a very good pain. That is in nature, it is our body's alarm system. It tells us where there is harm. We will not go, if we burn our finger, we are not going to put our hands again into the fire. That is the nature, that is the good part of pain. So this pain which builds the memory of the pain. In terms of pain management, we see that whenever if the patient has a previous history of bad treatment of pain, even in their childhood, they will not respond to medications, or they develop adaptive mechanisms in a way that they will be poor treatment subjects when they grow up also. So this acute pain is building a memory of pain which later on turns into a difficult pain or an easy pain. Then there comes the chronic pain. Remember, acute pain was adaptive, was good, it was preventive. But what about chronic pain? Any idea? It is the maladaptive part of pain. It does not serve any purpose. It is just the misfiring of the nerves, the neurotransmitters are confused, the brain is confused, and the pain is going on and on and on. The stimulus may or may not be there. So it is not protected in nature. It is due to nervous system reprogramming, and there is neuromodulation of the pathway. So, and there are many factors which affect these kind of pains. Although acute and chronic both are affected by psychological, physiological factors. Like if we talk about disease, if the disease progresses, the pain will aggravate. If we talk about sleep, if the patient does not sleep well, any type of pain will be aggravated. Okay. So anxiety, despair, if all these factors will increase the type of pain. Similarly, a compassionate listener by the side of the patient, no matter how intense the patient's pain is, if you listen to the patient, they will relax somehow. That is the beauty of the affective component of pain. It proceeds all the time over the sensory. So, so many factors which affect the pain perception, we should say. This brings us to think what type of understanding should we develop for the pain. There is biology of pain, which in our senses, in sports medicine, if there is an injury, that is the biology. If there is a tendon injury or a muscle injury, but there is a psychology of the patient also, which is why is it, what has harmed, what are the effects, if the patient has this memory of pain, or if he's catastrophizing, if there is a stress or he's unable to cope, all these things will aggravate the pre-existing biology of the pain also. And then there is the social factors also, which we all are very well aware of. If that pain is limiting his social activities, then definitely that will aggravate the pain. Okay. A very interesting example, because I do more of cancer pain. We had one patient with cancer, sarcoma, who was amputated. And he kept on coming to us again and again and again because he was amputated. And we did not understand, we did whatever best we could. But once we made him a disability certificate, his pain was controlled, because then he could get a wheelchair, he could get that car, and he could use that scooter and all. So that was a very big relief. So that was the psycho-social aspect of pain I'm talking. So yeah. Yeah, when we come to there is another concept like existential pain, why the pain is. This is more common with chronic diseases, not with acute pain, and more so with cancer pain. And when we come to the assessment of pain, we have to understand that whenever we are treating pain, you have to address all the four components of pain. Treating one will not lead us to help the patient be to his full capacity. So coming on to assessment, it has already been discussed, and you must already be knowing all this. History, examination, pain scales, and investigations. But
Take home message all the time. If we fail to assess, we fail to treat. So assessment of pain is very important. How do we assess? Three important questions. How much does it hurt? How much the patient feel distressed with this pain? And third is, how does it interfere with the patient's life? Like for an athlete who, I am not a sports person, but for an athlete who has injured his ankle, then his distress would be much more if the race is nearby. How much time do I have now? Yes. Finish? Yes. Oh my God. So, I told that my presentation is too long. So this is all the assessment of pain, the types of pain, investigations. I'll just brush on the management of pain. And the non-pharmacological part, the pharmacological part we all know, we follow the WHO pain ladder. I will focus upon the interventional part of pain management. So interventions are a group of minor major surgical procedures that can be used to control pain and chronic painful conditions. They can be percutaneous or minimally invasive. And kahan use करेंगे interventions? Only in resistant pain. Why? Because it will improve the quality of life and it will decrease the dose of pain medications. And in turn, it will decrease the amount of immunosuppression that comes with pain medication doses. So, focus of mind of image-guided interventions, which is also precision medicine. Interventional pain management techniques can be broadly classified into neuroablation, regenerative therapies, and neuromodulation. Ablation can be chemical, thermal, or surgical. Modulation can be through drugs and also through electrical nerve stimulation. Regenerative therapies is eluted on the block, and we use orthobiologics as well as gene therapy for regenerative medicine. There are many lectures, and they must have been dealt in detail. I would just like to connect the dots between. These are the long list of interventional pain procedures which you do for chronic pain. They're broadly categorized into sympathetic pain, sympathetic neurolysis, peripheral nerve blocks, neuraxial blocks, percutaneous cordotomies, spinal cord stimulation, musculocutaneous injections, which you all are must be quite comfortable with, and joint injections. Then various techniques, ozone, radiofrequency, various drugs. Keep on pushing the button. Okay. That's it. Should I stop here? So much to talk.
If you have any question, you can ask one question.
Yeah, the whole thing is that will they get the presentation? Will they get the presentation?
So yeah, they will get the presentation.
Yeah, please go through it. My message is just the holistic approach to pain management, which is very important. It is the assessment, reassessment of pain, which is very important in the management of pain. Remember, if we fail to assess, we fail to treat. The goal of pain management is optimum management with minimum side effects. And the treatment, has to be tailored to individual needs. Interventional pain management is a part of the armamentarium, and it helps in effective management of pain, minimizing the side effects. And finally, we should always remember that pain control is all about the triumph of the mind over the body. As you can see that this US gymnast, Kerry Strug, won the Olympic gold medal in 1996 with a sprained ankle. So anything is possible if the mind is okay. Thank you so much.
Ship and films.
So there have been a complete fellowship.
Sir,
Grab the presentation.
sure, sir, sure, sure.
I want to go through it indeed.
Yeah, please do.
Thank you, ma'am. Thank you.
You can have my number and any query you can always.
Let's take it.
Yeah. Next.
PRP. Yes, here. PRP.
Basic has increases. ठीक है सर अच्छा सर ठीक है ये इसमें से
The senior sports physician and clinical sir. So, sir, over to you now.
Thank you so much. I would like to, it was always my dream to come to BHU, a beautiful organization. And thank you for the organizers for giving me the opportunity. So without wasting any time, I'll just connect with the previous speaker. In one of the pain management thing, he had focused on orthobiologics and focused into PRP. So we'll just take that component of the interventional management. I do work PRPs in my clinical practice, about 20 to 30 per month. So what are orthobiologics? These are the autologous allogenic substances which help in healing of fractures, tendons, muscles, bones, or ligaments. These can be true autologous or allogenic. And what we are going to talk about today regarding PRP is basically the autologous sources of blood-derived substances. So these can be three. These can be blood-derived substances. These can be stem cell containing products. So these can be extracellular matrices. So we will only talk about the blood derived substances like PRP and autologous conditioned plasma today. Recently, I tried using allogenic stem cells also. They have come in the market. There's a company called ISSEM which has launched it. They derived 3 million cells, stem cells from 3 different allogenic sources, 3 different cadavers, and then they prepare this under those, radiological and desensitization procedures, and it's ready for use. Immediately, it can be injected, and it has been recommended for grade 2 and grade 3 osteoarthritis by the DGCA and the USFDA. It's available in the market now. We have tried using it recently, but today I'll talk only about the platelet-rich plasma, that is the autologous blood-derived products. So this is it. Body's first response to any injury is the platelets and the growth factors. They come to the site and they start a cascade of healing. So we know how important the platelets and growth factors are to the healing cascade. Now this is the healing cascade. Initially the coagulation, then the inflammation. You have macrophages, neutrophils all coming in, fibroblast activity starts in tissue granulation, collagen synthesis, then the wound contraction, epithelialization, remodeling, and healing. Ultimately, the total healing takes place. These are the various growth factors that are released from platelets, alpha and beta granules. You have platelet-derived growth factors, transforming growth beta factor, TSG alpha, which we call it, vascular endothelial growth factors, epidermal growth factors, fibroblast growth factors, all of them. And if you look at the biological functions, including mitogenesis of the mesenchymal stem cells, it stimulates the endothelial chemotactis, angiogenesis, collagen secretion. Every stage of healing process, these growth factors are able to modulate. Now, our special indications are Golfo pelvo, penicillin, rotator cuff tendinopathies,
Postprandial strains, partial thickness phase, low grade, type 1-2 slab, Achilles tendon, technique, muscular strength conjunction. We are using only partial grade tears in Achilles. Recently, I had 2 cases where this failed. So I was not willing to do it. Partial low grade tears. I advised the patient that you may not get good response to kabaddi players. They insisted on giving me, asking me to do PRP. I said, okay, I'll do it for them. But we did not get decent results. In those cases, we ultimately had to get surgery done. So you should know how to choose your cases. Decurvents, you can use MCL, LPL strains, sacroiliac joint arthropathy, and patellar tendinitis. You can use in grade 1 and 2 meniscal, but it should not have any flap or vertical handle tear. No history of locking. Grade 1 and 2 cartilage lesions, chondromalacia, osteoarthritis, grade 2, 3, and ACL, PCL strains, grade 1 and 2 injuries. In muscular, you can use it in hamstrings, gastroc. I have used a lot in hamstring and gastrocs, but whenever you are using some in muscular area, the area where you got strain, grade 1, 2, you have to make a, what do you call it, a grid, mark some dots, and you have to get 0.3 to 0.4 with a shallow needle, 26 number needle, inject up to 0.5 centimeter in multiple areas. So there is no single point of injection, you have to cover the entire area. In surgical setting also, they are used to enhance the healing of the rotator cuff repair, in ACL repair, meniscal repair as fibrin clot or PRP, in ACL for maturation of the graft, and you can also augment Achilles tendon repair and MCL repair with PRP and fibrin clots. Now, if you look at these studies, now there are some controversial studies also available which say that PRP is equivocal plus minus, not very strong evidence. So I have some evidences available. This was treatment of partial rotator cuff with ultrasound platelet replacement. You can see the results. So the conclusion was it was an effective procedure that leads to significant decrease in pain, improvement in shoulder functions, much cost effective, less problematic. And what is the advantage of PRP is that it's minimally invasive, or no side effect. It can be done in OPD basis. And yes, cost sometimes is a factor. Muscles, ligaments, and tendons. Percutaneous injection of PRP for intrasubcutaneous meniscal lesions. There was significant improvement, and it was sustained over a period of 2-3 years, and even the MRI correlation was given. So there was a level of evidence in this was level 4. Similarly, outcomes of PRP for plantar fasciopathy or plantar fasciitis. Here also we had decent results. There was another publication of case series of ultrasound guided PRP for SI joint function. You can see the conclusion again here. So we have a lot of evidence available. We want to look for the evidence. So if you want to look the other way, you'll find the literature to support that also. So how do we prepare it? See, the baseline concentration is about 1 to 2 lakh numbers of PRP, and we want to have a concentration which is about 5 to 9 times of the baseline PRP. We want to have a good concentrate so that we can give maximum amount of growth factors and the alpha beta granules so that maximum growth factors are released and maximum healing takes place. We'll go through the process in detail. This is the sports medicine classification of PRP, where you have either platelet rich or platelet poor, activated or non-activated, and the platelet concentration always remains more than 5 times. So we have 2 methods, open method and closed methods. I always use the closed method, which is on that side of the slide. Then the closed method is the open method. In the open method, this time when we use, we are not having any significant results. And what is the issue? The quality of PRP itself is probably low. And sometimes there was the RBCs would translate up and down, and they will lead to reddish discoloration. So this is the basic science. 2.5 times the baseline with ACDA, 30 ml current strength, 30 ml of whole blood from antecomital vein. Platelet degranulation, which releases growth factors. PRP is earlier in 2011, it was removed from the ban by WADA, and now PRP through all routes is available for use. So individual growth factors from any other source remain prohibited.
These are the commercial kits. I'm using a Tricell kit, which is a double chamber kit, closed system. Leukocyte filter. Osteoarthritis of the knees, we use a leukocyte poor PRP. So this is a filter responsibility to attach the filter. And then with 6 million leukocytes. So these are the routine steps of PRP. Double spin, I told you, after taking these are the same steps we talked about. I'll just go to the conclusion now. This is our dosage and frequency. 3 injections, 4 to 6 weeks apart, about 5 to 7 ml. Recently, the concept of super physiological doses has come in. So we were injecting a higher volume and we're taking higher blood, like 50 ml. Our threat has come up with a 50 ml chamber. So we have started using that now. So that gives you more PRP. So we are injecting 8 to 10 ml now, especially in bigger joints, like shoulder and knee. In our clinical practice, I'm giving only 2 because of the constraints of money. Leukocyte poor PRP plus hyaluronic acid. These two together inject in osteoarthritis, especially in the knees. These are the different shades you will get. The best quality shade which I find is on the left side. That we consider as a good quality PRP. Post PRP instructions, sterile dressing, no eyes or oil pack for 72 hours, no smoking, no alcohol, no NSAIDs 2 weeks, no blood thinners, restricted use of infected area for some time, order isometric after 72 hours, and rehab and strengthening to follow after 2 weeks. Thank you so much. Any questions?
I will ask Dr. Kavita ma'am to facilitate Dr. Chakra's teacher.
Yeah.
one person.
Yeah.
Just one question. How injections do you give in one? So do you just one injection and wait it out for?
So I see, technically we are supposed to give one of the slides I said,
Yeah.
3 injections, 4 to 6 weeks apart. But when with clinical practice, we're doing only twice. Only twice. And sometimes in osteoarthritis grade 2, grade 3, when I have mixed PRP with HA, I don't have the need to give a skin injection because the results are good. So you have to keep the patient consideration also in mind. Not costly, 18,000 PRP kit, 3 to 4,000 in the procedure charges. So that also in clinical practice, you have to keep things a little different.
Thank you so much, sir.
We are moving for an exam money here and Catholic. Person from Department of Physiology, PhD.
Good afternoon, everyone. Dr. Rajesh Kumar Meena, I'm proxy coordinator. He is a professor in the Department of Anesthesiology. We both are in the same department. And he is in charge of skill center. And we conduct lots of workshops on advanced trauma life support and basic life support and cardiac life support at skill centers. I will request the audience to please come closer. So you don't need the screen for the next lecture. Please come and comment. It's an interactive session. Anybody has ever witnessed cardiac emergency? Ten minutes. Okay, There is a infection जिसको दिल का दौरा कहते हैं. How do they respond to that? And what are the signs and symptoms? There is a acute chest pain. So whenever we are talking about some athletic event, some sports event, these kind of cardiac emergency can happen anytime. And we have already done a workshop on BLS. And the management and the preparation are basically on the same lines. Whenever there is a cardiac arrest, what are the signs? There is a chest pain, but in today's scenarios, there are mainly atypical signs and symptoms we need to care of. And there are special population group like geriatric patient, pediatric patient, and a pregnant patient in athlete, of course. Because in athlete, the signs and symptoms may be masked. So the signs and symptoms can be a GI upset, can be a diaphoresis, can be just a simple ghabrahat, okay, can be simple respiration. What I am trying to emphasize on ki whenever there are such kind of symptoms, these are present, or whenever somebody complains of these, we should keep high index of suspicion that it can be myocardial infarction, though it may not be. But if it is a myocardial infarction and you have missed the diagnosis, you are going to lose the life. So always keep the high index of suspicion. So there can be sudden cardiac arrest in the hospital, out of the hospital, on the sports field, or anywhere else also. So what are the emergency planning that we are supposed to do? So emergency planning, we should have a plan. If there is a cardiac arrest, what we are going to do? And this plan has to be before organizing any event. We should sit down, we should sit together, and we should find out कि अगर कोई cardiac event होती है तो how we should approach. So we should have an emergency plan. We should have a long-term plan. Though it is written at least once annually, but I would suggest those mock drills should be very frequent, like 3 months, once in month. Why? Because it has always been said that practice makes everyone perfect, not only math, but also everybody else. So practice is very important. You have a plan, you will conduct a mock drill, and then you will find out where are the loopholes in your plan. So we are organizing an event. We should have who will be participating, what are the chances, what event can occur. And we are organizing any event, we should emphasize on one very, very, very important thing, that there should be BLS provider. BLS provider, basic life support provider should be there. We have many incidences that has occurred in gym nowadays. And but till date, we go to a gym and we ask, do you have a BLS certified people at your gym? The answer will be no. Why? Still date we are not able to change this. Why? Because we lack awareness over this matter. So we need to create that awareness. So whenever we are organizing an event, we should have a BLS certified law people who can provide basic life support. Then what will be there on the emergency medical team? What responders should be identified. Communication should be activated. How you will communicate with the emergency medical team or the rapid response team. Then transportation route की हम मरीज को कहाँ से लेके जाएंगे, and how that particular patient or a particular victim will reach to the hospital. Then other emergency equipment should be available. A written emergency plan should be there. Regular review and rehearsal, as I have already discussed. So something happens on the field. What the primary assessment? In primary assessment, we always go like A, B, C, D, E. A is for airway, whether the patient's airway is open or not, whether the patient is breathing or not. Then B, we look for the breathing, chest rises there or not, abdominal movement is there or not. Then we check for the pulse. That's how we assess the patient. This is on the field when somebody collapses. So, if there is a collapse on the field, we'll rush and we'll check for the scene safety. Then we'll assess. We'll check for the responsiveness. First of all, we'll check for the responsiveness. And if the patient or somebody who has collapsed is not responding, then we should always activate the emergency response team, which can be your people who are trained into the BLS, carrying all the the necessary resuscitation equipment, or it can be somebody who you can call. But it's better to have people, train people when we are organizing an event. So train people. So those will be the first responder, and those will be the emergency team. So the team carries the AED, automated external defibrillator. Then we have AMBU bag, and we see a collapse. We check for responsiveness. There is no responsiveness. We activate the emergency response team. Then we check for the pulse. We check for the respiration. We palpate the pulse. Pulse is not there. We check for the respiration. We look for chest rise if it is there or not. If the chest rise is also not there, pulse is also not there. Then we start the BLS, that is the basic life support, which starts with the cardiac compression and airway management. For airway management, we need to give jaw thrust, which is just simply putting your hand on the jaw, get up, and then chin lift and jaw thrust to open the airway of the patient. And then this is the chain of survival. Then the chain of survival, you activate your emergency medical team. You start with the chest compression. Then you give the defibrillation, which is given by AED, which is the automated external defibrillator device. Then while you're resuscitating a victim, emergency medical teams come. They take over the resuscitation from whosoever is resuscitating and take the patient to the designated hospital where the cardiac care facility is available. So this is how the chain of survival is activated, and this is how the chain of survival works. Now, if we are on the field and we are supposed to give the cardiac compression, it is the 100 to 120 chest compressions we are supposed to give. And we give 30 compression and 2 ventilation. By ventilation, I mean we give breath to the victim who is on the field by opening his or her mouth and giving 1 breath over 1 second. So this is how we do the chest compression, and this is how we give the ventilation. The ratio has to be 30:2, 30 chest compressions and 2 breath, 2 ventilation. And depth should be anterior 1/3. We should be able to compress the anterior 1/3 of the chest. Compressions have to be given on the lower part of the sternum in the midline. So this is where you keep the hand. This is where you start giving the compressions. When giving the compressions, we need to keep in mind that 100 to 120 chest compression has to be given, and there should be a cycle of 2 minutes. AED should be available as soon as available. So we need to give the high quality chest compression, and as I've said, anterior 1/3 of the AP diameter. Questions would be better. Any questions?
Only quick question, you can take one question. Dr. Manish Pariyar, senior professor from Jaipur, our sports medicine. Please come, sir. Please come forward.
Sir was there in the BLS workshop.
Yes, he is everywhere, ma'am.
Years of age, hypertrophic cardiomyopathy remains the
Sir,
cause of death. So how the approach should be different, or in the same way, or little bit variation we needed to?
sir, HSCM identify करने का कोई तरीका नहीं है because it is present there since birth, and symptoms you usually don't get symptoms unless since the name is hypertrophic cardiomyopathy, and you diagnose this HSCM suddenly. There is no way to diagnose. Unless there are symptoms, we don't go to hospitals, do we? And at the age of 35, we don't even suspect that something is going to happen, some cardiac event is going to happen. But if we are talking about athletes, we always do screening. So in that screening, if you find that HSCM is there, that person should not be there on the field first thing. second thing, even if it is HSCM or even if it is some other cardiac event, the management remains the same. If there is no pulse, as I said in the workshop also, if there is no pulse, no respiration, first of all, we need to restart that heart which has stopped suddenly. And how do we restart that heart? By giving chest compressions and by giving the defibrillation. Once we have resuscitated, then we can further move on to the workup of the patient.
Thank you very much, ma'am, for your presentation. I ask now Kiran sir to facilitate the ma'am, please. Thank you, ma'am. Kiran sir, now we'll proceed with your presentation. Notes. पेन ड्राइव कर रहा किसी और का पेन ड्राइव है हाँ हम डाल
So, good afternoon, everybody. I am Dr. Kiran Kulkarni, sports medicine doctor and chairman of medical committee on India Football Federation. So, I will be speaking to you on anti-doping education. So, how many of you attended anti-doping education program in this? So, I think it will be interesting. And beyond that, high time our guts are calling to the lunch hour. So be with me so that I can take you through what the process of anti-doping education is, because I think this is the only lecture in these 2 days of workshop which is on anti-doping. Thank you. So now, thing is, I have 2 sections in my presentation because first section will be I'll be just going through about what anti-doping is basically a theoretical aspect. Beyond that, what I'll do is I'll just take you through how the dope sample collection procedure is done, because this is very important for all of you to know how the process is, because we just hear in our newspapers that this person has been caught, he has been caught, sample A is tested, sample B is tested, he is sanctioned for 4 years. But how actually that happened, we'll just go through in quick succession slides. So basically, I'll be speaking on definition, relevance to all of us here in this conference, then control activities, codes, addons and addum, TUE, prohibited substance. These are few, basically a bird's eye view. So again, relevance to doping because it is a part of sports medicine, dealing with conservative aspects of sports medicine injuries along with the know-hows. And basically, these are the various branches of sports medicine. And of course, sports pharmacology and doping are really a relevant aspect of this. World Anti-Doping Agency again established in 1999 a role to develop, harmonize and coordinate all anti-doping activities in this world. So there are about certain codes and international standards. India was one of the countries who signed this WADA code in about 2000, because without the government signing this WADA code, will not be able to participate in any international sporting activities. So these are the 8 international standards and 10 non-mandatory guidelines. Okay. IDEM is anti-doping education and learning platform. You can all access the World Anti-Doping Agency and other one is ADAMS. Okay. So this is the anti-doping administration and management system and it's a digital tool. If you can just go through these two of the World Anti-Doping Agency website, you will definitely get through this. And the old definition was, like administration or use of pharmacological substance foreign to the body, sole purpose of increasing performance. Okay, now things have changed. Till 2023, anti-doping rule violations were, the presence of a banned substance, use of a banned substance, refusal to give a sample, tampering with the sample, non-compliance, not cooperating with the doping control officers, administration, that is giving doping drugs to the athletes, possession, having doping drugs, and trafficking, drug trafficking, all these were considered. But now another few of them have been added from 1st of January 2024. Okay, so that is, these are now we have 11. Okay, another 2 have been added to this. So activities again, like in this workshop and conference, we are educating you regarding doping control as well as about banned substance as well as about how the dope sample collection procedures are done. So these are the awareness programs which we did for Indian Medical Association, Dharwad. Again, physical education, through research activities, and again, this is educational programs we are doing. I think there's some problem not responding. Can you please help me with this slide? So ADDR is anti-doping rule violation. Sorry for the technical glitch. Please hang on.
How will you change? Things like
हैवी होगा सर, इसलिए नहीं चाहिए। जब ज्यादा स्लाइड्स तक ये हैवी होगा इसलिए डायरेक्ट कटर पे चलाने में इशू होता है ऐसे। आपको कॉपी करो। हाँ, ये सिस्टम को भी सपोर्ट नहीं करता है। ये आयरस बनारस ये
What happened? The fender over. Somebody took my phone. Yes, yes, that is over. That many of that. It is very good. इधर से आगे नहीं जा रहा। इधर से क्यों स्टक हो रहा है? हो सकता है सर आप इस सिस्टम से काफी ज्यादा
नहीं नहीं है इधर 36 सब सीधी है सीधी है नहीं
इसमें से ही कर दो ना।
करो 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 ट्राई करो बंद होता है।
But team, is it mandatory that the team lead has to be signed by the same doctor who is prescribing the medicines, or a different doctor can?
No. Always better. Always better and the same doctor.
Once I faced a scenario where the athlete was prescribed certain doping medications for some lung infection, but the doctor was a private practitioner and they refused. And that is actually the one things like so here. So start. No.
Anti-doping agency doesn't want to catch you and put you behind bars or sanction you or something like that. We want to show that that you have a fair playing field. Can't dope and you come out run the race and just defeat others by making.
You can proceed with the presentation, sir.
last question is the last.
Okay, sir. Next. Okay. Yeah. Now coming just the dirty track of Indian sports. This is how we are like Olympic history. Earlier, before 2023, we were on third place. We were bronze medalists in highest number of doping cases, and we had 5 Indian athletes who failed the drug test in about 5 years' time. Imagine we had in school games, high school children, failed 8 drugs, and recently, just about 1 month back, we had about 8 boys less than age 15 who were found positive for performance enhancing drugs. So NADA is definitely they are doing an excellent work. Maybe 21, 22, they have done a lot of tests. Even our parliament also passed national anti-doping bill in 23. But we in India are ranked number 1 in the world at this moment among the highest positive cases at present. So India top in this highest number of cases. See, like we had about 4,000 cases and 3.26 total number of cases positive in India. Next is South Africa, Thailand, USA, Qatar. India has a dubious distinction. Now we have even overtaken Russia. Earlier, Russia was number 1. Why doping in different sports? Basically because of the strength and speed, endurance, sports which demand concentration, and definitely doping is possible in every sport. Infamous doping offenders, Ben Johnson to CJ Hunter, Lance Armstrong, Maradona, everybody. So what are these prohibited methods, 2024? So there are, prohibited substance groups, methods, substance groups in certain sports and specified substances. So in this, specified substances and prohibited group, the first one which are marked red are the highest abuse, like anabolic agents, diuretics and masking agents, and glucocorticosteroids. Anabolic agents because they are all testosterone derivatives, male hormone with anabolic effect and stronger than that of testosterone because, the increased muscle mass and strength, affect hormone balance and metabolism, prevent overtraining, early recovery and anabolism. That is why everybody is behind these steroids. So these are the various side effects, right from head to toe, you have these side effects. So can you say male, female, even I think most of our females also won't have 6 packs like this. So this is one, a poster. You can just, it is approved by World Anti-Doping Agency to be circulated among all our educational institutes. So again, these are the various side effects, absolute negative effects in any sport you take for that matter. Real side effects happen. That is the reason why steroids are almost, on the hit list of banned substances. So German shot put champion, gets a sex change because in 1970s, East German athletes were fed with steroids, and they were told to these athletes that these are vitamins, minerals and vitamins, but they were given these, So in about 4 years of Olympic year from 1970 to 1976, from 0 medals, they won about 36 medals in 1976 Montreal Olympics. So prohibited methods at all times: manipulation of blood and its components, chemical and physical manipulation, gene and cell doping. So again, we have this oxygen transportation, blood doping, and we have this oxygen, artificial oxygen transporters or liberators. Basically, side effects is risk of blood transfusion, allergic reactions, coagulation disorders, and of course now sudden deaths. And along with blood risk of blood transfusion, okay. So chemical and physical manipulation, tampering of urine, addition of a chemical substance like propan acid, replacement of urine, catheterization, use of condoms, and Intravenous infusion or injections of more than 100 ml in 12-hour period, except for those legitimately receive the course of hospital administration or clinical investigation. So now coming to this gene and cell doping. So gene doping is an outgrowth of gene doping, gene therapy. It involves insertion of DNA for the purpose of enhancing athletic performance. So definition, we have this definition of gene therapy. So this might be the gene dope. Well, see the size, human being is standing next to the almost about 5 to 8 times the size. What about this? Okay. Effects of gene doping. Maybe in a few years' time, we may see the person on the extreme right side, What about this? How many of you have seen this movie Hulk? So gene therapy is actually a medical therapy which is in research now. And of course, cell therapy, gene therapy is going on in medical treatment. Of course, illegal performance enhancement also you have got, that is gene doping. And third one is gene enhancement, that is we are heading towards destruction. So coming to the specified substances, and it is unintentional anti-doping violation, especially if anybody takes a cough syrup containing pseudoephedrine or terbutaline or salbutamol, they may be put in for a stimulant, and sanction can happen somewhere in between 6 months to 2 years. So Jyoti Chand gets a 4-year doping ban because her physio advised medications without the consultation of the doctor. Okay. So prohibited substance, alcohol, beta blocker, that is medicines we use for blood pressure, hypertension, and coming to tramadol is banned from 1st January 2024. Now we cannot give tramadol to these athletes. That's the reason why you always say, go for nutritional supplements, but be careful. Ayurveda, homeopathy, Unani, local, we call them as Gauti, local herbal medications, be careful, because the fact is the ingredients are unknown, no effective product labeling, and not recognized by World Anti-Doping Agency, because World Anti-Doping Agency recognized medicines of modern medicine, that is allopathic medications. So because they also contain, at one given point of time, these ATP injections were very popular among sprinters and jumpers and throwers, came from Russian pharma, and they had a presence of strychnine. Even this Jack 3D, very popular medication, like most of the, because it contains DHMA, okay, another banned substance. So now coming to this QE, therapeutic use exemption form, grant, somebody was asking me about QE, permitting the use of prohibited substance in the prohibited list. So minimum 3 weeks before you have to apply for the therapeutic use exemption. If it is in the competition, then there is something called as a retroactive TUE. Okay. So if you are giving in the competition, you can still apply to the anti-doping agency or the relevant doping control officer and inform them that it was important for the athlete to be given. Okay. So we call it as a retroactive TUE. So in this website, you can always get everything about what I'm just speaking about. So coming to the doping control, so we have this urine and blood tests. Both urine and blood tests are done. So 3 types of doping tests are conducted. One in competition testing, other is out of competition testing, that is 365 days, and third one is target testing. Now target testing, complaint, overnight enhancement of performance. So we call something as target testing. Then whereabouts information, very important, because athletes provide their whereabouts information every quarterly to the National Anti-Doping Agency. Cricketers were left off. Latest on the list is Hima Das, just a couple of months back, she did not provide her whereabouts. So she was, anti-doping rule violation. Okay. So just, running through what the dope sample collection procedure is. So this is how, officer, doping control officers, and they are
appointed, and this is just at the World Military Games in Hyderabad. This is a football team where doping marshals are notifying the selected athletes, and they have been escorted to the doping control room. You can see the 2 slides. After notification, they are being escorted to the doping control station. So international decisions during the Commonwealth Games, Asian Champions League, doping control squad, again in BCCI anti-doping team. So now the athlete is being notified in one of the national games. She won a gold medal. Chevron is notifying her that you have been selected. Athletes to the doping control station. This was in the doping control station, Doha Asian Games. Then why I am showing this slide is because any high profile athlete doesn't matter. He has to come to the doping control station. So when the athlete comes to the doping control station, he reports there with his accreditation ID card. The doping control officer checks his accreditation that the right athlete has come in. So these are what we call it as urine sample collection. Once the athlete comes into the doping control station, he will not go out. So in about 60 minutes time, athlete has about 60 minutes time to come into the doping control station. Till that time, he will be under the watchful eyes of the chevron. Okay, after the notification. So once the athlete is ready to pass urine sample, a minimum of about 90 ml of urine has to be passed. Okay, and once he is ready, athlete is ready, he comes to the doping control officer and he collects this urine collection containers, and he goes to the toilet. Male doping control officer accompanies, female goes with female, and the athlete has to lift his t-shirt up to the chest level and to the knee level before passing urine, and it should be in the direct vision of the doping control officer when an athlete is passing, male or female, in the direct vision. So once the athlete passes the urine sample, okay, do you want to see the next slide of what happens next? Direct vision. Okay, we'll not show this, but imagine that the athlete is in direct vision of the doping control officer. Okay, so once he completes giving the 90 ml of urine sample, then he comes and sits. See, you can see the athlete with the urine sample there. Can you see that urine sample? Athlete, chevron is there and the doping control officer. And you can now see the urine. And what the athlete does is, you can see those white boxes. They are called as Berlinger kits. They are Berlinger kits. And the athlete selects these Berlinger kits. Once he selects the Berlinger kit, he opens it. And once he opens that, he has these 2 bottles. One red and one is blue. Bottle A, that is sample A, and sample B. Okay, that athlete has, I think, about 120 ml of urine now. So once he opens up, checks the numbers. Now the athlete divides in sample A and sample B. In sample B, he pours about 30 ml. In sample A, he pours about 60 ml. Why 60 ml in sample A? Because over 500 banned substances are checked in about 60 ml of urine. If the athlete is found positive in any substance, if he is found positive for stanzolol in sample A, then athlete is called to check sample B, which contains the same urine which he has put in. Okay. So now once the athlete has completed 30 ml in B and 60 ml in sample A, he himself handles everything, and he is closing the lady is closing the sealing the samples. Okay. Once the samples are sealed, 1 or 2 ml is left over in that urine thing, and we check the specific gravity. Specific gravity is required 1.005 to 1.050. This is the standard range. If it is below 1.005, beyond 1.050, then the athlete has to repeat the sample, because it is not a good sample to be sent to the laboratory. So once he gives a proper sample, 5 minutes, not 5 minutes, maybe 2 minutes. I have another 10 slides. I just skipped. Almost we are at the end. So once the athlete completes, sampling the and closure of the bottles, now he fills the doping control form. And athlete also checks the doping control form, whether the number he has written
on the form as well on his bottle are all correct. So once the athlete signs the form, and before signing, what the athlete does is he will seal the samples all by himself. So athlete is sealing the samples. So this is what we call it as a Berg or Berlinger kit. So this is the doping control form. Athlete is the last person to sign the form. Once the athlete signs the form, then it is finished. Then we do not do any changes on the form. So that is the reason, even before the athlete signs the form, the doping controller has to recheck on the each column of what he has written. Okay. So now once this has been done, now we send this sealed sample to the laboratory. The NDTL, National Dope Testing Laboratory in India, is in New Delhi, Jawaharlal Nehru Stadium. Okay. We send it to NDTL in New Delhi. So if at all in doping, good news is no news from the doping control laboratory. Good news is you do not hear anything from the doping control. Good news is no news. If you get any news, means that's something wrong. Okay. So once a sample there is any positive substance, then the doping control laboratory will send information to World Anti-Doping Agency, to your federation, okay, and the National Anti-Doping Agency. So you have about 3 weeks time to respond that whether you have you agree to that you have taken any banned substance or you don't agree. So if you don't agree, then you come back to the doping control station. Then there is you are taken back to the doping control laboratory to check that sample B. Okay, sample B is analyzed in presence of the athlete. So once the sample B is analyzed, two things can happen. What are the two things which can happen? One is sure shot 99.99%, whatever is present in sample A will be present in sample B also. So if it is again present, then he will be sanctioned according to the banned substance, and like stimulants, basic, 6 months to 2 years, steroids, 4 years. So it depends. So what happens here is like think that if the sample B comes out to be negative, sample A is positive, sample B is negative, then what happens? Anybody? Sample A is positive, sample B is negative. Then the athlete is left scot free. Athlete is left. Athlete is not sanctioned. But the doping control laboratory will taken into task by World Anti-Doping Agency, because sample A is positive, then sample B is negative. Okay. Then there will be scrutiny. Then they will call the doping control officer whether there was a change in sample A, sample B, all these things will be checked. It will be under investigation. Okay. Basically, thing is clean sport. 1988 Olympic Games, Carl Lewis and Ben Johnson. Carl Lewis, just this poster itself is enough to show the clean sport. Everything in anti-doping started in 1988. Everything started since then. All eyes opened. World Anti-Doping Agency, all the doctors, they started. This was the time. So basically, clean sport. Most 99% of all athletes are clear, but I am afraid in India, 1% of controlled athletes have used prohibited substance. Therefore, 99% are clean. An athlete is clean until proven otherwise. So final say is clean sport is all. We stand for no doping. That's the reason play through World Anti-Doping Agency, National Anti-Doping Agency, and of course Indian Society for Sports and Exercise Medicine, ISSEM, the very conference in which you are, stands for play through, and we all are here to give you backup. You can call any of our doctors who are under this Indian Society of Sports and Exercise Medicine, because we are all trained doctors who know about what the banned substance, how these doping samplings are conducted. You can always contact any of the doctors of ISSEM, and they'll be ready to help you. And I say it is 24/7. So thank you very much. Few questions. Okay.
Only have Dr. Manish, yes, please.
from where to download the form and where it should be sent by email or what the way it should be sent and where? Which form? Therapeutic youth examination. See, all forms you can, there is something called as a download section in World Anti-Doping Agency. Even in our NADA also we have a download section where you can download a sample dope control form, therapeutic use exemption form, retroactive active form also. All forms are available. You can just download one and even if you cannot download the form, what you can do is write the name of the athlete, name of the doctor, diagnosis, what competition you are in, when you are given everything. Even that can be uploaded and you can send it to the National Anti-Doping Agency. Email, yeah, email, WhatsApp, even WhatsApp also is fine. 21 days of that. No. See, there are two things. Okay. One is the routine TV form. Other one is retroactive TV form. Normal TV form is, see, 1 month before the competition, you are giving salbutamol to your team. Okay. Is salbutamol allowed or not allowed? Salbutamol is allowed. It has got a range. About 10 nanograms per deciliter, there is a cutoff range. If you are giving him 100 nanograms per deciliter, then you will be sanctioned. Terbutaline. Maximum problem is terbutaline. Maximum athletes non-specified. You know, you go to the any medical shop in India, you don't need ask him give me a cough syrup and he give you a cough syrup which contains terbutaline. Athlete just takes it. Next day he is checked and you come positive for that. Okay, so be careful. And now we have, you know, like know your drug. Know your drug. Download that. Know your drug. Okay. There is another. Know your drug. Then you just have to write what drug you are taking. Immediately, green means you are able, red means not taken. Okay. So if it is already giving an acting that it is bad, then you have to inform. You have 3 weeks time before that, because for your TV, the committee has to be set up and they have to give you the whether you have to take or not. And you set up all in emergency after that given the dress. See, emergency you can always go ahead, but you should be in a position to write to the TV committee that why you have given, what was the emergency, what are your investigations, what is the dosage, what is the type of route of administration, everything has to be mentioned. Along with investigation. And you can be different in all that two types of. No, sir, no. Same form, you itself, you can write, see, you can write in a hand, it is emergency TV, retroactive TV, in competition. RTV, we call it. RTV. Thank you.
Thank you very much, sir. Now we'll conclude the session. And before going to the, we will show you a short video. And after that, play the video.
हाँ
Okay, check.
T-shirt.
I thought
Picture is
here
आ रहे हैं अब इधर पे, क्या करें, इधर भी तो चल रहा है, कोई तंगी नहीं है जान, कोई तंगी नहीं खा रहे। हाँ ठीक है।
Yeah, black. District was in monitor.
चल बे
अब तो ये कैमरा
you have your PPT in PowerPoint. Actually, they have just the session was over by how much? 155.
अच्छा अच्छा अच्छा
इसीलिए सब खाना खा रहे हैं.
कोई नहीं
But we will continue.
कोई नहीं.
Because actually आपको भी जाना है ना. नहीं कॉपी करना है क्या? नहीं डायरेक्ट है. स्कैन को वीडियो नहीं है.
The Ayurvedic department will the medical and medical education. So I will call upon Professor Gordon sir. Sir, thank you very much for being invited, sir. And sir will be talking about concept of exercise. Sir will be talking about the concept of exercise physiology and fitness. What is in the ancient or ancient tradition of Ayurveda. Thank you very much. And for the sharing the session, I will call upon Dr. Nabda, is an assistant professor, Department of Sports Science and Yoga from Howrah, Dharma Academy. Thank you, sir.
So yeah, thank you for giving me this opportunity. Well, Ayurveda is one of the ancient systems of healthcare that was documented in India, like ancient India, and it has some very important, valuable observations that have been documented. Plus, there is some physiology, right? So it is very interesting to know how did they come to know about these physiological aspects and what observations did they document and how precise they are and what are the lacunae in the their recording or documentation, what are the lacunae. So this is how I'm going to describe the topic. Because Ayurveda is ancient science and historicity has to be kept in mind whenever we look at Ayurvedic physiology, because in around 2000 years ago these concepts were documented, and these documented concepts have undergone a lot of changes through modern science, and the ancient concepts, some of them have become obsolete. And this we have to recognize. And without recognizing it, if we say that everything documented in those ancient textbooks is it stands true even today, it will be kind of dishonesty. So I'll be trying to be honest as possible in my presentation. So Charaka Samhita, Sushruta Samhita, Bhela Samhita, these are some of the very ancient textbooks that we have even today, of course, not in their entirety and not in the form that were originally composed. They have undergone so many editions and multiple corrections and so on. And most believe that the documentation took place somewhere between 2nd century BC and 4th century AD. These textbooks are written in Sanskrit language and deal with many aspects of health and diseases, including anatomy, physiology, pathology, diagnosis, dietetics, lifestyle, prevention, and therapeutics. And again, these specifically document specialized branches of medicine that were prevalent in those days, like clinical medicine, surgery, eye and ENT, pediatrics, toxicology, geriatrics, sexual medicine, etc. These were the branches that were in being practiced by those physicians in those days. So the physiology of Ayurveda is based on Tridosha, a theory called Tridosha, right? Vata, Pitta, and Kapha. Many of you might have heard of this, and it is the common connecting link, right, between different domains that Ayurveda deals with. It uses this theory to explain biology, physiology, then even to understand the personality of an individual, to understand pathology, to understand diagnostics, even to plan therapeutics. Everywhere this common theory is used, and it is similar to ancient Greek medicine, where they too had bile, phlegm, and black bile, blood, and all that. And similarly, we have got Vata, Pitta, and Kapha. Vata is similar to wind, right? Pitta is similar to bile, and Kapha is similar to phlegm of ancient Greek medicine. And this theory was even prevalent in some other ancient traditional systems of medicine also. Even in Chinese medicine, similar theory exists, right? So it was basically developed using some commonsensical observations. For example, if I asked you, name 3 essentials without which you cannot survive, and most of you would say that so it is air, food, and water, right? So based on this essentials of life principles, the similar life principles were also assumed to be working inside the body. Just like outside the body, we have air, food, and water. Food is ultimately sun, right? Because ultimately all living beings, including plants, they derive their energy from sun. So that way they indicated wind, sun, and water. So these are the 3 essentials which they found or recorded to be very important outside the world. That is, and similarly, the 3 things were inferred within the body also. They were termed Vata, Pitta, and Kapha, right? Vata for wind, Pitta for sun, and Kapha for water. So Vata, just as wind, controlled all activities like movements. Pitta, just as sun and fire, generated heat, imparted color. Kapha, just as water, provided nourishment and acted as coolant. So this is how they formed the conjecture of this physiology, right? Biologically identified viable entities inside the body are like respiratory gases in digestive tract, Pitta for acidic gastric secretions, bile, pancreatic juice, and all. Right, mucous secretions, they can be visualized as watery secretions. So these are the visible things, and a possible observational basis could have been like inhalation and exhalation are nothing but the movement of air in and out, right? Similarly, act of vomiting produces burning sensation because of acidity. So these, all the 3, Vata, Pitta, and Kapha, were ascribed with certain qualities or attributes. Like Vata, like it is cold, dry, rough, light, minute, mobile. Pitta, moist, penetrating, hot, light, foul smelling, sour, flowing, and so on. So Kapha, dense, slow, cold, viscous. So these are the 3 opposite entities, like opposite qualities for 3 doshas were ascribed, and depending on the consumption of similar properties would lead to similar manifestations in the body. This was their hypothesis. So if you consumed more and more cold substances, it would lead to increase in Vata, because it is also cold. Similarly, if you consume more and more hot and pungent things, it would increase Pitta. So this is how the theory was conjectured, right? So Ayurveda has documented several observations very precisely, but the mechanisms that they assumed were conjectural because they did not have tools to identify these mechanisms, right? So inductive logic was used, and pattern recognition. This was the tool that they used. I think they kept on observing people, right, over the centuries, and they went on documenting, the patterns. So obviously, when this method is used, then there are chances that some conjectures or some ideas may be erratic. So there could be faults, right? That's why they use this heuristic approach. And we need to understand this whenever we understand the physiology. So Charles Tipton, a professor of University of Arizona, he wrote a very interesting article a few years ago. Sushruta of India, an unrecognized contributor to the history of exercise physiology, where he discussed so much of contributions of Sushruta. And also he discussed several of these physiological descriptions that were discussed in Ayurvedic textbooks. And while he is correct in pointing out that Sushruta has given a very good documentation about exercise physiology, it would be wrong to say that it was only Sushruta. Right? It is similar things are found in even Charaka Samhita, even Ashtanga Hridaya, Ashtanga Sangra. So in almost all textbooks, similar descriptions are found. So I have tried to summarize some of those descriptions which are found in Ayurvedic textbooks. I won't read those Sanskrit verses, but only it is I have narrated only to show that yes, these are from original textbooks. So physical activity, how would they define physical activity? For example, Charaka, physical activity or exercise, physical exercise was defined as physical activity that strengthens and stabilizes the body, increases endurance and enhances physical power, is considered to be exercise. This is the definition of physical exercise given by Charaka Samhita. It should be done in moderation. This is also a caveat which always comes along with prescription of exercise. So benefits of physical exercise: lightness, ability to work, strong digestion, reduction of fat, and well-defined firm musculature result from regular physical exercise. This was documented in Ashtanga Hridaya. Excessive exercise can lead to thirst, emaciation, bleeding disorders, fatigue, malaise, a cough, fever, and vomiting. This was again defined, recorded, documented in Ashtanga Hridaya. Then it was advised that one should perform exercise up to his or her half capacity. This is again a unique concept in Ayurveda. It is suggested that physical exercise should be done in moderation, ideally to half one's capacity, especially during the colder seasons. This is what has been advised. So sweating on the forehead and breathlessness, they indicate that one should stop exercising. These are some interesting concepts that they have recorded. Again, Charaka has recorded the benefits of exercise. Exercise leads to lightness of the body, the ability to perform actions efficiently, stability, endurance to discomfort, reduction of bodily imbalances, and increase in digestive fire. So signs of good physical exercise include the onset of sweating, increased breathlessness, lightness of the limbs, and discomfort in chest region. See, the increased sympathetic activity, or all that manifests as these symptoms of signs. But again, the precise mechanism of or a physiological basis is not known to them. So excessive exercise can cause fatigue, exhaustion, emaciation, thirst, bleeding disorders, severe dizziness, cough, fever, and vomiting. So these are some documented facts that have been recorded in these samhitas. So those who are excessively weakened by excessive sexual indulgence, lifting heavy weight, or long journeys, and those afflicted by anger, grief, fear, and exhaustion, children, elderly, those exposed to strong winds, those who speak out loudly and excessively, and those who are hungry or thirsty should avoid physical exercise. Again, those people who should not be performing exercise have also been enlisted, right, by Charaka. Whoever engages excessively in these and other similar activities perishes quickly, like an elephant being drawn down forcibly by a lion. So these are the metaphors or similes that our textbooks use very frequently. Of course, Sushruta happens to be one of the champions who prescribe exercise as medicine. So we prescribe this regular physical activity, not only once in a while. Regular, nityam, he says, every day one should perform physical activity or exercise. This is what he says. So benefits of exercise include body growth, enhanced beauty, well-defined musculature, a strong digestive fire, lack of laziness, steadiness, lightness, and smooth skin. Exercise increases tolerance to exertion, fatigue, thirst, heat, and cold. It also leads to overall good health. There is nothing better than exercise for reducing obesity. Again, see, in obesity, he has prescribed physical exercise very clearly. There is very clear indication. Similarly, in diabetes, he has prescribed that regular physical exercise is must. And it was modern actually. If you consider the historicity of these textbooks, somewhere around 2nd century BC or before that, and this was actually quite modern to indicate or prescribe physical exercise as a remedy to obesity and some other metabolic disorders. This was really something very, very important that I must want to highlight. So, those who regularly exercise are not easily affected by old age and their muscles become firm. These are all references from our textbooks, especially this is from Sushruta Samhita. Regular exercise makes one good look better even if they lack youth, beauty or qualities. Even incompatible food is digested well if one exercises regularly. Exercise is always beneficial, especially for those who are strong and consume oily food. Exercise is particularly good in cold and spring seasons. However, it should be done every day in all seasons by those who seek self-benefit or health benefit. So exercise should be done to half of one's capacity. And when value from the heart moves into mouth, that is breathlessness, right? It should be understood that the person has reached their half capacity and should stop exercise. So these are certain interesting, observations that are documented. So similarly, caution. One should consider their age, strength, body constitution, place, time, and food intake before exercising. Otherwise, it may lead to diseases. Over-exercising can lead to exhaustion, thirst, loss of taste, vomiting, bleeding disorders, dizziness, and fatigue. Excessive exercise can cause cough, emaciation, fever, asthma, and consumption. Those who are emaciated, recently eaten, engaged in sexual activities, exhausted, or feeling thirst should avoid exercise. So these are some interesting facts that have been documented. So these are observations, and observations are very interesting. Most of them are true. As we have seen, right? Most of them are true. But these are of course immense value. But physiological mechanisms, they always said that by exercising, suffering is decreased, right? It will cause an increase in vata and decrease in kapha. So all mechanisms were expressed or explained through vata, pitta, and kapha, which we should now be replacing by the modern mechanisms that we all know. So if we do this, I think Ayurveda has got many, many more things to contribute, because such many interesting observations are of immense value. So with this, I thank the organizers, and also thank the chairperson for giving me this opportunity. Thank you.
Starting of exercise medicine was done in the two rivers. One is yellow river in the Yangtze River, there is China, and another is Indus Valley. So Indus Valley civilized and the yellow river, they are foundation to exercise, yoga and so what is written in our ancient texts about Ayurveda, everything, about the concept of the physical fitness, importance of exercise, importance of lifestyle, importance of how nutrition and all this very important, and Sir is well known in this field. So who is better than Sir to tell the story? Thank you. So I will call upon Nas is give certificate and open a moment up to Sir. Brother.
Nice. Thank you. Thank you.
Sorry,
कोई बात नहीं सर
Thank you. So we will recognize awards with a chairperson of the company of the session. Dr. Arnav Das, please come. I have a request of the remarks to share.
Thank you very much for your question.
Next, the fourth medicine and sports science. Sports science is filled with performance enhancement, and for the performance enhancement, sports technology, advances in sport technology not only for the rehab, but also for injury prevention and performance enhancement is very important. So engineering field, especially biomedical engineering field, is very much close to sports science and sports medicine. So and hence we have an excellent speaker to talk about the concept on biomedical department of the biomedical engineering, IIT BHU. So detail is not yet. So the great part sorry, we are so Dr. I will request Dr. Dinesh Kumar that please. So we are very much happy that you are consented for this talk, and this talk will be regarding the rehabilitation concept, how application of the sport technology is put. So sir is from the Department of the Biomedical Engineering, IIT BHU. I will be talking about the rehabilitation concept regarding application of technology. Thank you very much. And for the chairmanship, sir, I will request sir to please come for the chairmanship. Please. Yes. Everyone, good afternoon. So I'm Dinesh Kumar. I'm assistant professor at School of Biomedical Engineering. So by training, I'm the electronics engineer, but my research work went into biomedical engineering, and I worked on a lot of stroke-related rehabilitation works. And one of them I like to discuss today is improving balance using operant conditioning paradigm. It is related to stroke rehabilitation, but I'm sure this concept, basically operant conditioning paradigm, is a learning paradigm. So it can be used in sports also to improve performance. So if you talk stroke, there are multiple types of post-stroke effects. So what we are discussing about here is people who are hemiplegic. That means one side of body gets weaker than other side. As a consequence, what happens? Their body weight distribution on both the leg disturbs. So asymmetric body weight distribution generally is a consequence of hemiplegia. And that leads to a lot of increased body weight, unstable balance. And over the time, what they do, they rely more on their non-paralytic leg compared to paralytic because they don't have confidence. Okay, so in the activity of daily life, a lot of activities, let's say we are reached out for something, we shift our body weight into one direction or other direction. And if our both leg is fine, then we distribute weight properly and we don't fall. But in hemiplegic cases, this is problematic because distribution is not even. So they rely more and more on their non-paralytic leg. As a result, what happened? There is something called impaired balance due to learned non-use of paralytic leg.
they had problem because of the paralysis they have caused. But in addition to that, something happened that is learned non-movement because of not using their paralytic leg low on impedance. Okay. So at least we can address this learned non-use of paralytic leg. We need to devise a mechanism that actually encourages them to use their paralytic leg is more and more. Okay, and that's where this operant conditioning based motor learning paradigm, that is what we explore here. So what is operant conditioning theory is basically here we condition one's behavior by modifying the presented stimuli. Some stimuli will present that will condition their behavior to facilitate the learning that we want. But this learning happens through reward and punishment mechanisms. So there are two types of learning basically, classical learning and classical conditioning based learning or operant conditioning based learning. So this is the operant conditioning. So this theory actually proposed by the psychologist Skinner, B.F. Skinner, who actually conducted this experiment in rat. So what this is something called Skinner's box, where he put rat into the box, and then this box was designed to teach rat how to press that lever. Okay, it is not the natural nature of the rat that it pulls the lever, but how do we condition that? So he used two types of reinforcement: positive reinforcement and negative reinforcement. Positive reinforcement was that whenever he press the lever, the food will come. So he will associate that whenever he pulls the lever, food will come. Okay, and negative reinforcement is like he provided electrical shock in his feet. So that electrical shock will be applied to the rat. It will run around. Then eventually it again pulls the lever. That shock will be stopped. Okay. So one is punishment behavior. By punishing, he is making sure that it pulls the lever. And another is reward, like giving food. It is actually giving some reward, and that is affecting the behavior. So this is the kind of operant conditioning way right on the animals, but the same condition applied for the human also. Later on, a lot of rehabilitation approaches, this principle has been used. So in our case, what we did, because we were discussing about the balance, we developed this learning paradigm in basically operant conditioning augmented virtual reality based balance rehabilitation. So I already work in a virtual reality based system design, where I develop different types of exercises that we can perform in virtual reality. So here we took the balance and center of pressure concept for our exercise. So balance generally it can be quantified in terms of trajectories of center of pressure during weight shifting tasks, because we are discussing about the weight shifting problem in the hemisphere pressure. So what happens? The way they move their body during the weight shifting, their center of pressure also moves. By analyzing those data, we can actually understand how much their balance is affected, or is an indicator of balance. In that context, COP excursion task, where they have to move their COP in directed direction, has been widely used for balance training exercise post-stroke. So we have also used the same thing. Here we use Nintendo Wii balance board. That is nothing but a post plate. When you stand on that, it provides person's body center of pressure. Actually, this is the gaming console which is used in Nintendo games, but this is being used as a low-cost post platform for this kind of purpose. Then what we did, we prepared a lot of virtual reality tasks, and let's say why VR object, what is it, and that is the location of virtual object in the virtual environment. Okay, and then one person is standing, you can see here, in two balance board, one balance board for each leg. So we are getting center of pressure for each leg. Okay, because one leg is weaker than other, we want to quantify which leg is contributing how much. So we have two balance. So two COP will create for individual leg. And then what you're seeing here, WL, this one, these are the weight scaling factor, WL and WR. Whereas these are the COPL and COPR is the left leg COPL, right leg COP. So what it is, the object that moves in VR environment is the combination of their left leg and right leg COP, and that too we have the scaling factor WL and WR that we can control to develop the operant condition paradigm. For example, in the table you can see that WL, WR 75% to 25%. What it means, some person comes for the rehabilitation, we see his residual balance. So let's say he puts 75% body weight into his healthy leg and 25% on unhealthy. Okay, so this is its natural distribution that we can change over time. Let's say we change by 5%. So 70% for non-paratic, 30% for paratic. So the movement of this will get affected. It won't be as natural as this initial residual balance. So this is how we try to develop this operant condition. Actually, we did this in multiple stages. So in step 1, we try to find out what is their baseline COP of left leg and right leg. In the second stage, what we do, we find out initial weight distribution. That means we give them some task and ask them to move forward. So anterior, posterior direction, they have to shift their weight. So we don't give them any goal. We ask them just move as much as possible, and the maximum they can do, that becomes their initial weight distribution across both the legs. So that is called WL initial and WR initial. We find out. So from there, through some mathematical calculation, we try to find out what is the weight distribution in their left leg and right leg. Okay. And something here tells OBPH, what you're seeing is that for tasks, when we give them goal directed tasks, so what will be the maximum COP displacement on which they will achieve their goal? So that we wanted to keep some percent more than what they could do in their initial testing. So let's say they were able to move like, let's say 15 centimeters. So we want to keep it at 17 or 18 centimeters as 100% more. So this is the 1 plus delta. Delta can be changed. So with this, we developed a lot of VR-based tasks, 72 VR-based tasks, and then we presented it for 20 minutes, different tasks. You can see, so these are presented in the computer screen. And this object, like here, the person moving with this side, and here the swimmer, that is controlled by the COP of these two boards when they move forward. So this different type of virtual reality environment we prepared, that actually enhances their motivation for the task. Okay, and then as I discussed, our object is controlled by position parameter WL and WR. That is a weight factor for left and right. So conditioning of this left and right weight when visualized based on individual person's capability. So this is not the standard for everyone. Then during the task, we developed 2 types of tasks. So one is normal task where whatever their initial weight shifting capability that we will have, and then every time we will increase the difficulty level if they are able to cross that difficulty. But we will have that distribution, whatever, let's say 75-25. So that will be initial, then 70-30, then 65-35. Like that will change. That is a normal track. In that they will exercise, and in between what we give them is a catch trial. Catch trial, what we give both the legs weight or object movement is same. So when we are keeping same, at that point we can actually assess the training what we are doing, is it having any impact on its relativity. And then for calculation of performance, we measured length of COP trajectory. And also, this is an ankle strategy of weight shifting. So we discourage people to lift their ankle. So they have to be planted and then moves just like an inverse pendulum. And if they score performance like more than 70%, it was adequate performance, will move to the next difficulty level. So this is basically better as a protocol. Initially, we took BBS, World Balance Scale, for their balance. Then baseline measurement, threshold estimation, that's what is discussed, and then VR-based execution we provide. So you can see that we start with the first level of normal trial, whatever the initial weight. Then once they clear this one, we give one catch trial. Then we move to the next level of normal trial, and again catch trial, like that. We go up to 20 minutes. However, how much ever they can do in 20 minutes. Go up to. So this mechanism or this system was tested in 29 post-stroke hemiplegic participants. You can see here participants were post-stroke period were very varied, male, female both, with different age group. We actually tested all of them, and what we found is that the first we calculated the performance scores. Performance score, that means how much their COP trajectory actually they are progress, the improvements. What we found after analysis is that CT first and CT final is basically the initial catch trial, and the final is the at the final stage where they did the final catch trial. So there was improvement in their performance. In first trial, it was around close to 69%, close to 80%, and about 15 points score where people perform out of that 29. In the final catch trial, the group average of performance was increased by 22%, and about 70% of participants had scored more than 80% in final catch trial. So this actually shows that they were able to perform better in catch trial. And remember that in catch trial, the contribution of both the leg is equal, 50-50%, right? Which is not natural to them. So it means that their parietic leg is slowly getting hang of more and more use. And the same trend found out for actually categorized left hand and right hand. There also we found a similar trend that was statistically significant difference also we found here. Then we clearly measured the COP displacement, not in the performance of the virtual reality, but just the center of pressure displacement from the balance board what we found. And there also we see that in final catch trial, we found 21.49% more COP displacement in their parietic leg, which was the area of concern. Same happened for LH and RH group. We divided different group, but results were more or less same. The percentage varied like 21.49 for overall, but here again in the range of 51, no, not much difference. So we saw the uniform improvement. Another point to check that whether our operant condition paradigm works is looking at this graph. So what we are seeing is this is catch trial first, second, third, and fourth. So this is constant improvement in their catch trial performance. Okay. So more and more they got practice, their performance increased throughout the catch trial. So this is basically for the participant who actually reached up to catch trial goal, but not all of them actually reached up to that. So we took a subgroup. Whereas if you see the normal trial, their performance almost remained constant, because that is the conditioning we were doing. So with this, we can see that our paradigm operant conditioning actually helped to improve the COP displacement of parietic leg. So what's the conclusion? That our operant conditioning paradigm encouraged increased usage of the parietic leg in tailored weight distribution, that is, it controls weight distribution without explicitly limiting the non-parietic leg stability. This is important because there is the constant induced movement therapy, which was not employed here. The future work actually we didn't do the longitudinal study, so that we have to do, and also we didn't take the previous score after the study because it was very short period of study, so that we could correlate. Thank you. This was my presentation. Any questions?
Sir, anyone from the back want to ask a question? No? Okay, thank you very much, sir. I'll ask sir to participate the Now I'll request Dr. Jack Frido to come forward and start his lecture. He is the faculty in Biomedical Engineering Department at BHU itself.
Hi, all. So myself, Dr. Jack, I'm 7 years an assistant professor in the School of Biomedical Engineering in IIT BHU. So my work actually mostly concentrate on neuroimaging, like how to actually diagnose the developmental disorder by using structural MRI, functional MRI, and video. However, there is no scope in talking those topics in this conference. So I thought of actually another book, sort of that is emotion detection. So here I try to actually explain actually with a small word how to actually classify the different human emotions by combining this electrodermal activity that is one of the physiological signals and this artificial intelligence technique that is the random walks. So what is actually emotion? So we all know it is a psychological and physiological reactions of human beings for a particular actually stimulus. So it is very important in our day-to-day life, can affect our behavior, can affect our communication, our decision making, interpretation. And if you see over here, that can also lead to some disease conditions like mood disorders, anxiety disorders, neurodevelopmental disorders, and also psychotic disorders. So then see so much in common and in good news, we get really healthy. And is there is a specific application of this emotion detection? So it can be very different application of emotion detection. In healthcare, we can actually diagnose, we can develop receptor, and then we can actually recommend them for actually particular upstream immediately can actually try out this application in self-driving car. You can say we try to both make the playlist to be taken song or in the case of the human return. So the mission statement is an activity that now many to remove people from the disorder and 300 million people affected with depressive disorders, etc. So all these activities, emotion detection can be actually helpful in this sport. So we can actually see over here in the case of certificate or agree or we can see a different activity than the emotion activity cases. So we can see excessive that we can put in and so not be very popular. And we don't feel to complete on those seems like they could get us to lab. And because they feel this is something that can be because so if you can find that the other difference, you can actually impose your from or you can actually give some kind of the to this actually sports prevalence that may be used there as good performance. So we make then make some of the greater than Physiological signal. However, I'm sure that the physiological signal, like eating, eating, reacting, or repeating, there are some work. The most important beginning, so there are certain situations with this. So the context is over this, then let me go to make up a better. Right? Think of going to some some about really cool. So you will keep spending this time. Kita nanti mentor dari yang apa kita istilah aku tak punya lagi masyarakat yang macam so jadi ini juga berkaitan dengan kehidupan dan ketika nanti ada sekali kita start dari bagaimana kita menjalankan kita itu dari yang ada masyarakat dari dunia. So it's EDA signal. There may be actually two kind of actually signals may be there. One is actually and slowly signal and another thing is that no time is being signal. So sonic signal. However, it can actually get actually very good information in the case of actually. So when we are trying to decompose the GDA signal in the sonic and everything, and in order to actually for further actually feature actually extraction. So we can actually we are there kind of actually on the first like the body and we can actually use the picture we can make the So again, you know, create this I like that I just started. Scholarship. Come up with And then they most of the physical after experimenting with these secrets are very classified. So you can explain you but the things are very
Yeah. Do we have any questions? Someone wanted to have any question? Dr. Manish? Okay. No? I'll ask Dr. Sir. So I call Dr. Siddharth Mudal sir, present this lecture on tendinopathies. Everyone is waiting for that only in the long back. And sir, please.
USB tracking
Oh, hello. A very good afternoon. One more mic, please. Need to speak like this. It's no issues. A very good afternoon. I'm Dr. Siddharth. So I'll be speaking on tendinopathies, the current views and updates. I'll make it as quick as possible since it's post lunch. I know everybody's tired. Tendinopathy describes a spectrum of changes that occur in damaged and diseased tendons, leading to pain and reduced function. It is characterized by abnormalities in the microstructures, compositions, and cellularity of a tendon. It remains a challenge to treat. When you start practice, you will realize that you will see a lot of tendinopathies, and it is one of the most challenging structure to disease, or you can say condition to treat, with a lot of documents which shows that there is it's very difficult to achieve 100% success. Now coming to epidemiology, the incidence of lower limb tendinopathy is more than incidence of osteoarthritis, which many people don't realize actually.
while in general population and patients seen in general practice, you will see around 1 to 2% of adults, that is from 18 years to 65 years, you will see lower extremity tendinopathy, definitely almost in 1 to 2% of adults. So it's quite common actually as a tendinopathy as a condition. In this picture, you will see a lot where and all the most common is always the rotator cuff tendinopathy, which you will always see almost 5.5%. That's the most common. Then you will see it in the elbow, your usual tennis elbow, golfer's elbow, your hip gluteal tendinopathy, knee, the patellar tendinopathy, while your Achilles tendon and your peroneal tendons are all tendinopathies, which you will see quite common also. But the maximum you see is mainly in the shoulder, the rotator cuff. And most commonly you see it with those who play badminton usually. Now, risk factors, there are intrinsic and extrinsic. This all we know, we can see it in textbooks always, all the intrinsic factors which are there, while extrinsic, overuse, sudden increase. Medications are also quite a bit. So usually I ask my patients also whether they have taken any medications, some antibiotics, fluoroquinolones or statins is one thing which is very common, which I definitely ask all the time. So coming to pathophysiology, I'll just briefly say type 1 collagen, that is the main content always. And we have our immune cells. These are all in the healthy tendon. And when injury occurs, this gets filled up with type 3 collagen and becomes new vessels develop and inflammation occurs, and that becomes tendinopathy. Now, there are a lot of theories which goes in risk factors which are involved. So one of the major thing is that there is genes which are involved. So we have the COL5A1 gene, TIMP gene, MMP3 gene, TNC gene. These are all genes which those who have that gets tendinopathy is more common. You will also see a lot of cytokine inflammation, dysfunction, immune cell dysfunctions occurring also. Those leads to tendinopathy. And when there is apoptosis, excessive stress, more stromal cell dysfunction occurs, and that leads to chronic tendinopathy. This is in general the pathophysiology. Added environmental factors such as smoking, metabolic disease, drugs, those all can cause. Now, we have all studied different theories. Usually as PGs, when we study different theories of tendinopathies. When I studied, and definitely when Dr. Dobson and many of us studied, we all studied the continuum model. That was the most latest model at that time. It was there, the pathophysiology. So we have the mechanical theory, inflammation theory, apoptosis theory, and the last was the continuum model. While the continuum model showed basically an unloaded tendon, when it becomes loaded, it is a normal tendon, and when it becomes excessive loading, it gives something called a reactive tendinopathy, and that forms tendon disrepair, and then finally it becomes degenerative tendinopathy. If you give a proper rehabilitation, it can go back to a normal tendon. This was considered the model at that time, and it was considered to be the perfect model. The problem was that inflammation was never considered in this model, and that was one of the major reasons why this model failed, because inflammation does play a role. So what has happened is that we have come with a 4-point model, which is basically you have the stromal compartment which gets involved, you have the immune compartment, we have the neural compartment, and you have the vascular compartment. All of these 4 compartments, when they get involved, is when tendinopathies occur. And all of these changes which occurs, which you see in those pictures, but these 4 compartments together involved is when injury occurs, and that gets converted into tendinopathies. Now coming to management of tendinopathy, so usually we come to a diagnosis. We consider differential diagnosis. So there's something called ICON 2019, which was a conference in which they came to a consensus on tendinopathy. I'll be coming a little bit into that also. So basically, when a patient comes, you need education, you need acknowledgement, and you need fear mechanisms. What and all is causing the fear of doing the activity. You have to commence load management. That is the most important thing, and you have to give a tailored program. The basic concept is always a tailored program with exercises, and that is what is going to help them back into normal treatment. Now, you reevaluate, and if that is not working, then you use all your adjuncts, extracorporeal shockwave therapy, your laser therapy, your NSAIDs, injections. Those things can go also in parallel according to your treatment. But along with it, always exercise goes in. Reevaluate, differential education, always educate the patient. The main thing is communication. That is the key in treatment. In all the studies which I've gone through, all have said commonly that you need to have communication with the patient. And lastly, only we go for surgical opinions. Now, the ICON 2019 is just about the name tendinopathy. We don't use now tendinitis. That is the main preferred term. Tendon tear refers to macroscopic discontinuity, and imaging is not always necessary. You don't need to image for to tell that this is a tendinopathy. There are 9 core domains. So if you are going to go into tendon research, they have told that how to go for the guiding reporting for the outcomes of clinical trial, patient rating of condition, their participation in life activities, pain on activity or loading, function, psychological factors, physical functional capacity, disability, quality of life, pain over a specified time. And these 2 and 6, if you see, are almost similar. Physical function capacity and participation in life activities. These are all similar. These 9 core domains is very important. If you are going to do any form of research and you want to research on tendinopathies, go with this always. ROM, pain on clinical tests, clinical exam, palpation are not core domains. These are the sort of side domains. These are not considered core domains for any tendon research you're going to do. Coming to treatment, injections, you have most orthopedicians use corticosteroids. Studies have shown that corticosteroids might impair the physiological heal response for local tissue, leading to progression of the disease. So you have to take it with a pinch of salt whenever you're planning corticosteroid. But it is very commonly injected. If you go to any general hospital, orthopedicians, you will see left, right, and center, they injecting corticosteroids. Steroid-induced tendon atrophy is very common, and if it is not injected at the parotendon level, and usually you see them injecting blindly. So you see quite a lot, but steroid is a wonderful drug. Like saying that, but if you are doing it properly under ultrasound guided, definitely it helps. Coming to PRP, PRP unfortunately, while study-wise, there's a lot of conflicted results. Multiple meta-analysis has said no benefit in long term. But in practical usage, if you see, definitely there is some benefit. When I have used it in patients, definitely I see some benefit. But in the long term, according to studies, it's showing that there is no benefit. Now, the problem lies with studies also. The major thing is variabilities in study design, difficult to standardize, the concentration and composition. So if you ask a person how, if you have heard Dr. Sadhbir's talk in the morning, if you ask them how he does his PRP, he will tell in a different way. While you ask another person, they will say they did it in a different manner. The concentration of leukocytes, nobody can standardize it. It's very difficult. So similarly, it is for studies also. So when I do a study, it will be for my base population and my based, blood concentrate. So it's very difficult to say whether what works and what doesn't work. And it's always subjective. Pain is very subjective. So it's very difficult to measure it. If it was objective, then we could have easily come. Coming to cellular therapy, which is one of the latest, you would have heard of a lot of places, stem cells have been injecting progenitor cells, autologous phenocytes which is taken from the bone marrow. Now, this is invasive procedure which many patients do not accept. They don't want to do when we tell we are going to take it from the bone marrow and you explain the procedure, they say that no, nothing doing, I don't want such a procedure. The problem is that it's all positive results seen in animal studies. Nothing is in human studies. So there is very less evidence on it. Human studies are too small for significance. That is the truth, or it is in pilot forms. I went through a lot of studies, but nothing is coming in proper form. So definitely we need more studies to say that this works and this doesn't work. Coming to pharmacologics, there are a lot of studies which are coming in cytokine manipulation because there is an inflammatory component. They are coming into cytokine manipulation, targeting of resolution molecules such as lipoxins, epigenetic modification, that is example of microRNAs being used, modulation of various signal pathways as potential therapeutic avenues. These are all latest studies. They are all in early phase clinical trials. These are these studies have come in due to rheumatological studies, not as sports medicine studies. That is the truth. Because there is something in soft tissue rheumatology where a lot of their patients get tendinopathies. So that's how these studies have come in actually. And they are trying it out on rheumatological patients and seeing whether this works. Now, there's no difference in saying that what doesn't work in rheumatology will work in sports medicine also. So definitely we can apply their studies as well as in ours. So there is a lot of pharmacologicals which is coming up and definitely we have to look forward to it. Another thing which is coming up is gene delivery. Preclinical studies focused on establishing gene delivery systems for the regeneration of tendon by regulating expression of BMP2, BMP4, TGF, beta1, and LAC-Z. These are all genes which are coming up. There are a lot of preclinical studies which are going on. And initially promising results have been shown relating to tendon strength and accelerated healing, but all are animal-based studies. You have to understand most of the studies, which is the most recent, are all animal-based, but in US, FDA-approved studies have been started in human beings. That's why preclinical it is still being done right now. This is something interesting which I thought I will talk about, scaffolds, because as sportsmen and physicians, we don't look into surgical aspects much, but we need to know also that there is another avenue which is being built in, especially if you had seen the earlier speaker was a bioengineer who's talking about sports medicine. So definitely there is a lot of bioengineering coming up, which is coming, and scaffolds is one area which is coming up quite a bit. And these are three-dimensional structures that mimic the structure and function of tendons. Used in tissue engineering to promote the growth of new tissue and the attachment of growth factors. Preliminary studies show that scaffolds can provide an alternative for tendon augmentation with an enormous therapeutic potential. Why I said scaffold? So if you know an athlete, I deal with quite a lot of international athletes. So there's one athlete of mine, Sri Shankar, is a long jumper. So he had surgery recently and he is now doing quite well. So I had a discussion with the Qatari who did the surgery. It was done in Aspeta. So we had a discussion in which he was telling that the latest modeling, he was using scaffold and all. So in him, nothing of such was done, but still he was saying that that is something latest which is going to enforce the tendon quite a lot. So any tendon ruptures, he's using scaffold and he says that he's getting excellent results. So that is something in the future which we have to look into. And when we are going to do rehab, when the patient comes to us for rehab, we should know that scaffolding has been done. So how to go about it. And so as you learn, there is always going to be new and new stuff coming up. So we should know that there is something like this which is coming up, and definitely in the future, this can be a part of the treatment which we should be knowledgeable about. So I'm stopping here. So otherwise people are going to get bored with this area. So takeaways, tendinopathy is a spectrum of changes that occur in damaged and diseased tendons, leading to pain and reduced function. Pathophysiology is still evolving, but it's a combination of involvement of stromal, vascular, neural, and immune compartment. You have to understand that it is the continuum model is long gone. It is now a combination of things, and they've come up with this 4 models, which all the involved compartments together involves, and that's how tendinopathy occurs. And we have to target all 4 for if you want an improvement in treatment. Management, communication is key with a treatment plan which should primarily revolve around exercise. That is the most important thing. It should not be exercise. I've had a lot of patients where doctors have told take rest. Tendinopathy never heals with rest. If it has done, then that's a miracle. But it has never worked well with rest. So always whatever treatment you do, you use extracorporeal shockwave therapy, you use low level laser, you use PRP, you use steroid, whatever it is, exercise should be there. Those are all adjuvants. So that is the most important. Eccentric exercises, as we all know, I'm not going into those areas because that is something which you can easily read in the textbooks. So thank you for listening. Any questions, I will happily answer.
Thank you very much, Mr. Kedar. Now, I have a few questions. If anyone wanted to ask a question, please have a question now. One? Yeah. One question is there.
Class of 15 is weeks for intervention. Are we using plasma therapy?
Plasma therapy, you mean PRPs?
In weeks for intervention?
Yeah, we do use. Definitely, we use PRP injections and all. We use treatments for athletes. We do use. It's quite common actually. Now we use one of the most common things are PRP injections which are being used.
You should have attended Dr. Sathi's lecture.
Yeah. PRP is quite commonly used. Now it's like part of this thing. The only problem with PRP is its expense. I work with the rheumatology clinic also, which sees 200. So they have created their own, and they charge only 2,000 rupees for PRPs because his wife, the rheumatologist's wife, is a blood bank person, so she knew how to do, and so we do it quite cheap over there. In that center alone, I've seen the cheaps. Otherwise, usually it comes to around 15,000 to 20,000 rupees. Definitely. So that is the only drawback of PRP, the price. Otherwise, PRP is quite commonly used. Now for You will ask, you see athletes coming and telling that I want this injection.
10,000 is minimum.
Yeah. Now that is the minimum.
Now I'll ask Dr. Felicitate the speaker. For next symposium on cardiometabolic adaptations and exercise and sports performance, I'll ask Dr. Vibhu Naik sir to please come forward and become the chairperson. You see, he is a pioneer of sports medicine and exercise physiology in India. We all know him. So it is an honor to have him. So, please proceed with your presentation.
His knowledge and wisdom in you. That goes without saying.
So, good afternoon all. I would like to thank the organizers for giving me this opportunity. So my topic is just a small topic, is just 10 minutes. So I'm going to, our symposium is cardiovascular adaptations to exercise. We have a list of speakers. Myself, I will be starting first, and Dr. Sunil will be the second speaker, and Dr. Gagan will be the final speaker, third speaker. So my topic is basically cardiovascular adaptations to exercise. So the learning objectives of this session will be the immediate cardiovascular responses to exercise, the long-term cardiovascular adaptations to regular exercise, the mechanism behind these adaptations, health implications and benefits of exercise. So what happens to the cardiovascular system during exercise? So basically there is an increased oxygen demand by muscles, there is enhanced blood flow requirements, and there is a need for heat dissipations. So because of these things, the cardiovascular system has to compensate and get adapted to different types of exercise. So we have to, before moving on to the cardiac adaptation, so basic thing we have to clarify based on the intensity. There is a low intensity exercise, medium intensity, high intensity exercise, and also there is a dynamic and static exercises are required to perform any sports activity. So what does this dynamic refers to? Dynamic refers to the endurance type activities where it requires regular contractions of larger muscle groups and characterized by relative percentage of maximal aerobic power. So basically, dynamic is isotonic exercise. Whereas the static requires these are type of exercise which have sustained muscle contractions performed to overcome resistance and can be characterized by relative percentage of a maximal voluntary concentration.
So both some of most athletic activities does not involve any component as such, static or dynamic. Most of the activities involve both. They involve both static and dynamic components of exercise. So the combination of static and dynamic components of each sport will result in specific hemodynamic effects that influence the type and degree of exercise-induced cardiac remodeling. So whenever we do exercise, there is something called as EICR, which is called as exercise-induced cardiac remodeling. So as you can see, these are some of the examples. Sorry for the poor quality of picture. These are some of the exercises which shows the static component exercise. These are static component exercise. You can see the cricket, golf. It both involves a static and dynamic components as well, but they are less. The intensity of these exercises are low when compared to boxing, canoeing, which involves a lot of static and both the dynamic exercise types. So the cardiac remodeling will be different in each of these exercises or different types of exercises. So what are the different types of cardiovascular adaptations? You can classify them into basic two types, acute, which are immediate responses, and chronic long-term adaptations. The immediate first thing what we are going to see is immediate adaptations, immediate response. The first thing we will look into is the heart rate component. The heart rate response is basically when you do an acute exercise, the heart rate is going to increase up to 220 minus your age, the maximal heart rate, and it is also regulated by the sympathetic stimulation. So whenever you do exercise, your sympathetic activity is going to be higher, and since sympathetic stimulation is going to be there, heart rate is going to be increased. And then there is a decreased parasympathetic activity. Whenever there is it's and vice versa system, sympathetic and parasympathetic. When sympathetic increases, parasympathetic is going to be decreased. And the stroke volume changes in acute exercises, it is going to be increased by 20 to 50%, and then it is enhanced by stronger heart contractions. There is going to be increased venous return and then increased venous return, and then it is based on the Frank-Starling mechanism, which states that whenever there is an increased cardiac load, it's going to be the force of contraction is going to be increased. The cardiac output can increase from 5 liters to 20 to 40 liters per minute in case of acute exercise, and which is the cardiac output is the main determinant of oxygen delivery. And the blood pressure, the systolic BP increases, whereas the diastolic BP remains stable. And what happens to acute blood flow changes? The working muscles, in the working muscles, there is an increased blood flow of up to 80%. And then in the skin also, there is an increased blood flow because of heat dissipation. And then as we all know, physiologists, the digestive system, it is going to be decreased blood flow. The sympathetic system is going to contract constrict the blood vessels of the digestive system and non-essential organs. There's going to be a decreased blood. So studies, what is this study says? Whenever there is a exercise, what happens to the cardiovascular system is that whenever there is ultra endurance exercise, which consists of 50 kilometers to 160 kilometers, what happened is that there is an attenuated left ventricular and right ventricular ejection fraction. Both left ventricular and right ventricular has become attenuated, and with larger reductions on the right ventricles. The right ventricular ejection fraction was more decreased when compared to the left ventricular ejection fraction. So the biventricular function immediately following an ultra endurance like triathlon, whenever they studied the cardiac remodeling which happened in triathlons, what happens is that there was an attenuated larger reductions of right ventricular ejection fractions, and this phenomenon was called as exercise-induced cardiac fatigue. So the greater in acute cases, there is a greater vulnerability for the right heart, which is likely to be wall thickness because of exercise-induced relative increase in wall stress is substantially larger for the right ventricles. You can see there is more workload on the right ventricles, 125% when compared to the left ventricles, which is just 4% in acute exercises. So what is
there is no actual physiological reason behind this cardiac fatigue, but there are some proposed mechanisms which may be resulting, which are substantiated for the cardiac fatigue. These are decrease in blood volume may attenuate the cardiac preload. Circulating catecholamines may decrease the beta adrenoreceptor sensitivity, and also oxidative stress or cardiomyocyte membrane damage may attenuate the ventricular function. So these are the reason which they say that it is the reason for cardiac. There is no actual reason for the cardiac fatigue. And the next thing is, what are the cardiac adaptations that are going to happen in chronic exercises? Whenever the person is doing an athlete who's engaged in chronic exercise, what is going to happen? There is going to be a decrease in heart rate, which is by 5 to 10 beats, 20 beats per minute. It is because of enhanced parasympathetic tone. That is, vagal discharge is going to be more, thereby the heart rate is going to come down. So whoever is going to do exercise, as we know that the person is going to have bradycardia, which is a normal phenomenon. And then there is these persons are going to have more efficient heart functions. And then what happens to the heart structure is that there is an increased heart size. And here you can see that the left ventricles goes for hypertrophy. In acute cases, there is going to be right ventricular hypertrophy, whereas in chronic exercises, it is going to be resulting in left ventricular hypertrophy. And the contractility of the heart is better. And then there is increase in diastolic volume. What are the structural changes that are going to happen to the blood vessels in case of chronic exercise? There is going to be increased capillary density, neovascularization is going to be there, enhanced vascular elasticity is going to be there, and functional changes, the improved endothelial function is going to be there, blood flow regulation is going to be enhanced, and then the peripheral resistance is going to be decreased in case of the chronic changes, chronic exercises. Blood volume, as you all know, whenever there's going to be a person who is doing chronic exercises, the plasma volume is going to, there is an increased demand, plasma volume is going to be increased by 20%, increase in total blood volume, and enhanced blood flow capacity. Composition, because the basal metabolic rate increases, you can see that the red cell mass increases. As such, it is because of the basal metabolic rate, these red cell mass increases. Higher hemoglobin, since RBCs increase, hemoglobin concentration is also going to be increased, and then improved oxygen carrying capacity is going to be there. So whenever you see or examine a chronic person, an athlete who has done chronic exercises, we have to disregard these conditions: sinus bradycardia, first degree AV block, Mobitz type 1, second degree AV block, ectopic atrial arrhythmia, incomplete right bundle branch block, early repolarization, anterior T wave inversions, especially in populations under 16 years of age and black athletes. So we have to, we don't need to do additional investigations for these persons, because they might be common in these individuals. And then ventricular hypertrophy, in dynamic training, enlargement of all cardiac chambers is going to be observed. The degree of remodeling may overlap with mild forms of cardiomyopathy, which is termed to be referred to as a diagnostic gray zone. So as you can see in this picture, these are the cardiac remodeling which is going to happen in case of systemic static exercises and dynamic component exercises. You can see whenever there is a static component involved, you can see that the left ventricular are going to be remodeled, LVH is going to be there. And whenever there is a dynamic component which is involved in the exercise, both the chambers are going to be enlarged. Both left ventricle and right ventricle are going to be enlarged. And you can see whenever there is the static, both static and dynamic component involved, there is going to be cardiac hypertrophy, which involves both left ventricle and right ventricle. And then this, again, you can see in what type of exercises, which type of cardiac remodeling happens. Spoke with isometric physiology, black ethnicity, male gender, normal systolic blood pressure. You can see there is going to be a left ventricular wall thickening. And the chamber is going to be enlarged, dilated chamber with both with isotonic physiology. And a dilated RV or right ventricular chamber is going to be seen in sports with isotonic physiology, no subjective symptoms, unremarkable family history, and the ECG normal 12 lead ECG. And hypertrabeculations will be seen in sports with isotonic physiology, black ethnicity, no subjective symptoms, and unremarkable family history. So to conclude, and then what are the health improvements for cardiac health improvements? There is going to be a lower resting blood pressure, reduced risk of cardiovascular disease, better heart rate variability, enhanced coronary circulation, improved endothelial function, and better metabolic health, and reduced systemic inflammation. These are the health benefits of chronic exercise. So, and to summarize, acute adaptations provide immediate response to exercise demands. Chronic adaptations improve cardiovascular efficiency, and regular exercise leads to significant health benefits. And you can see that we have discussed about different trainings types are going to produce different types of specific adaptations to the cardiovascular system. Thank you all. If you have any doubts, you can.
Thank you very much, Dr. Ravi. We have a question. We can take a quick one question. Dr. Mani, please.
How much time or duration it takes to get adapted? Different activation, is there any difference between?
Is there any?
Yeah. Adaptation, yeah, adaptation adaptation. First, we get the response, that exercise. First, we started with the response, like increasing the BP, increasing the heart rate, and then we come to the adaptation. But if we start other things, thank you very much, Dr. Ravi. Now I'll ask Dr. Ashwin sir to join us in this presentation.
Now, we'll be seeing about the timing of exercise and what it has to do with this circadian rhythm. Okay, so I'll be covering these basic concepts of circadian rhythm, the exercise performance and how it changes during the time of the day, the molecular mechanisms, the clinical applications, and the optimization strategies. So this we already know, the suprachiasmatic nucleus is the center, master center for controlling the sleep wake cycle, and we have the clock genes, and we also have clocks, peripheral clocks in the skeletal muscle also. So these three are interlinked together. Okay, we have the clock genes like BMAL1, clock, per, and cry genes. Okay, so if you can see here, so we have the central clock, we have a peripheral clock. The central clock is the suprachiasmatic nucleus, and the peripheral clock is in the skeletal muscle. So just like our central nervous system, even our skeletal muscles has a specific clock. Okay, accordingly, which the exercise benefits will vary. Okay, so we know many hormones, temperature, everything has a diurnal rhythm, it has a circadian rhythm. So similarly, we have our skeletal muscle exercise training, which also has a particular rhythm. Here you can see the most important gene is your BMAL1 gene and the PER2 gene. Okay, so it is period 2 gene. So what are the different performance variables we come across? So one mainly in a sports medicine we come across is the VO2 max, The next is the lactate threshold. Okay, so how soon the subject will be able to accumulate lactate, okay, during an exercise. And then the perceived exertion and the availability of different substrates for exercise. Okay, so research shows that the VO2 max can vary by approximately 2 to 10% throughout the day. Normally itself, there is a variation of 2 to 10% throughout the day. So the VO2 max normally itself, because of circadian rhythm, it peaks in the late afternoon around 4 to 6 p.m. And the lactate threshold, if you see, the lowest values are in the early morning around 6 to 7 a.m. And the peak values usually again they are in the late afternoon. Okay, again around 4 to 6 p.m. So there is a difference of around 1 to 1.5 millimoles per liter between the peak values and the lowest values. Okay, so what is perceived exertion? So perceived exertion, suppose we are doing the same workout in the morning, afternoon and evening. So it won't seem the same. The amount of exertion will seem little bit higher in one part of the day. In the other part of the day, it will seem little bit less. So this is known as perceived exertion. And here you can see the rate of perceived exertion when the exercise is done in the morning, it's typically 1 to 2 points higher. Whereas when you see in the afternoon, it has the lowest RP scores. So if you say the best time to do an exercise, it will be in the afternoon 2 to 6 p.m. Okay, but that doesn't mean that doing an exercise in the morning or in the evening does not have any benefits. Definitely it has, but the rate of perceived exertion is less in the afternoon when you do it in the afternoon. Again here, if you see the substrate utilization, availability, when you do your exercise in the morning, it is predominantly your fat utilization, fat oxidation which is happening. Whereas when you go towards your afternoon and in the evening portions, it shifts more towards your carbohydrate metabolism. Okay, and in the evening, again, it is a mixed diet. So it is better to have a high protein intake in the evening so that you feel fuller for longer. It also helps in the replenishing of proteins, okay, muscle building and proteins. Okay, so what happens is, okay, so what is repeated wow effect? Okay, so when you repeat an exercise at the same time of a day, then okay, you have something known as again muscle memory. Okay, so that when the training is consistent at a particular period of time, then it leads to stronger adaptations to exercise. The benefits are more. Okay, so this is because of the neural adaptations changes which are happening. So better to do approximately at the same time, not precisely, but approximately at the same time of the day. And cellular adaptations, if you see, the protein synthesis is highest 4 to 6 hours post exercise. Okay, and better you take any protein shake which you want, you can take it immediately after exercise so that it will help in your muscle building. The secondary peak of your protein synthesis happens during your sleep. Okay, so that's why sleep is very essential for muscle building. And next, so what is the pathway which plays a role? Here it is the mTOR pathway. Okay, so it is the mTOR pathway which is activated during exercise. What are the mitochondrial adaptations which are happening? So of course, during exercise, you have a lot of mitochondria which are increasing. It is producing a lot of ATP. And you can see here, this mitochondrial production, it peaks in the late afternoon. Again, more favorable for exercise in the late afternoon. Okay. And what are the enzymes which are expressed? It is PGC1 alpha expression, AMPK expression, and citrate synthesis activity. I'm not going into the details. I'm just brushing through. Okay. So what are the performance gains when exercise is done during different parts of the day? Okay. So morning training, when you do an exercise in the morning around 6 to 9 a.m., you can see there is an initial slightly lower performance. Okay. And the adaptation curve, it takes a little bit more time for you to adapt to the morning exercise pattern. Okay. And it takes around approximately, as I was asking, around 4 to 6 weeks for optimal adaptation to gain the benefits. Whereas if you go into an afternoon training session or an evening training session, you can see the adaptation curve is still steeper and the initial lower performance is also there in your afternoon training. But again, here also it takes around 4 to 6 weeks. But when you move to the evening training, you see the adaptation rate is moderate. So when you do something in the evening, the adaptation rate is slightly variable. So better period of the day to do an exercise would be around the morning or in the afternoon. because again, exercise in the late part of the evening can affect your sleep quality. It can affect your sleep. Okay. So next, you can even tailor your exercise according to the type, chronotype. What do you mean by chronotype? Or what type of a person you are? Whether you're early morning waker or you're a late night sleeper. Okay. So morning types who get up early in the morning, they are known as morning larks. Those who are awake throughout the night, they are known as evening owls. Okay. And in between, mixed here and there, they are known as intermediate types. So if you see, if you are a morning chronotype, then the best adaptation to exercise happens in the morning, early morning. Whereas if you are in the evening types, you are a night owl, then maybe an afternoon or an evening training session will better suit you. Okay, that's fine. So here consistency is the key. Whatever exercise you do or how much ever you do, but keep doing it out throughout at the same point of time, there will be good adaptation and good muscle recovery will be there. Okay. So what are the clinical applications of this? So how do we use this knowledge of circadian rhythm for training? Okay, so it is better to schedule high intensity sessions in the afternoon where you use more of carbohydrates for as a substrate. Okay, and then endurance training. Okay, when you want endurance, then it is better done in the early part of the day, in the morning sessions. And recovery sessions are usually in the evening. Okay, so you plan accordingly. You will have enhanced benefits for the exercise. Okay. So what are the recovery strategies? How do you plan a recovery strategy according to this thing? So you do a post-exercise nutrition. That is, after an exercise, you want to give proper nutrition. You time it in the evening. That is the time where your muscle recovery takes place. The protein synthesis takes place. Okay. On morning time, the glycogen replenishment is slightly slower. Okay, the glycogen depletion. Usually the muscle glycogen gets used up and it takes longer time for the muscle glycogen to be replenished. Okay, so now to summarize briefly. Okay, so we know regular physical activity, of course, it reduces the disease risk, it has cardiovascular benefits, it improves the overall. But the circadian rhythm also, it influences the exercise physiology. Okay, and any disruption in the circadian rhythm can affect your exercise capacity. Okay, so this is a very important point. So any alteration in the circadian rhythm can affect your exercise capacity. And the timing of the exercise, it depends upon how you utilize your substrate. Predominantly, your body is into fat metabolism or carbohydrate metabolism. You are a morning lark or you are an evening owl. So you can tailor your exercise pattern according to it. Okay, so what does exercise do? Basically, it positively influences the molecular mechanism, the clocks in the peripheral tissues. As I told you, it is the BMAL1 pair and cry genes, clock genes. Okay, so there is a transcriptional and translational feedback loop which is happening. And mainly the AMP kinase. The AMP kinase is the one, the mTOR pathway and the AMP kinase one is the one which is activated during exercise. Okay, so these are all the references. I have intentionally made it short because it's a very vast subject, but I just made this presentation to brief you about the importance of circuit. Thank you.
We can take quick question. Ask any question. Thank you very much, sir, for your time. We proceed with the last session, that is my session. So basically, in this symposium, we wanted to talk about the cardiac exercise, effect of circadian rhythm on sports performance and cardiac health. So basically, I summarize the thing whatever we have talked. Sports medicine branch and that's Patiala. And first of all, I wanted to thank Dr. Varun for organizing this conference and working
Sports physician like Dr. Manish is there, and the young faculties, whoever is present over here, I want to thank you all for the participation. We have talked about various things in these 2 days. Okay, what exercise does to your body. Ravi sir has already talked about the exercise changes and adaptation, and Ravi sir has already talked about the circadian rhythm effect. So I will touch those things in brief. So Manish has asked a very good question on adaptation, acclimatization. So I must tell you, I started that slide only. Like this is my judo team, and I was posted at Sai Shilaru, that is a Rajiv Gandhi High Altitude Training Center. It is 50 kilometers from Shimla. There's a high altitude center, Sai Center, and various teams used to go there. And when I was posted in Sai Patiala as a sports physician, I was used to be posted in the Sai Shilaru for 2 to 3 months. We had various teams. This is our judo team. If you see in the center in black t-shirt, this is the judo coach who is with GSW now, Jeevan Sharma sir. And if you can see, he is more fit than any other athlete in his team. And I'll tell you, when I was posted for the first time with the judo team, 2013, I had nervousness while walking. In the beginning, when I used to walk, I used to have that nervousness. And I never had that till then. At the time, I experienced that. But with we had the training with the leader team. They used to go and create 8 kilometer run in the morning and used to speak for 3 hours. And then we stopped to them. So I used to climb with them. So it takes 2 hours to climb to them and 3 hours for you. It was in the beginning, and 1 hour descent. They used to go 3 to 4 weeks blood pressure stop. I acclimatize to the conditions, as I say. So, you see, environmental physiology is a part of exercise physiology. In exercise physiology, we see the changes in the body. Environment has its own effect when you study the effect of environment on the exercise. That is the environmental physiology. And when we use the concept of exercise on the training, improving the sports performance, that is the sports physiology. This is what we do basically. The sports physiology, what we do, what I am doing in aegis Patna currently. So, whatever the lecture you give, any lecture without this person is incomplete. He is the one and only exercise physiologist who got a Nobel Prize in the physiology in medicine. He is Dr. A.V. Hill. And he visited India in 1944 itself with Dr. S.S. Bhatnagar. He is a pit of our own Dr. S.S. Bhatnagar, who is the father of research laboratories in India, and for following Dr. Bhatnagar, government of India also released a stamp on his name in 1994. Dr. A.V. Hill. Basically, his work was muscle and how temperature in the muscle, temperature changes in the muscle fiber during exercise. So the contraction, that is his work. And the changes in the muscle temperature was 0.003 milliseconds. He measured that with the help of the instrument he devised, that is the thermopile, and that's how he got the Nobel Prize. And till that, he is the one and only exercise physiologist who got the Nobel. So, we have already discussed about cardiovascular adaptation. I'll just repeat very few sentences. You see, aerobic exercise has its own effect on endurance, performance, and increasing the VO2 max or aerobic capacity. Resistance exercise has different effects on the left ventricular volume and its mass. Those are the different effects are there of the exercise. And if you study that in athletes, that is connected part. If you do the echocardiography, we have our echocardiography machine at ISSEM Patna right now, all because of the effort of Dr. D.K. Sir. So I must tell you, we are the first department to get the echocardiography machine in the 50th department in India.
because of the effort of Dr. G.K. Paul sir. And now we can do that. Okay. So you will see the changes of the athlete's heart with the help of the echocardiography machine. Whatever changes occur, that is called the athletic heart. I'm not going into too much detail. It is basically a cardiac remodeling happening due to the exercise. Long-term effect, adaptations. Okay, which lead to enlarged cardiac chamber, enlarged left ventricular mass, and various things are there. Accepting the exercise physiology now. Dr. Guru has done a lot of work in ASSEM Pune and HRD on the athletes, basically the archers and shooters, and we have seen that whatever has a better shooting performance, had better HR, higher HRD. We have seen that. Okay, so HRD is also very important variable can assess in the sports persons. Okay, heart rate variable. That is also a new concept in sports right. I'm not going into the detail, but you already know that testing heart rate is less in the athletes, vagal tone is high in athletes, which are more. As I'm using, it tells about the autonomic dysfunction in the TB is happening. HRV, genetics, all are combined, play the role. You see why an athlete is a successful athlete. Okay, genetic is has a very important role to play. Circadian rhythm and sports performance. That was already talked about. Like in different times, lactate threshold is different. At different times, you see body temperature is different. Basically, what is the basic mechanism why we have a different time? Like sir has already told, in the evening, sports performance is better. But if you see in the evening, fatigue is also more. Both the things are there. Okay, at high altitude, you went to increase the aerobic performance, but it has been seen as due to that if you are at a higher altitude. That's how the concept came, then stay low, train high. These are the things, and sir has already talked about the center of circadian rhythm, suprachiasmatic nuclei, and Zetterberg, the basically the optic tube right here. Sunrise, sun rays are the optic tube. That's how we have the 24-hour cycle, 12-hour sleep. That is the Zetterberg concept. See, I already told like after training has a better performance. Okay. Because of the greater release of calcium and also I'm not going to too much metabolic detail. It has been seen that body core temperature is low in the early morning, lowest, and at the evening maximum. Maybe that was one concept which lead to the better performance in the evening. As I told, then a very important concept of non-functional overtraining. The overtraining syndrome. So if you see your circadian rhythm is disrupted, sleep, very important thing for an athlete. If it is disrupted, can lead to the non-functional overtraining and lead to the development of fatigue and overtraining syndrome. Okay, so it has been seen that if in the various studies it has already been seen and established that if sleep deprivation is there, exercise performance tend to decrease. There are too many papers over here to see sleepless night, glycogen storage used to reduce. Okay, sleep deprivation performance is decreasing. So many things. So what can you do to improve that? To improve or align your circadian rhythm. What are the things? What supplements? So what are the established supplements? Do that. Like carb, protein. You see, carb eating and evening meal with a high protein intake actually increases take to sleep to start. Roll of carb with the highest glycemic in the evening. Simple carbohydrate. Protein drinking, dairy products may lengthen sleep. That we know. Ethanol decreases REM sleep time. Okay, but I won't suggest you all to suggest ethanol to everyone. Caffeine. Taking caffeine actually increases sleep onset delay and disrupted sleep. Very important supplement is melatonin. melatonin is used to be treated in the jet lag and all whenever the sleep disruption is there. Melatonin, it basically increases the sleep quality. Okay, so it has been seen that 5 grams of melatonin in the morning substantially impacted individuals' future physical performance. It increases the performance basically. Okay, and if you take some vitamins and some precursor of melatonin, amino acid like tryptophan, it also has the same effect. So amino acid, tryptophan. There are some vitamins which has a role in conversion of tryptophan to melatonin, like vitamin B12, vitamin B6 has a role there, and then some nutritional supplements. So you see, there is a list of these supplements which has a positive impact on the performance. Orally, pumpkin seed powder, milkshake containing lactalbumin, magnesium oral sulfate. So they are all basically increasing the sleep efficiency, increasing the total sleep time, and decreasing the onset to the sleep. So concept of cardiac rehabilitation is not new, but now we know that what has to be done in cardiac rehabilitation. Okay. So basically, what is cardiac rehabilitation? Why we do? Basically, it has been done. It is a program, increasing exercise, taking the metabolic profile, okay, everything to improve the aerobic capacity, performance, and quality of life in patients of the ischemic attack. Okay, so you see, there is cardiovascular disease causes 30% of the death worldwide. And in Europe, number is more. Okay, in the developed country, it is more, and more than 85% is because of the coronary artery disease. So cardiac rehabilitation is defined basically as a secondary prevention model that reduces mortality and the risk of recurrent events and improve cardiac patient quality of life. So basically, we are using the exercises and other means to improve the quality of life in the patients of cardiac ischemic attacks. Okay, so these are some of the indications I already told you: acute episode, chronic episode, or peripheral artery disease. Some of the less indications. So it is a program including apart from exercise, it includes the educational sessions, educate your patients, nutritional advice, psychological support, and also pharmacotherapy. Pharmacotherapy is also included in the cardiac rehabilitation program. So basically, in the short I'll tell it has 3 phases, starting after the treatment itself, like phase 1, phase 3, phase 2, phase 3. So phase 1 started itself in 48 hours. Phase 2, from 36 hours up to 36 training sessions, phase 2, and long-term goal will be taken in the phase 3 and 4, and then we will assess the quality of life. So this is in very small, I talk about a food physiology lab, whatever you need at your lab and whatever we have. So these are some of the equipments we have: body seismography, seal pad, and body composition analyzer. These are the things we have. And the seal pad we are basically aerobic capacity, VO2 max. That's what we do. So if you see in the seal pad, this is the data, you'll get all those things. Like you will get to know what is the VO2 max of the subject. If it is poor, how to improve exercise, you can suggest. Okay. Seal pad will put body composition analyzer. This is the body composition report. So you get to see the percentage body fat percentage, what is the body fat percentage. Even if the BMI is normal, body percentage can be more and person can be obese. That is the beauty of having a body composition analyzer. So see. So in summary, I wanted to say exercise improves the overall health of a child. So if you wanted to talk about exercise, do exercise. Okay, if you don't do, then talk. Okay, so I must quote this, like physical activity must be considered a lifetime pursuit. and the benefits of sound exercise program are rapidly lost once that program is discontinued. So you see, you took time to build up your muscle, but you stopped it, you will lose it very fast within 15 days. This is our team at AIIMS Patna, including Dr. G.K. Pal sir, our HOD sir, Dr. Ravi is here. This is when done in Savita Medical College in 2022. Dr. Dominic Dawson sir is there. All credit goes to him at that time. This was our team. Joy sir is there. All sir. This is our team now. See, Dr. Peter Buchner is there. Vibhu sir is there. This is our team today. This was my team when I went to Commonwealth Games in 2014 with Indian boxing team. So you see, I am a team player. So thank you very much all for quite listening. You know, the people are less, but I must tell one last line to all that when recently we did that topic on AIIMS Patna, and people were few like that only, and I told that to Jalal sir, physiology from AIIMS Delhi. He's a professor, a senior professor, and a known guy in physiology field. He told, भीड़ कितनी भी कम हो, सुनने वाले उतने ही होते हैं. So don't worry about that. Keep doing good work. Thank you.
वाले ज्यादा है इधर.
Sir.
I thank Dr. Gagan for his talk. Now I invite Dr. Gagan to get his felicitation from
Dr. Ravi.
Dr. Ravi first, please. Get the doctor to do, please.
Escort. It's a big honor. Thank you for everything. Please, one side you have to be there. No, but please, sir, and Mal and this, but yeah, this is right. Thank you very much.
I invite Dr.
Getting out on the timing of the exercise.
Now I invite Dr. Gagan.
Thank you. Thank you, sir. Thank you for your presence, sir. Thank you very much. We are honored, sir.
No, please, you are very great. Good.
Thank you very much.
Like it's
To play one video, that is an online session. So I'll just quickly play it. निकाल दो इसको डाल. It's not.
Pleased to be here. That's what only I can say. And Dr. Sika, please stop giving me that sarcastic smile. Thank you. Again, yes, sir. Thank you. Sir. All of you are doing great. Really.
present at your conference. I appreciate the invitation. And my job today is to speak on the roles of non-surgical sports medicine physicians and athletic trainers in the United States. I am a head team physician at a large university in the United States. I also serve as the first vice president for the American Medical Society for Sports Medicine. So when we look at sports medicine physicians in the United States, I want to take a step back and just explain sort of the medical path in the United States for those that are not familiar. So we attend after high school, after secondary school, we attend 4 years at a university, then another 4 years in medical school, and then we will do a residency in the specialty of our choice that can be anywhere from 3 to 6 years, followed by fellowship for those that choose to do so. I would like to focus on this residency time when it comes to sports medicine. So there's 6 different residencies you can do in the United States and become a sports medicine physician. But there's orthopedic surgery, and then I sort of lump it into all the other 5. So if we go to orthopedic surgery, those folks will do an orthopedic residency, and then they can do a fellowship in sports medicine, which for us typically is arthroscopy of the shoulder, knee, and hip. But you can also do a foot and ankle fellowship and then work with athletes and deal with their foot and ankle issues. But usually that won't be your full-time job. That will just be someone who also sees athletes. When we look at the 5 other specialties, family medicine, internal medicine, pediatrics, physical medicine and rehabilitation, and emergency medicine. In the United States, anyone who does any of those 5 residencies can then do a fellowship in sports medicine and become a sports medicine physician. And so it's interesting because they have different backgrounds. Going back to orthopedic surgery, there's pros and cons, and I think the people in the United States who go into orthopedic surgery find it fun. They like that it's procedure oriented. They get to subspecialize in the musculoskeletal system. They do make more money than non-operative physicians, but there are some potential cons as far as long work hours, high pressure stakes, being a surgeon, and then also just less time with athletes. So in the United States, a lot of the people who spend more time with athletes are those primary care or non-operative sports medicine physicians. In that world, in the non-surgical residencies, each of those 5 has their pros and cons. And so you have your family medicine, internal medicine, pediatrics, which we would call our classic primary care residencies. And obviously there's some differences as far as the exposure to intensive care time and age groups, but they really focus on that primary care medicine. Physical medicine and rehabilitation is a 4-year residency with a lot of exposure to musculoskeletal medicine, but also some medical aspects as well. Learn also about adaptive sports, brain injury. So a lot of that can apply to sports medicine. And then emergency medicine, a lot of them are great at those really acute traumatic injuries, mass event coverage. So any of those can go and do the same fellowship, right? So they all are applying for the same fellowship and get accepted based on, their interview. And then the fellowship's job is to really elevate them. So when we do this, talk about this fellowship in sports medicine, it's actually only a 1-year fellowship, and it is optional, but frequently done for physicians who are taking care of athletes at the professional and collegiate level. So this fellowship that we typically do, obviously there's just elevation of musculoskeletal care, getting better at fracture care, injections, ultrasound, spending time with surgeons to understand how they work. But then there are also components of research, concussion management, medical issues in athletes, training room coverage, sideline coverage, and then a continuity clinic where that physician sort of functions on their own with just some mild supervision on the side. When we look at the numbers and the membership within the 2 major sports medicine societies in the United States for physicians, AOSSM is the Orthopedic Sports Medicine Society and AMSSM is the Non-Surgical Sports Medicine Society. And currently the non-surgical side actually has increased to greater than the orthopedic side. If you can look at this graph right here, the black line is total membership for AMSSM, and over the past 20 years, it's risen from less than 1,000 to, this is a couple of years out of date, to now over 5,000. So very significant growth in that field just in the recent past. Now, when we look at the demographics of who these people are, as far as sports medicine physicians in the United States, AMSSM, our non-surgical society, is about 30% female. The Orthopedic Society of General Orthopedics is 6.5% female. But one thing to look at, maybe parity, gender parity is coming, is that orthopedic residents are 14% female. So it may be down the line that we do see more women in orthopedic sports medicine. Within the non-surgical subspecialty, and we say, okay, there's 5 different residencies you can do. How does that break down? So the majority are still family medicine physicians, but there is some growth in the physical medicine and rehabilitation, pediatric side, as far as what % of members are coming from those residencies. And then internal medicine and emergency medicine give the smallest proportion of members. When we go to the college side, so college team physicians is a great role in the United States. Again, it's what I do. There are a lot of universities. If you look at all divisions, over 1,000 universities that do have to name a team physician, a head team physician. Within those, and specifically Division I, which is our highest level, our most competitive, that's the one you'll usually see on TV. 90% of head team physicians are male, while only 10% are female. But interestingly, amongst the male physicians, it's about half and half who is ortho and non-ortho, whereas for the female physicians, the majority are actually non-surgical. So only 1% of Division I college head team physicians in the United States are female orthopedic surgeons. So it seems like there's some difficulty for them breaking through into that role. Now, switching over to athletic training is really important in the United States, and they serve a role to take care of athletes. Their big society, which is the National Athletic Trainers Association, or NATA, actually has 45,000 members, right? So that's a lot higher than the physician societies, and 79% of those members are board certified. When you look at the setting, so 25% are students, but when you take them out, it's a pretty evenly split between athletic trainers working at the college level, working in secondary schools. So again, that's high school right before you go to university, and then working in the clinic or a hospital. So they can be in lots of different settings, but this emerging settings category, which right now is only 2%, but it's called an emerging setting because it is increasing. There's a lot of different roles for athletic trainers. Especially in this public safety sphere, so fire and police and emergency medical systems, a lot of those groups can hire an athletic trainer to work with their, policemen and women on injuries, on getting them back to work. And it really actually saves the department some money because it can keep their employees active. The military is also a role in the United States that athletic trainers are just starting to break into. There was actually a study looking at athletic trainers in U.S. military settings, and it was found to decrease attrition due to musculoskeletal causes by 25%. And they had 16% lower stress fracture incidence. So that's very significant. And for these athletic trainers, it gives them the ability to have more standard work hours. Obviously, from sports coverage, a lot of those athletic trainers have early mornings, late nights. Whereas when you work in some of these roles, you can have more of a typical work day. And some of those do get better salaries in these roles, but it just sort of depends on how far along you are in your training and what the offer is. And I put less conflict with a question mark. Some of us know in sports medicine, it can be challenging to work with coaches or administrators if there's some pushback as far as why an athlete isn't playing. And I think in those emerging settings, there's maybe a little less pushback, but still, I'm sure they still want the police and fire folks to get back as fast as they can. Secondary school, so again, this is that high school setting in the United States. It's interesting because it's split about a third of schools that do not have an athletic trainer. So about a third do not have any athletic trainers in their school. So it's not guaranteed to have one. About a third have a part-time athletic trainer and a third have a full-time athletic trainer. So in the United States, it's not that every high school or secondary school does have an athletic trainer present. There's a little bit of a difference there. And unfortunately, a lot of that does go by socioeconomic status. So this study shows that those schools that have the upper third median household income are likely to have a higher AT availability, higher hours per week that they are designated to that school. The athletic training education in the United States, historically was an undergraduate 4-year degree, and then they would take a certification exam. But in 2013, their association decided to switch to a graduate level degree. So now it's 4 years undergrad plus a 2-year master's. And some of the thought that it's been explained to me for that change from undergraduate to a master's degree was try to get back on par with some of the physical therapists, occupational therapists, speech and language pathology, hopefully for pay parity, but also just to have that respect of being a professional and having a postgraduate degree. Still to be determined if that will make a difference or not, but we have now switched over to all athletic trainers needing a master's degree in the United States. So salary wise, I know sometimes this can be a little controversial. I just took the average salary from a website in the US and then put it in a Google form that switched it over to the Indian rupee equivalent. So in the United States, athletic trainers still make a significant amount less than even physical therapists, physician assistants, and then primary care, sports medicine physicians, and orthopedic sports medicine surgeons do make more, but you can see that the orthopedic surgeons make, twice as much as the primary care sports medicine physicians. So what I wanted to do is give you a snapshot of what my role is. So I am the head team physician of a university. Its name is Purdue University. If you look at that map of the US, that red state is Indiana. And that's the state that I'm located in. Our football stadium there in the upper left is called Ross-Ade Stadium. We have a capacity of over 60,000 people that can go to our football games. The football training center was a $65 million training center built a few years ago in that lower picture, but that's for football only. So we still have a whole nother set of facilities for all of our other sports. We have soccer, basketball, volleyball. That person in the lower left is David Budai, who's an Olympic diver who used to dive for our school and now coaches for us. So my university specifically is 18 sports. There are some that have as high as 30 or 30 plus sports at their university. We have 16 athletic trainers, 3 of which are dual credential athletic trainer and physical therapists. And our American football team has 5 athletic trainers designated just to them. So there's over 100 athletes. It's a sport that does tend to get a lot of injuries. And so there's 5 athletic trainers there. Track and field has 2 athletic trainers assigned to it because it's a larger team. The men's and women's teams are combined. And then some of our other sports tend to have a 1-to-1 ratio for 1 athletic trainer for 1 sport. Athletic trainers in the United States do have the ability to get credentialed in dry needling, phlebotomy, suturing, and making orthotics. And not all of them do all of that, but they can sort of get some extra skills there. We also, as part of our team, don't just have athletic trainers, but we do have mental health clinicians. My university has 2 full-time psychologists and a part-time psychiatrist who works in conjunction with the team physicians for mental health care. And then occasionally we will use outside resources if someone needs a residential eating disorder admission or significant substance abuse. Dietitians also contribute significantly at our university. So we have 5 full-time dietitians just for our student athletes. They each are assigned to multiple teams and they help so much. So individual counseling with the athletes, in addition to team meal planning, we do have an athletics only dining hall that they help run. Fueling stations are like the snacks that are on the weight rooms, and then help athletes with hydration, especially the outdoor sports that can deal with heat. Now, our strength and conditioning professionals, we have 15 of those for our 18 teams. Again, football has 5 dedicated just to them. And then other strength and conditioning coaches may have 1 or multiple sports. And they help athletes in the weight room with performance and return to play. So you can see how big our sports medicine team truly is just at this one university that I work at. From a physician standpoint, so we have 2 full-time non-operative physicians. So I am the head team physician, I'm PM&R, and I oversee policies and all medical care and also see athletes in the training room. And then our second team physician is trained in internal medicine and pediatrics. He's the primary point of contact for football, but then also helps with other sports. And then we have multiple part-time physicians from varying backgrounds who might cover 1 sport or come by once a week to help in training room or help out if myself or the other full-time physician are out of town. And then we get to our orthopedic surgeons. So we have 3 orthopedic surgeons who come to our campus. So one is an upper extremity surgeon, then a knee surgeon, and a foot and ankle surgeon. Sometimes they come to football games, they do weekly training room. And then we have other specialists like spine or hip that they don't come to campus, but they have made themselves available to us where we can get someone in quickly to be seen if needed. And so when you look at what the schedule is, you know, there's essentially sports medicine, non-upper sports medicine available every day during the week and on call on the weekends for these athletes. And then again, our orthopedic surgeons might come once a week and run a training room just to see the injuries that are specifically referred to them. And the coverage for physicians can vary a little bit. Sometimes physicians are just assigned to a specific sport and they only take care of that sport. Sometimes they split up coverage and just any athlete can see any physician. And then a lot of colleges now will have a hybrid model where physicians are assigned to sports, but patients can also be triaged based on area of expertise. So for example, I take care of all the eating disorders at my university. So if there's an athlete that I don't cover their sport, but they have an eating disorder, I'm usually going to be involved in their care. Whereas other physicians might be more specialized in PRP or ultrasound guided injections, and athletes may get referred to them. So not all universities are the same. So again, I'm currently at this Division I, bigger budget, more competitive school with 550 athletes, 16 athletic trainers, 5 dietitians, 8+ physicians, 2 psychologists. My previous role was the head primary care team physician for a Division II school that had 750 athletes and more athletes and only 4 athletic trainers, no staff dietitians, no staff psychologists, and 2 part-time physicians. So really in the United States, it can vary significantly. And I just wanted to give you a little idea of what my setup is like at my university. So I hope that was helpful. I do have references here. And I'm happy to answer any questions that are sent my way through your conference. But I appreciate your time today, and I've really enjoyed giving you a peek into the world of sports medicine in the United States. Thank you so much.
We'll proceed with one more session, online session, and that is by Jeff Young.
Point being 10 repetitions per set for most people. They also suggest that new lifters begin with what's called a familiarization, preparatory, or adaptation phase. The purpose of this video is to describe and give clarity to this common sense phase, so you have a strong understanding of the setup. The design of resistance training programs is broken down into 2 categories. The initial program design, or familiarization phase, and then ongoing, ideally lifelong progression, which should begin with a linear periodization model. The familiarization phase is the learning curve phase, and for those of you who have experienced traditional orthopedic physiotherapy, you'll recognize that this phase closely mirrors what occurs in physiotherapy. From a coach's perspective, and using myself as an example, I always view the initial sessions as having a new body placed in front of me, and I need to take the time to get to know it. So the familiarization phase applies just as much to the coach as it does the exerciser. From your perspective, it's important to begin resistance training within your comfort zone to ensure safety, and then slowly move out of your comfort zone in small, tolerable increments, which is necessary for your body to have a reason to adapt and improve fitness. While there are some differences between this phase for someone who isn't in a rehabilitation setting compared with those who are, the main similarities in general setup of a session include beginning with a frequency of 2 to 3 days per week on non-consecutive days, starting at 10 repetitions per set, and 2 to 3 sets per major muscle group such as legs, back, chest, and shoulders. The intensity of each set begins at a 5 on a 1 to 10 rate of perceived effort or RPE scale, which I'll explain in more detail later in this video. A big difference between this phase for general fitness versus what occurs in rehab are that sessions are set up as total body sessions, so that each major muscle group in the body is being trained, which adheres to governing body guidelines. To give a little more clarity to this general setup, it's important to begin on the low end of frequency, sets per muscle group, intensity, and even the variety of exercises to create that initial level of safety. I call it placing yourself in a safe box, which you'll then begin to progress out of. The primary purposes of this phase are to determine your available pain-free range of motion. You determine this by assessing and modifying exercises based on any joint pain you may have, tight areas that may be causing movement restrictions or mobility issues, and apprehensions. The purpose is to find the pain-free range of motion you can work within so that you can feel safe knowing you won't get injured and then progress from there. Related to tight areas as mentioned above, this is why it's important to view and perform the joint range of motion self-assessment video so you can objectively determine where these areas are, and then engage in a stretching program to improve range of motion in those areas. This will remove restrictions or tight areas, improve your movement, reduce or negate pain, and reduce the risk of injury or re-injury. Other purposes of the familiarization phase include determining your appropriate exercises. This is partially based on your training environment, such as a home exercise program versus a gym, and the equipment you have access to. It's also partially based on what was previously mentioned, any musculoskeletal conditions you may have, mobility limitations, your abilities, and any possible apprehensions. This phase is also used to learn the names of exercises in proper form. Use rate of perceived effort scales to determine the weights you'll start with and also to guide progression. For those who have a fitness trainer or coach, this is where a lot of verbal, visual, and tactile cues occur to help establish mind-muscle connections. Lastly, an important purpose for this phase is to help the individual trust in resistance training as a mode of exercise, learning by experience that lifting weights won't hurt them or cause excessive soreness, which in turn will help them gain trust in the overall program, seeing that it's designed to be graded in volume and intensity and catered to them. In the previous section, I mentioned starting at a rate of perceived effort of about 5 on a 1 to 10 scale, and then use these RPE scales to determine the initial weights you'll use and to guide progression. In this section, I'll give more clarity. The subjective intensity of a set, which is the effort you put into a set, is arguably the most important variable in resistance training because it determines how your body will respond and adapt, and determines if the load was heavy enough to elicit an adaptation, such as an increase in strength. The purpose of this picture is to show that the effort lies on a continuum and is associated with the fatigue you're feeling. Lower effort leads to less fatigue and a lower perception of what the number is on the effort scale. Higher effort leads to more fatigue and a higher perception of what the number is on the effort scale. With that in mind, this picture shows that a resistance training set falls into one of two categories. The set was either a warm-up or it was a true working set. And even though this is a subjective scale, we need to differentiate between the two as objectively as we can. As you can see, the 1 to 6 RPE range is considered warm-up intensity. RIR stands for repetitions in reserve, or how many repetitions you think you could have completed before reaching muscle failure. In the warm-up intensity domain, it isn't possible to accurately predict how many repetitions you had left. The best you can do is give a wild guess and hope that you're close. But in the true working set domain, the end of the set is starting to feel hard or very hard, and it does become possible to accurately predict how many repetitions you could perform before reaching muscle failure, because you can literally feel that you're getting very close to your max effort. A sincere look of strain begins to show on your face. The speed of the lifting part of the movement is now slowing, and you can feel the fatigue building internally and manifesting itself externally. As it relates to this familiarization phase, and referring back to the original table, you want sets to start off feeling like warm-up sets, somewhere around moderate in intensity. And then as you progress through this phase, at your own pace, you move from about a 5 RPE to a 6, and eventually a 7. So how do you know when it's time to end this phase? When you feel comfortable with proper form with each exercise in your program, when the intensity of each set moved from the initial starting point of a moderate intensity warm-up to the bottom end of a true working set spectrum, and when the number of sets you're performing for each major muscle group in each session, legs, back, chest, and shoulders, has reached 3, it's time to end this phase and begin ongoing structured progression. I'll finish this video by giving an example of what each week would look like in a month-long familiarization phase. This is also what I would suggest most people use as a template, but based on your experience, abilities, and discretion. The variables that won't change during the entire familiarization phase are that you'll always perform 10 repetitions per set for each muscle group. The only exception would be core training exercises such as crunches or torso rotation strengthening, where you may perform more than 10 repetitions. The other variables that won't change are that you'll always make sure to strengthen each major muscle group in your body because you want to create total body strength balance to reduce the risk of injury. But you may want to consider beginning the first week with a frequency of 2 training days per week on non-consecutive days, performing 2 sets per muscle group, and choosing loads where you would describe the last repetition of each set as feeling like you put moderate effort into the set. Each set felt like a moderate warm-up. This means that there was little to no look of strain on your face, the speed of the movement of each repetition didn't slow, and when the set was finished, there was little to no huffing and puffing. You recovered pretty quickly. This is what each workout would look like, and the purpose is to ensure that there's very little to no soreness, since soreness is not a marker of a quality workout. No joint pain, and that you feel confident as you begin to learn your body, proper form, and the flow of a session. Again, this phase is known as the preparatory phase because you're preparing your body and your mind for when you enter ongoing progression. In this example I'm presenting, week 2 will look similar to week 1. 2 training sessions during the week on non-consecutive days, both of which will look the same. 10 repetitions per set for each exercise. 2 sets for each major muscle group, sticking with the same exercises so you can continue to work on proper form and overall confidence, and total body training sessions. While you may decide to stick with an RPE of 5 during week 2, since an RPE of 6 is still within the warm-up domain, most people would be able to progress to that intensity. This means that you would slightly increase the weight you're using for each set and choose loads that cause the last repetition of each set to feel moderately hard. You may start to get a slight look of strain on your face at the end of the set, but the speed of movement of each repetition would still be about the same, and if there is any huffing and puffing following the end of each set, it would be minimal. Recovery will still occur pretty quickly. These attributes are how you know you chose a weight for each exercise that was about a 6 RPE. Moving on to week 3 in this month-long phase, by now you may want to consider increasing your frequency to 3 training sessions per week, still on non-consecutive days. 10 repetitions per set as usual, total body sessions as usual. Intensity would likely remain at a 6 RPE for many people, since frequency has just increased, which means total weekly volume, or total number of sets you're performing, has also increased. This way you're only progressing in one major variable at a time as your mind and body continue to adapt. Despite the increase in frequency and total number of weekly sets, since the intensity is still in the warm-up domain, soreness should be minimal. Before I move on to the last week in this month-long phase, please keep in mind that choosing accurate weights for each exercise takes experience, so in the beginning it will take some troubleshooting. This would even be the case if I were training every person viewing this video. It would still take a little time for me to figure out which weights lead to the prescribed rate of perceived effort. So don't worry if you don't guess correctly right away. At the end of each set, ask yourself how the last repetition felt on a scale of 1 to 10, as though I were standing right there asking you the same question. If your goal was for it to feel like a 6, or moderately hard at the last repetition, and it only felt light to moderate, it just means you guessed wrong and you can increase the load on the next set. If your goal was for the exercise to feel like a 6 RPE at the last repetition, but you had a sincere look of strain on your face, the speed of movement definitely started slowing, and you could feel your heart rate up and some huffing and puffing immediately following the set. It just means you guessed a little on the heavy side, and you make the adjustment on the next set by lightening the load a little. You'll probably have to adjust weights from set to set for each exercise because of accumulating fatigue, but this will more likely be the case when all of your sets become true working sets. The last week of this example month-long familiarization phase will progress in one variable. The weights you're choosing for each exercise will increase again, so that the end of each set feels like a 7 on a 1 to 10 perceived effort scale. You have officially graduated to true working sets. There was definitely a sincere look of strain on your face at the end of each set. You could feel the speed of movement slowing at the end of each set as well, both internally and externally. In other words, there was a visual slowing of the movement along with the beginning of some challenging effort. And you were definitely huffing and puffing, at least to some level, as soon as the set was completed. This is how each of the training sessions during this week should look. And if the soreness remained minimal, there was no joint pain or discomfort, you felt comfortable with maintaining proper form, and you feel mentally ready to leave this phase, it's time to enter the world of linear periodization described in that instructional video. There will be some people who feel like they can either bypass this phase completely because of experience, or that they don't need to spend a month in this phase, and that's totally fine. You can go at your own pace and at your own discretion. But I would suggest that most people, and especially everyone new to progressive resistance training, spend at least some time in this initial program design. That wraps up this instructional video on the initial familiarization phase. As you can see, the intent was to provide a general overview.
I think one more is there, the last one.
Krishna.
ये सब ऑनलाइन चल रहा था सर,
रिकॉर्डिंग जा रही है पूरे annual
सब ऑनलाइन।
मतलब अपना भी यहाँ से ट्रांसमिट हो रहा है।
हाँ हाँ, ऑनलाइन सेशन।
अच्छा, कहाँ से जा रहा है प्रोसेसिंग?
ये अपना खुला हुआ है ना सर।
अरे सर, तो सुनते हैं यार।
You want to sign up? Done. हाँ डन। ये किसका पेन ड्राइव है? हाँ वरुण। ओ बंद कर देते, बंद कर होगा। ठीक है, माइक पर के देना बंद कर। मेरा पेन ड्राइव दे दिया था क्या?